Good morning, everyone. If people could find a seat,
Oh, really?
and if you are going to be the first testifier, which is Dr. Anne Marie Sullivan, the seat you want to find is at the front table. Thank you. We'll let everybody else get themselves settled in. Okay. Morning. Okay. Excellent. Good morning. We'll just let everybody get a chance to get into some seat. Okay. Right. Well, good. Everybody figured that out very quickly. Good. Thank you. All right. So we do some basic opening rules of the road for these hearings. I'm Liz Kruger, the chair of the Finance Committee, and we alternate between Gary Pretlow, the chair of Ways and Means in the Assembly, and some days the hearings are run by the Senate, some days by the Assembly. So Gary had yesterday's hearing, so today he gets a little bit of a break, and I will be running this hearing. We all pretty much do it together. Everybody who's here, who's sitting on this side of the room, is a legislator, and they are going to have opportunities to ask questions at different times during the day. But we have a very important thing here, these clocks. And if you are sitting up here, you see clocks in front of you. And if you're sitting in the testifier's table, you also see clocks. And clocks determine whether you have more time to talk or ask questions or not. So just for people to figure out where those clocks are, because they are going to be dictating what you get to do at any given moment. So those people who are the first panels, I think we have five government representatives today, and it's the mental health hearing, by the way, mental hygiene. So government representatives have 10 minutes to present their testimony. They might have 40 pages of materials to give us, and everyone who's testifying and everyone who's not even testifying but wants to submit testimony has been able to do so, and your testimony is up on the Senate website and the Assembly website. So all 20 million New Yorkers can choose to read your testimony, but you'll only have 10 minutes to present. So you should just think through what you think are the highlights you want to make sure we all know, and use your 10 minutes for the highlights. When we get to the part in the hearing of the non-government invitees, you only get 3 minutes. And I know that's impossible, but that's what you're going to do. You're going to do 3 minutes for your testimony. Again, everyone can see the full testimony, but you only get 3 minutes to testify. And when legislatures asking questions of the governmental witnesses, the chairs of the relevant committees get 10 minutes to ask questions, and even a 3-minute second round if they like. So the chairs get a decent amount of time to ask governmental, and the rankers get 5 minutes, and all other members of the relevant legislative committees only get 3 minutes and no second rounds. Then once we get through, to be honest, much of the day, and the 5 governmental witnesses have completed their Q&A, we then get to other people who have been invited to testify, and they again get 3 minutes to testify, and all legislators become equal, and we all only get 3 minutes, no matter whether we're a chair or a ranker or just won their election yesterday. Oh, the ones who won their elections yesterday, I don't think will be here quite yet today. No.
They're not certified yet.
They're not certified yet. That's right. They have to get up here and take their oath. And so that's the model of the day as it goes along. And now I also have to read some basic information that is required. So, as I've already said, good morning. I'm Liz Kruger, and this is Gary Pretlow. Today is the fifth of 14 hearings conducted by the joint fiscal committees of the legislature regarding the governor's proposed budget for the state fiscal year 26-27. These hearings are conducted pursuant to the New York State Constitution and legislative law. Today, the Senate Finance Committee and Assembly Ways and Means Committee will hear testimony concerning the governor's proposed budget for the following state agencies: the Office of Mental Health, the Office of People with Developmental Disabilities, the Office of Addiction Services and Supports, the Justice Center for the Protection of People with Special Needs, and the Council on Developmental Disabilities. Following each testimony, there will be some time for questions from the chairs of the Fiscal Committee and other relevant committees. I will now introduce members from the Senate, and Assemblymember Gary Pretlow will introduce members of the Assembly, and then Tom O'Mara is the ranking member of Senate Finance Committee, will introduce members of his conference, and Assemblymember Ra will introduce members of his conference. But we've had a substitution this morning, so instead of Tom O'Mara, we're going to have Senator Oberacker serving as the ranker for Senate Finance for a little while. So I just want to start off by making sure I introduce members who are here. So we have Senator Fernandez, who's our chair, Senator Webb. Right now, I think that's all we have. So let me just double check, Gary, for the Assembly.
Thank you, Senator, and good morning, everyone. Today with us, we have Assemblywoman Simon, who's the chair of Mental Health, Assemblyman Steck, who's our alcoholism chair, and members Burdick, Tapia, Eckes, McMahon, and Assemblyman Otis.
And I forgot Senator Purcell. I'm so sorry. And I'm going to turn it to Senator Oberacker to introduce his members.
Thank you. And I am Senator Oberacker, standing in, of course, or sitting in, I should say, for Senator O'Mara. We are represented by our ranker, Patricia Canzeri Fitzpatrick, Senator Bill Weber, and Senator Rob Rolston.
And Assemblyman Rob will introduce his conference members.
Thank you. We're currently joined by Assemblyman Joe Sempolinski, our ranker on mental health, and Assemblyman Keith Brown, our ranker on alcoholism and substance abuse.
Great. Okay, so today our 5 representatives from state agencies. Again, Dr. Anne Marie Sullivan, Commissioner, New York State Office of Mental Health. Dr. Chinazo Cunningham, Commissioner, New York State Office of Addiction Services and Support. William Baer, Commissioner of New York State Office for People with Willow Baer, excuse me, I'm so sorry. Commissioner of New York State Office of People with Developmental Disabilities. Maria Lisa Murray, Executive Director, Maria Lisi Murray, I need more coffee this morning, I'm so sorry. Executive Director, New York State Justice Center for the Protection of People with Special Needs. After the final question and answer period, there will be an opportunity for members of the public to briefly express their views on the proposed budget under discussion. And with that, I would like to start with Dr. Anne Marie Sullivan, Commissioner of the New York State Office of Mental Health. Good morning, Commissioner.
Turn your mic on, please.
Oh, that's the other important rule for everyone. The green ring, it has to become green versus red for it to be on. And there's a sweet spot. You have to push that push button just in the right place. Okay.
Thank you. Good morning, Chairs Kruger, Pretlow, Brooke, Simon, and members of the respective committees. I want to thank you for the invitation to address Governor Hochul's fiscal year 2027 executive budget as it relates to mental health. Since taking office, Governor Hochul, in partnership with the legislature, has made tremendous investments towards building a comprehensive mental health system focused on ensuring robust prevention, increasing access to community-based treatment, and addressing the needs of the most vulnerable New Yorkers. Since 2022, over 1,000 inpatient beds have been brought online for those individuals with the highest needs, but there has been a significant expansion of the certified community behavioral health clinics, which are already serving over 158,000 individuals each year. There are 50 critical time intervention teams, a vital component of improved hospital discharge planning, and an expansion of Healthy Steps with the goal of serving more than 300,000 children and families in pediatric and primary care practices across the state by 2028. And for 2025, Mental Health America rated New York as #1 of all states in mental health, using 17 cross-cutting measures. These are just a few examples of the significant progress made in our mental health system under Governor Hochul's leadership. Given the federal government's attacks on New York healthcare and social service systems, they are more important than ever. I want to thank you also for your ongoing efforts to stand up for the New Yorkers in need. One of the most successful initiatives has been the launch of the Safe Options Support Program in 2022, a team-based approach focused on providing assistance to individuals who have been chronically unsheltered. SOS teams utilize an innovative manner of engagement, linking with specialized inpatient treatment when needed, and providing continued support, and has resulted in over 1,600 individuals who have attained permanent housing to date, many of whom previously lived for years and sometimes decades unsheltered. Safe and affordable housing is critical. Since taking office, Governor Hochul has invested more than $520 million in operating funds and $1.1 billion in capital funding to strengthen residential services for individuals with mental illness, including the addition of 3,500 housing units. Fiscal year 2027 budget includes $65 million to increase rates for OMH residential programs to ensure that providers have sufficient resources to maintain housing capacity, including stipends for scattered site supportive housing units and funding to increase rates for single-room occupancy units. By March 31st, there will be 51,000 operational beds in New York for individuals with mental illness and another 6,500 in the pipeline. And for the 5th consecutive year, the governor has proposed funding for OMH mental health providers with a 1.7 targeted inflationary increase to address rising operational costs, enabling them to offer more competitive wages to their staff, as well as an increase in the statutory minimum wage increase. This follows other successful workforce initiatives, such as the Loan Repayment Program, which has made awards to over 1,400 people in the behavioral health workforce. Workforce recruitment and retention continues to be a priority issue. Additionally, the proposed budget includes critical workforce supports for first responders. OMH will work with OASAS to establish a First Responder Behavioral Health Center of Excellence. This builds on Governor Hochul's commitment and previous investment in CARES Up, an initiative that focuses on improving the mental health and wellness of uniformed personnel and veterans by providing a framework to assist community organizations to enhance the wellness and health models. In response to many of the impacts of federal actions taken this year, Governor Hochul is supporting regulatory reform, directing the continued examination of regulations to reduce provider burden. To further improve integrated treatment, we will be working with OASIS on the development of a single joint license for providers who deliver both mental health and addiction services. OMH has been working collaboratively with OASIS on integrated behavioral health services through our continued efforts to build and strengthen the crisis continuum, the expansion of CCBHCs, and new CCBHC regulations. From the beginning of her tenure, Governor Hochul has made the health and welfare of children and youth one of her main priorities. The commitment to children and families has resulted in the development of Youth ACT teams, assertive community treatment teams, expansion of home-based crisis intervention, new resources for suicide prevention for high-risk youth, and partial hospitalization children's service rates. This year's proposed budget includes protections for high-need population programs to educate and increase wellness, and initiatives that will ensure New York continues to be a leader in the mental health treatment of youth. When Governor Hochul conducted youth listening sessions across New York in 2023, we repeatedly heard from young people that they wanted 3 things: services in schools, safe places to gather, and the ability to talk to friends. Youth turn to each other when needing help, and they want to know how to support the mental health of their peers. Building on a existing funding for youth mental health first aid and teen mental health first aid, we have so far certified over 7,400 adults and teens. In this year's proposed budget, an investment of $17.5 million will allow all 10th graders statewide to have the option to take this training, equipping a generation with life-saving skills to identify and respond to mental health challenges. This is an opportunity to reach more than 180,000 students per year and ensures mental health is a regular topic of discussion among our youth, helping to address the stigma that has long persisted in this space. The proposed budget will also add funding for 2 additional youth-safe spaces, a non-clinical safe environment where teens and families can discuss mental health, connecting youth people between the ages of 12 and 24 with mental health resources, positive peer relationships, and meaningful activities will bring the total number of sites to 10 across New York State. We have made progress in school-based mental health services across the state, with nearly 1,300 school-based mental health clinics. Building on this success, we will provide $100,000 for schools of distinction and supporting strong mental health, a designation to be developed recognizing and rewarding schools that have done an outstanding job providing strong mental health supports. A maximum of 10 schools per year will receive this distinction. At this moment in time, when the federal government is attacking many of the people we serve, and at the same time risking the sustainability of mental health providers, Governor Hochul is again taking action to strengthen our service delivery system. Responding to the federal government's sudden discontinuation of the 988 Suicide and Crisis Lifeline's Press 3 option for the LGBTQ+ community in July, which was answering up to 60,000 calls monthly, the proposed budget includes $1.8 million to support this population. OMH will work with the National Crisis Support Center to provide young people with access to trained counselors specialized in challenges facing the LGBT+ community. And recognizing that people in need may also still call 988, we will be providing training to hundreds of 988 counselors, as well as establishing the new legal hotline. To improve mental health outcomes and strengthen our cultural support for Indigenous students, New York State will partner with all the tribal nations to support Indigenous students' mental health, utilizing language, storytelling, song, and land-based education to build resilience and healing. Building on the Indigenous Mental Health Wellbeing Pilot Program, the state will expand the use of transitional support workers and peer advocates to all tribal nations, with a government-to-government relationship with the state. The initiative stands up an Indigenous School Mental Health Workforce Center to support SUNY students seeking careers in school-based mental health. Making sure that New York youth receive the very best quality care is a priority. To that end, OMH will publish a 10-year training roadmap to implement evidence-based practices in child mental health statewide to ensure all child-serving clinicians in agency settings are trained in evidence-based practices. OMH recognizes the need to build a strong field of generalist mental health professionals to treat the wide range of the most prevalent mental health conditions for youth, as well as a strong group of clinicians who can treat youth more complex and special needs. Finally, OMH will lead a 3-year suicide prevention action plan to raise awareness of risk factors and help save lives by ensuring vulnerable New Yorkers are recognized before reaching a point of crisis. As suicide rates rise nationally, certain populations face heightened risk due to social isolation, discrimination, and a lack of culturally competent care. By taking a multi-agency approach, we will develop a collaborative approach to suicide prevention, addressing special needs and reaching high-risk populations. Again, thank you for the opportunity to testify on the executive budget, and I'm happy to answer any questions you may have.
Thank you very much. And your first questioner will be Senator Fernandez, our chair of alcoholism, substance abuse.
disorder. Yes.
Senator Brooke, who is our chair of mental health, is on maternity leave. So I think we're asking Senator Fernandez to play double duty.
I'll do my best, Brooke, today. But thank you so much, Commissioner. This is not a bad budget, I'll say that. There's a lot of great intentions here. But just jumping to the joint license, I was very excited to see that, knowing that there is the disparities and holes people fall through when getting services from OMH and services from OASIS. But can you tell me a bit about this license and the anticipated goals and how long before the program is up and running?
This is really the ability to finally do what providers, what you have been asking for and others for years, is to have one single license. A single license means that no wrong door can be operationalized. So it means if you come in, there will be one single way that you are assessed, a single way that you are billed, a single way that you can opt for services. You will not have to have separate assessments. We'll not have to have separate billing standards. All the standards, all the policies have been approved by both OMH and OASS. So in this license, it's truly integrated care. So the clinicians there will be able to provide both mental health and the full range of addiction services right there in the same facility.
All right, well, after years of promoting a no wrong door approach to care, how will the state ensure that this approach does not narrow the door by signaling that only certain providers can and should treat co-occurring disorders?
There's going to be really a three-tiered system so that ultimately what we would love to do is get everyone to that single license, but not everybody's ready for that across the system. So everyone will have, every clinic will have certain baseline standards that they have to meet. Then there's going to be an intermediate place where those clinics that are getting ready to go to the full license will be able to do the maximum integrated care that they can do under their current license, whether it's an OMH license or an addiction license. So we're working very closely. So for example, over the past several years, we have been doing a collaborative with our mental health clinics to get opioid treatment into our mental health clinics. And at this point in time, over 25% of our clinics have the ability to do full opioid treatment in our clinics. That would be expanded to a level 2. So level 2, not the full license, but the capable license will ensure that every clinic ultimately can provide integrated care.
Thank you. Last year, the governor promised 1,000 mental health beds to open up. Right now, we're not at that number. Are there still funds left over from this initiative?
Well, we actually have opened 1,000 beds.
Oh, we did?
Yes, we did. I can break it down briefly. There's about 640, I think, in community that were reopened. Then we added an additional 275 state beds and an additional 83 forensic beds. So the total new beds that have appeared is 1,000. Now, we also recognize that there still may be a need for more beds. Particularly, we're interested in trying to get some beds on the community side that can work with the duly diagnosed OMH and individuals with developmental disabilities. So there is an RFP out to even further increase some new beds, but we do have 1,000 beds that are opened now with some increases. And also, in last year's budget, there was a 100-bed addition to the forensic system, which will also take a number of years to come because that requires construction, and an additional 75 state beds, again, requiring construction.
Are locations known for where these beds are throughout the
Yes,
state?
the 75 will be at Creedmoor, in the city where we have the highest waiting time. It's not too long, but the highest waiting time for our state system. And the 100 forensic beds will be on Wards Island in Kirby Psychiatric Center, a new building.
Thank you for that. Recruitment and retention. In previous years, the executive budget has included a line for recruitment and retention for OMH providers. Can you explain what those funds go towards, and how does this help providers with recruitment and retention efforts?
There have been a number of recruitment and retention efforts. The biggest one has been a loan repayment, which has brought in over 1,400 clinicians, psychiatrists, nurse practitioners, and counselors and social workers into the system where they're paying back, getting the loan repayment, and then work with us for 3 years. In addition, some of those dollars have gone towards very close working with SUNY in terms of getting a pipeline for students to be coming into the system. So we have some internships. We're also doing a labor apprenticeship with the Department of Labor. SUNY and CUNY have had scholarships for individuals from diverse populations that have brought 600 individuals into the behavioral health field. And on the retention side, we have been doing some training because one of the reasons sometimes people stay in our public system is because they learn. So we're doing increasing trainings in the public system so that people stay with us as a learning experience. And then lastly, we are going to have by early next year a very exciting website that will provide listings of job opportunities across the state, as well as explain what jobs in mental health are. So there will be videos explaining what it's like to be a
Great.
counselor, et cetera. And that website, we hope, will really attract people who are young and looking for job opportunities to get some idea of what it's all about, and will also give them paths to licensure, a lot of information. So that website was also funded through those dollars.
Great. Well, I've heard from some providers who offer both mental health and substance use disorder services who have had to pull staff from their OASIS services onto the mental health side to help them qualify for the scholarships and recruitment retention programs. Why are OASIS providers who provide mental health services unable to access these funds?
That the particular group of funds were earmarked for mental health providers. However, OASIS does some loan repayment, as well as there are significant dollars on the DOH side now that cover everybody in the DOH budget that have come through various changes in dollars that have come to DOH for anyone from across the board can apply for loan repayment. So that's been significantly expanded now to include, and it was really started largely to see how it would work, and we found it to be very successful. So the loan repayment systems across the country have been successful and have been expanded.
Okay. We were expanding crisis stabilization centers. Can we know the status and where they're functioning? Any successes in these stabilization centers?
There have been some difficulties in getting the crisis stabilization centers cited, and it's taken longer than we want, to be quite honest. We have a total of 24 possible eventually, a total of 8 that are actually working and operating now. 5 which will be up and operating
How
this
much is the
year.
total we're supposed to have? 12?
24.
24.
So by this year, the end of this year, we will have 13 fully operational. The others are in the process of finding sites, and 2 are actually returned to us for rebid because the providers weren't able to cite them. And I think this is where we try to do extensive education with communities, that these centers are for families, these centers are really to serve the community in crisis, but still sometimes the stigma about mental health services and addiction services gets in our way. So the main problem has been citing. The dollars have been out there, the providers are working, but we're not giving up, and we will eventually get all 24 open. And the ones that are open are doing a great job. And the communities, once they're open, are very, very happy with them.
All right, looking forward to seeing the continuation of them opening. Last 2 minutes, I want to touch upon Daniel's Law. With the historic funding of Phase 1 implementation of Daniel's Law, is there any information you can share about the status of these programs? We know that the executive budget did not commit to continue funding despite that being the recommendation of the Daniel's Law Task Force. Would the office continue to implement these pilots if the final enacted budget included this funding?
Well, the RFP was out for the pilots. We have gotten the responses for the 3 pilots. We're very excited. They will be awarded in mid-February. So we will then start working immediately with the pilots. Also, the Technical Assistance Center, we have staffed up. We have a director, and we just had the first meeting of the advisory board for the Technical Assistance Center, which is a diverse group of individuals who will be helping us design what these programs should look like, but also be an assistance center across the state for any jurisdiction that is interested in doing this work, a health-related response, and things like standard protocols, things of how do you integrate 911 and 988. And that's where the Technical Assistance Center will be available across the state. So we're very excited about it.
All right, I know that's certainly a priority of ours to make sure that the Daniels Law is implemented. And I don't think that there is funding in this budget for it, but trust that we will fight for that. Last 30 seconds, very excited to see what you're doing with our teen mental health and the Indigenous students program. If you could just clarify, this is for Indigenous students within our Native American territories, or?
Yes.
Yes? Okay.
Yes, so these dollars will go to the tribal nations, and we will work with them. It's very important that they design them themselves. These dollars will go to them to work with their students on cultural issues that are very central to each individual nation. So it will include things like after school programs, crafts, etc., also with mental health supports. But we are working very closely with the nations. It really is in their ballpark to decide what they want these dollars to be used for, and it's been a great partnership.
That's great. I'm glad that there is a partnership. And thank you so much.
Thank you. We've been joined by Assembly Members Santa Barbara and Assembly Member Berger. Our first questioner will be Assembly Member Santa Barbara.
And I'll just jump in quickly. We've been joined by Senator Fahey and Senator Borrello. Thank you.
Let me change that. Our first question will be Assemblywoman Simon.
Oh, and Senator Tom O'Mara has also just come in. Thank you.
Thank you. Thank you, Mr. Chair. Thank you, Commissioner. I have 8 pages of questions for you,
Thank you.
which I will attempt to shorten. But I wanted to just thank you for your testimony. I'm very heartened by some of the new initiatives and the expansion of certain programs, particularly around youth mental health. There is some questions I know colleagues have about the teen mental health first aid, but also this designation program that I'd just like a brief explanation of. But the other 2 issues I want to talk about are supported housing and how that's playing out on the ground, and also the Medicaid managed care issue for behavioral health. So, could we start with the first one, which is the teen mental health issues, and it's kind of explaining that because people had some questions, including whether or not our emphasis on young people and mental health should start earlier than teenagers.
Yeah, I think the teen mental health first aid is really focused for that particular age group, which is teenagers, and we're going to be focusing it with sophomores in high school. And it basically will be voluntary for the schools to work with us, but I can say that already a number of schools are asking already. They're very interested, and we had a pilot which served about 7,500 adults and kids in mental health first aid, and it went very well. So basically you train some adults in the school system to be knowledgeable as well. That doesn't have to be teachers. It can be other school personnel, school support personnel. It can be coaches in athletics. It can be anyone. They get trained as well to be available in the school. And then you do trainings with students. Actually, they are teaching students, helping students know how to talk to each other about mental health concerns. You also explain basic mental health issues, things like anxiety, stress, how you can get help for that. But you also help them to do it in a non-judgmental way so they can talk to their friends. And then you give them resources and connections about where they can go if they need to get assistance. So it's a very exciting program because it really helps our youth. And I think, yes, you could probably design it for even younger kids, but this particular is evidence-based, it's been tested, is particularly for high school students. So that's where we're beginning it. And we're going to cover, hopefully, eventually, all the sophomores in high school, which is, I think, should really change the future of the way generations see mental health and their ability to access care and feel okay about accessing care.
Thank you. So let me get to Medicaid managed care, behavioral health carve-out question that a lot of people have been raising for some time. So the question is whether you would be supportive of a carve-out of most mental health or substance use disorder services from the Medicaid managed care program, in part because it appears that we're spending an awful lot of money for managed care services, and we're not seeing much change in the results. For example, the teen suicide rate in the past 10 years has gone up almost 10%. That's during the period of time during Medicaid managed care. What are they doing? How is this helping? Do you have a view on that?
Well, I really can't talk to the issue of the carve-out because it's pending legislation. I think that is not in the executive budget. We are working very closely with managed care companies on a number of issues, but I really can't speak to the carve-out.
Okay. And then the other issue I wanted to mention, and we've talked about it before, of course, is the issue of supported housing. And I know that you're working on that, and just some data I just got from the city shows that the OMH supported housing units are vacant longer than the HRA units or the some of the other units, and I know we have difference between the OMH-funded units and the ESHI units, and there's a concern that the OMH-funded units provide a higher level of care of acuity, but they get much lower rates. And so I wanted to ask you if you were familiar with that data and what can we do to fix that problem, because they're providing substantially the same services, if not more so, and they're getting paid less to do it.
Well, this budget helps with that significantly in terms of providing the $65 million to support what we consider the highest level of care, which is the SROs, SPR SROs, that's the acronym. So we will be spending about 26.7, almost $27 million to support the rates in those facilities, which will help, definitely will help. And also an additional $38 million for the scatter sites, which are the apartments in the city. Rentals in the city are extremely difficult in terms of rates. Even finding them, there's less than a 1% vacancy rate across New York City. So in New York City, they're not really vacant. It's looking for the apartments and trying to find the apartments. And that the $38 million, which is being added to increase the stipends and the ability to pay the rent, should help with being able to find affordable apartments within what's a very, very tight market in New York City.
So one thing that we've just learned, I'm happy to share this data with you, is that it actually takes 175 days to fill a vacant OMH unit, and OASIS units are filled in half that time. And so I'm curious about exploring barriers that might be present, that maybe the agency may not be as familiar with, to see, because that data seems odd to me.
It seems a little odd. I will definitely look at that. I'm not aware of that data, but I'll definitely look into it some women's time
I'll
and
make
get
sure
back to
you
you.
get it.
Yeah, I'm not aware of that. Yes.
Yeah, it's something I just got.
Okay.
And the other thing is, if you could tell us how far, or if there's any reporting on the Daniels Law pilots.
So well, the RFP went out on in December, and they are back now. They're being scored, and basically we will be announcing the awardees within a week or two. In February, and there will be one in a rural area, one in a suburban area, and one in a more larger metropolitan area across the state. We got a lot of applications, which is very exciting, and we think we have some excellent candidates.
Okay. You know, another issue that has come up a couple of times is, well, let me just, I'll do that in my follow-up, but another issue that has come up, of course, in our conversations is Housing First, and I know that the governor has proposed doing 2 Housing First proposals in different parts of the state. What is the timing of that? How will that happen? When will we be able to start looking at doing Housing First in a bigger way in, for example, larger cities?
Yeah, we're currently doing Housing First both upstate and rest of state and in New York City, especially for that unsheltered homeless population. Those, and we already have Housing First, and that's been a critical reason why we've been able to permanently house that 1,600 individuals who have been unsheltered on the streets, both in New York City and the rest of state. Using a Housing First model, those are the individuals who have been often unsheltered for many years and resist going to, don't really want to feel safe going to shelters, other places. With Housing First, you can get those individuals quickly into permanent housing. And that's why we've been successful in housing 1,600 people. So those units for those individuals have been Housing First. And so we're continuing to use Housing First, especially for that group of individuals, because that's what they need in order to get into housing and then stay in housing. And the success rate for that has been over 85% of the individuals who are in that permanent housing have stayed, which is incredible for individuals who have been unsheltered as long as many of those individuals were. So Housing First works. And that right now, that's the housing that we have. We will, in our selection of housing, how we design it across the state, we might be increasing some of those Housing First for other populations that need that immediate access to housing.
Well, it still seems to be a number of people who are unhoused that are in that sort of chronic, serious mental illness and chronically unhoused. In the city, which is obviously more people than anywhere else. And so I'm really encouraged by the data, but also looking very much to see that expand. And perhaps that's a way that you could work more closely with the city itself.
Sure.
Because I'm not always sure the right hand knows what the left hand is doing. And so it becomes confusing for those of us who are trying to help people and also people who are trying to find that housing. So thank you very much.
Thank you.
Excuse me. Thank you very much. I think our first questioner will be, excuse me, our first questioner from the Republicans will be Senator Kenzoni Fitzpatrick, who is the ranker on mental health.
Thank you, Chair. Thank you, Commissioner, for being here. A couple of comments. I know that we mentioned the 1.7 inflationary increase, COLA. I know most of the organizations in the workforce are asking for 2.7% in today's inflationary economy. I think that the 1.7 is not going to be sufficient, but I'm sure you already are aware of that. I'd like to ask a few questions about the teen mental health program. The 17.5 million that you mentioned, is that from your budget? And will OMH staff be providing the training for the 10th graders? Or is it something that the school district is then going to have to provide? So my question is getting at the 17 million that you're coming up with in your budget. Is your staff providing the training, and now the school district will have to come up with funding on its own to implement the program in the course of their school day and their curriculum?
The funding will be for a vendor to do the training. So it's in our budget. We will send out a request for proposal to the vendor. The vendor will do the training. And the training will be voluntary. You know, all the schools are mandated to do mental health curriculum training. So this can serve as that if they want to use that in their system. It can be done after school. It can be done in any way that suits the school. This should not cost the schools anything. It may be a certain amount of time for voluntary individuals working in the school if adults want to get trained.
So
but we'll be working very closely
optional
with the
then
schools.
for a school
Yes.
district to implement the
Yes.
program if they decide not to do it?
Yes.
Okay. Now, you also mentioned that there was, in your written statement, that there's a $100,000 for schools of distinction, up to 10 schools, and that it would be if they establish certain standards of excellence and key benchmarks. So my concern is that we're going to give the schools that are doing well more money, and that money will be diverted then from schools that don't have a great program. But my concern is, what is the benchmark by which you're going to judge success?
We're going to work that out with the schools. We're going to be talking with the schools to plan that out. And it's a small stipend. It's a little bit of an award, about $10,000, but it's helping schools to just become more involved in mental health. But we will be working with the schools and Department of Ed to come up with that criteria.
Okay. Your written statement said that youth safe spaces, that you're going to have funding for 2 additional community sites. And I'm wondering, have you identified where those sites will be? And that your statement says you'll bring it to 10 across the state. So my question is, where are the current 8 and where are the 2 proposed to be added?
The 4 that we have now, I believe one is in Queens, one is in Central New York, one is in Wayne County, and one is, I forgot the 4th one. But then we have 4 that are up. The other 4 were in last year's budget, and we've just gotten back the applications for those, and they are being scored. So I don't know where the next 4 are. And these 2 will also go out as an RFP. But the first 4 that were awarded back a year before are one in New York City, and then the others are rest of state.
Okay, so will your department decide where those other locations
It's based
go?
on an RFP, and we rate the RFPs. So it's open across the state, but we actually rate them on a basis of need, et cetera.
Okay. You mentioned also in your statement that there's going to be critical workforce support in the budget for establishing first responder the CARES Up program. How is that money going to be spent, and what are we doing for our first responders and their mental health support?
The CARES Up, we have been doing for it's now, and I think about over 60 jurisdictions across the state. And CARES Up is a program that works with first responders, also can work with veterans, to really build within the structure of the local police precinct or the local fire department, peers that work with each other on wellness activities or supports when individuals are under stress, suicide prevention, et cetera. So that's CARES Up. This particular pilot is using a piece of that to expand peer-to-peer work. What we have found with Cares Up is how valuable it is for peers to talk to each other. So this is an expansion of that. We'll be doing it with OASAS, and we'll be able to expand it then to other jurisdictions across the state.
I fully support everything that we can do for our first responders, and the suicide rate among first responders is something that's very troubling. And so I appreciate your commitment to that, and I hope that we will continue to see more funding. I only have a few seconds left, so I won't burden you with another question, but thank you for your time.
Thank you.
Thank you, Chairman. And Commissioner, thank you. It's good to see you again. And my first comment I want to make is moving toward the joint licensure with OASAS, I think, is a wonderful thing. I think the more we can do to break down these barriers, especially, I would say, across all of the mental hygiene lines, and include disability in that as best we can, I think is a very positive thing. So I just wanted to positively reinforce that. Much like my counterpart in the Senate, I wanted to talk about the TII, and we sort of do this every year where it's not really what inflation is, so it's effectively a cut. But I wanted to, in light of that, highlight in your testimony, you mentioned that we're going to have statutory minimum wage increases coming up. When we get to 27, we're going to be in a situation where folks in other sectors of the economy are going to get an automatic, true inflationary bump. And I don't have anything against folks that do minimum wage work. My first job was at a Wendy's working the drive-through, and I started at minimum wage. But if I made a mistake doing that, somebody got a bad sandwich. If somebody who is working in your department is, if it's difficult to hire the best because of wage issues, you could have much more serious consequences. So I would say, why is there the difference where certain sectors of the economy are, certainly that's what our statute is, but why isn't the executive matching these automatic, true inflationary minimum wage increases through the budget for the folks that are dealing with extraordinarily vulnerable populations?
I'm not sure about the minimum wage increase do apply to our services as well. I think it's about $7 million.
Right, but what I'm saying is, if you have somebody that is at the minimum wage level getting a true bump, well, that's going to filter up throughout the system, where the people that are above that, you would think they would want to get a true inflationary bump as well. You have one sector of the economy getting a true inflationary bump and other folks getting partial, which is effectively a cut.
Yeah. Well, yeah. So, but there is the 1.7 increase, and the governor, if you add up all the increases that the governor has put in over the years, it's almost 14.8% since she's been governor, and then this 1.7 will be on top of that. So there have been significant increases, but you're right, it's 1.7.
Right. Okay. I would love to get to the 2.7 that the advocates are going for. We went through last year some changes with involuntary commitment through the budget. Do you have any updates on statistics on that, or how many people have been impacted, how that's been working out?
We have very preliminary. The actual law went into effect in August of last year, so we have about 5 months, and also data lags a bit. What we are seeing so far, and this is very preliminary, so I think this might not be what I'll be saying next year, a very small increase in involuntary commitment, less in the range of about 1% perhaps. But again, it's very early, but we are looking at it and we'll be tracking it.
Okay. And I would, as we make these changes, I would love to see, as that data comes out, I certainly understand it's a little hard to produce that data at this exact moment, but going forward, I'd love to see how that has worked out positively or negatively. I represent a very extremely rural portion of the state, and one of the issues we have to deal with, regardless of what area of the budget we're talking about, is access to services. Is there anything particular you're doing, making sure we have mental health professionals available in the more rural parts of the state?
Yeah, well, we're doing now. I realize that sometimes even the telehealth can be an issue in rural
Right.
areas, but we are doing a lot of telehealth in the rural areas. We are also working with, there was the grant for Farmers Helping Farmers, which goes out and really does a grassroots connecting with farmers and helping them to get connected to services. And we also have a mobile app, a mobile process with some of the sheriffs. I think it's in about 15 or 16 jurisdictions in the rural areas where the sheriffs can have an iPad when they go out to answer a call. And that iPad connects back to mental health services at one of the emergency rooms. And they can talk to the clinician, or they can have the individual talk directly with the clinician. And that has significantly decreased movement of individuals. Over 85% of individuals
got
don't
about
need to go to the
20
emergency room.
20 seconds left, so I want to tee up one thing from one of Mr. Palmisano's constituents, Mr. Tobia, who testified last year about having a committee on rural suicide, and we want to see if we can continue those conversations. I know he's been in contact with your
Yes.
office about maybe doing that as opposed statutorily through the administration. But
Yes, he's meeting with us and he's part of our task force. We're definitely working
we
with
want
him.
to keep
He's
that moving
great.
forward. Thank you very much.
He's terrific. He's terrific.
Thank you. Senator Pat Fahey.
Thank you, Chair, and thank you. Good morning, Commissioner. Thank you, as always, for your testimony and for all of your work. I think mental health is an issue that is crossing across every issue we touch, it seems, and really has been difficult, particularly since COVID. So I'm particularly interested in the program that you have launched, the 10th grade program on the first aid in teen mental health program. You said it's not mandatory, but every high school is mandated to do some type of mental health training. So in other words, this is one they could choose from. Can you explain your
Yeah,
comment a few minutes
basically,
ago?
several years ago, there was a law that was passed that mandated a curriculum on mental health throughout the school system. So it's not just high schools, it's throughout the school system. And we have worked with SED on that kind of social emotional learning, et cetera, throughout the system. So every school does have to have a curriculum. This could serve as that, but for many schools, they're doing this in addition to what they are already doing. And it's been very well accepted by the schools that we piloted it with. We actually did it with some schools to make sure that this could be done and that the schools were happy. And we've had lots of schools coming forward and asking for us to provide the service. So we're expecting that a lot of schools are going to be asking for this. But yes, it is voluntary.
It is voluntary. Okay, isn't it something that's done during the day or after school? I'm just
It can
really
be done whenever the school thinks it works for them.
it's
It
flexible.
could be
Okay.
after school, could be during the day, whatever.
Okay, I look forward to hearing more on this because for years we have talked about how we expand services in a more systematic way since we have such extraordinary shortages of psychologists and psychiatrists and more. So the idea that we are training young people in what it appears to be more of a peer-to-peer way in a prevention way sounds terrific, and I really welcome hearing more on this. Along that same vein, I'm dismayed to have read that yet another one of the Trump administration cuts have been to the 988 crisis and suicide line. You've said that we are still maintaining that. Can you talk about what we've seen with that and how much that what has been the reviews on that so far?
Yeah, but basically, as you said, there was a special, when you called the suicide prevention line, not crisis line 988, individuals with LGBTQ plus could press a button and then talk to someone who's particularly skilled at working with them. That was canceled by the administration, which really cut off the ability for almost 60,000 calls, which we have had from New York State focused on that. So in this budget, we will be contracting with a crisis support line. We have to put out an RFP for this, but crisis support line, which will provide the same service, but the state will now pay for it. It will be a separate line. It will not be connected to 988. However, we will also be training 988 counselors. So if someone does call 988, those counselors will be able to work in a special way with individuals who are LGBTQ+. Also, they could refer them off to this other line, which will have some warm line capacities to be able to talk. So we will have both. We will have a specialized line, which the New York State will now have, separate from 988, but we're also doing intensive training for the 988 counselors. This is one of the highest risk groups both for depression,
Yes.
anxiety, suicide, and they really need people who know, are well trained in how to work with them and
Thank
know
you.
their resources.
Thank you for your sensitivity to that and for follow through. You said there's 60,000 on just the LGBTQ line. How many calls are there overall or annually now on the 988 line?
Well, since we
Roughly.
started, it's been over 1,200,000 since the line started, and we're second only to California, which has a much larger population, and we're only slightly lower than them in terms of the number of calls. So we're really pleased that the word has gotten out on 988, and the top reason people are calling is for relationship problems, which is fascinating because it's very important that we get early. Then comes individuals calling in crisis for suicide, etc. But a lot of people calling for just what we want them to call for, crises big or small. So we're very happy with the success of the 988 line.
We advertise it in all of my newsletters, so thank you.
Yes.
I think it's terrific, and want to also commend you on the No Wrong Door for training. Last question: the 10-year roadmap that you've produced on evidence-based practices with child mental health. What do you see? Are the next steps for that, and how do you see us really influencing early child mental health services and practices, particularly in our schools and at younger than the 10th grade?
Yeah, we will be working with our providers to make sure that our providers are well trained across the state in the evidence-based practices for youth. There are a number which include family-based work, individual-based work, cognitive therapy, etc. But many of our providers are trained in this, but some are not. And we want to make sure that every provider, whether they are school-based providers or community providers, get the training. The Office of Mental Health has often done, we've done a lot of training over the years, so we will be emphasizing this in our training division and in something called a Center for Practice Innovations, which we have associated with the New York State Psychiatric Institute, and we'll be focusing particularly on getting some of these trainings out to the schools. So by doing it in a roadmap organized way, I think we can really evaluate over time the increased percentage of evidence-based practices across the child. And those will include evidence-based practices for dual diagnosis, integrated care for OASAS, and for developmental disabilities as well.
Thank you, Commissioner. Really appreciate all you're doing, and I'll give back the rest of my time. Thank you, Chair.
Assemblymember Stick.
Just one question. There is a proposal in the executive budget for $1 million to establish a first responder behavioral health center of excellence to develop peer-led behavioral health programming and support. I saw that as being in the OASIS budget, but it sounds like it's more appropriate for your budget. Do you know anything about that, and why is it in the OASIS budget?
Well, I think it's important for both of us, and I think it's as we work closer and closer together, OASIS and us, it's a major issue with first responders. Substance use is a major issue with first responders as well. So I think it will be in the, technically it had to be in somebody's budget, so it's in the OASIS budget, but we're going to be working hand in glove with OASIS on the mental health as well as the substance use issues.
One of the difficulties is that the mental health budget is a lot more robust than the OASIS budget, and my concern is that it could take away from some of the other things that are in the OASIS budget. So that's my concern. I don't have any other questions.
Okay. Thank you. That's it? Just checking. Thank you. We have Senator Rollison next.
Good morning, Commissioner. How are you? It's good to see you. I had sort of a three-tiered question, starting with the street. And how do you measure the effectiveness, which I think are really good, of the mobile crisis teams that are out interacting with individuals on the street, say, as it relates to traditional response? This obviously has been a priority of the administration, and I'm happy to see what's your thoughts on that as far as
Yeah, we're the mobile crisis teams are they're asked to keep data on basically who they serve, the demographics of who they serve, also on follow up, how they, for example, if you went out on a call, was there a follow up? Was the person connected to services, not connected to services? And we're going to start doing more. We haven't done as much on satisfaction, which we will be doing to just get the answers from individuals. Some of our mobile crisis teams have been doing that, but we haven't been doing that across the board. So the data we have currently is usually on service utilization in the areas, the reasons that they've been called, and whether or not if they needed to be connected to services, they got that connection and they were successful in making that connection.
And you talked about the some of the challenges with the stabilization centers. Let's just say, for argument's sake, there will be counties who are unable to do it for a variety of reasons. Do you have thoughts on what's the next step that the state would be able to start to think about and possibly present as alternatives to those centers that aren't going to get cited? I mean, of course, we have one in Dutchess County. It's a huge success. But what happens when some places it's not going to happen in that county for a variety of reasons?
Well, we continue in high need counties. We continue to work with them, and one of the things we try to do is have them go, for example, to Dutchess County and see what it really means. So we've had some success with that in terms of even just doing videos or connecting them to the providers and talking back and forth. It's dealing with a lot of misunderstanding that has to constantly be discussed. And we're not going to give up, because I do think we don't want to not do it in the counties that really need it. But sometimes it can take a while to get them to understand. And the more we have coming up, I think in other places, the more that will then make them feel more comfortable that putting these things into their area is helpful, not a problem.
And that's my third question with just about 20 seconds left. So you got the street, you have a stabilization center or other locations where individuals go that are in crisis. What is the wait time for state beds? You mentioned that. Was there like you know what that number is?
For most of the rest of state, it's probably about 2 to 3 weeks after you've been accepted.
Okay.
In New York City, it's higher.
Okay. Thanks.
Thanks. Keith Brown? Oh, Santa Barbara? I thought he went already. You didn't go? Okay, perfect. Assembly Member Santa Barbara.
Thank you, Commissioner. Thank you for your testimony. I went through some of the things you described, and you indicate the system is expanding, more beds, more housing, more programs, and more funding. But I want to talk about a situation happening here with the Center for Disability Services, because with this situation, I see something very different happening. Are you familiar with the Center for Disability Services? Mm-hmm. In the Capital Region, they are our service provider, one of the largest disability providers in the region, and they recently announced that they are ending psychiatric services, which is a big problem for a lot of people in this area. This is not a small clinic. They operate in more than 80 locations, 15 counties is what they cover, and serve more than 10,000 individuals every year. I'm sure you've seen the numbers of the people that they serve. Yet even at that scale, they could not keep psychiatry financially stable. At one point, they had just one provider for more than 1,100 patients. And they did not close because people didn't need care. They closed because they just couldn't recruit or retain psychiatrists under the Medicaid reimbursement and regulatory rules. Now, hundreds of people with complex mental health and developmental needs are scrambling to find care in a system that's already full. My son was one of them. I had to actually drive him to Long Island to find a psychiatrist. That 4-hour drive had to be in person. The first meeting had to be in person, the first appointment. Now we're able to do telehealth, so that's a little better. But a lot of people are not going to be able to do that. So people are scrambling to find services. And this is not an isolated problem. It's a warning sign. And my question is, how many community providers like this across New York State have reduced or eliminated these type of services because they could not sustain them financially? I
think in terms of them being in the article, the clinics run by the disabilities, I don't have that data on which ones other than that. We do
But you
know
have
about
heard
this.
about this. You have heard about this.
Yes, oh, we've heard about this one, yes. And we're working very closely with OPWDD to try to help move some of those individuals who need services to our services. I think that what we need to do, and we're in the process of doing this, sadly, it'll probably take a while, is to get our, just like we're trying to integrate care with substance use, we want to do integrated care for developmental disabilities. And we have started a significant training in the Certified Community Behavioral Health Centers. So the Certified Community Behavioral Health Centers, which we have been successful in hiring psychiatrists, our CCBHCs, to have them well-trained so they can see dually diagnosed individuals. That's something which we are growing. We have a number of programs that we are growing jointly, dually diagnosed with OASAS. Telehealth is very important here. We use telehealth for this within our current system, and we're trying to get some clinics that perhaps are not as used to telehealth to really use it. These specialists, super specialists in developmental disabilities and mental health, especially psychiatrists, are in short supply, but you can get them often through a telehealth. So we're trying to work with clinics to begin to use that more robustly in terms of helping to get, because it is hard to hire someone to be in person in those clinics, yes. But we are expanding the training across our system as well, in conjunction with the advice of the OPWDD.
I understand your, but is this situation being addressed now?
Yes,
Because
we're working.
the
Yes, we
gap
are working.
exists
We are
and-
working with OPWDD to look at the individuals and to try to help get
Okay,
them
because
the
it is
services
an
they
urgent
need.
need, and it's not something new. This has happened, and there's a
Yes.
gap now. So I think people are scrambling, and the longer people go without services, the more I think the more problems it's going to cause in our community. I have another question about when a community provider loses psychiatric services, how does OMH track the impact on hospitals, emergency rooms, and other services? Because I think when something like this happens, they can no longer offer services. The pressure doesn't go away. It just gets shifted somewhere else. And what happens is the system is going to get overloaded somewhere. So emergency rooms, hospitals, police departments, families, something is going to get overloaded somewhere else. So it doesn't just go away. And that's what's happening right now. So that's my concern. This is not new. It's been ongoing. It has not been addressed. And I'm hearing from more and more families that cannot find services. So it's happening right now as we speak, and it's going to continue to happen until it's addressed. So I'm asking what can be done immediately right now to help these people.
Well, we work, the clinic system itself is under OPWDD. Let me just explain that. So we work very closely with OPWDD.
Right, but this is psychiatric services.
For psychiatric services, if someone was to come into the emergency room right now and say that they couldn't get services, we have established teams across the state and in Albany where they can call our field office and we can help get them the services that they need. We are also in the process of doing home-based crisis intervention services for dually diagnosed. We're in the process of growing support teams around the emergency rooms and the process of educating and training our CCBHCs. That training has already started in our CCBHCs, Certified Community Behavioral Health Centers that are under OMH, to be able to work with individuals with dual diagnosis. That training has started. So if someone is having those difficulties, they should call our field office and find out where we have the ability to be helpful. Now, it is growing. Right now, it is growing, but we have not stabilized the system entirely. But we are keeping track of it, and we're working with OPWDD.
Now, have you had conversations with Greg Sorrentino at the Center for Disability Services?
We do it through OPWDD. We've been working with Commissioner
My
or
understanding is he's
OPWDD.
working with your office. Are they working with your office as well, or not?
Yes,
Okay.
yes.
All right. So how'd those conversations go?
The conversations with OPWDD, who's working with their
Okay.
clinic system.
Okay. Okay. And what about the reimbursement rates?
There is a proposal to increase some of the reimbursement rates that has not gone through yet, so that when our clinics do this additional service, they would get a higher rate.
Because
But that has not been passed yet.
the reimbursement rates, I mean, from what we hear, what we know is they have not kept pace with the real cost of care. That's what caused this problem. And I think we're seeing the effects of that. Meanwhile, workforce costs have risen. We heard about that from previous testimony. Compliance costs have gone up. Documentation requirements have expanded. These all have factored into this. So even when programs are full, and this is what's happened with this department, they operate at a loss, and that's not going to work. So I suspect this is not the only problem we're going to have in the state. It's going to continue with other services elsewhere. This is really a system design problem, and it needs to be fixed, or we're going to continue to see these problems. And it's driving care out of our community, out of my community. And as I said, I described what I had to do with my son, making a 4-hour drive, and that was an entire day. And a lot of people just can't do that. So we need to find a solution to this, and it needs to happen right away. I wanted to ask about just the time I have left here, the suicide prevention programs. I want to shift gears here. Suicide prevention programs in the schools specifically. If you can expand on that a little bit. And then I just want to ask about our veteran services. We're tracking information on suicide prevention. If you could give us an update on veterans, and I know the Dwyer program is very effective. If you could just give some updates on that, and are you tracking that information?
Yeah, with the Dwyer program, we're definitely working. We're tracking the information with the Dwyer program. We've been working very closely with them on suicide prevention. We've done a number of suicide prevention trainings with them, but also they have, the peer-to-peer networks. The Dwyer program does suicide prevention as well as a lot of other services, but we've been doing some specialized training with them as first responders because that's what veterans, a particular program focused on the transition for veterans who are coming out of the service. That particular year, that transition year when you're leaving the service and coming back to the community is a particular period when there's a higher suicide rate. So we are working very closely with the Dwyer programs, with other veterans organizations to work with those, to put in place programs on suicide prevention, mental health wellness, et cetera, for those individuals leaving service coming into the community. In the schools, we have a whole array of services, of trainings that we provide to the schools. We have something called Suicide Safe Talk. We have some special suicide work which we do with different schools, different ages, et cetera, across the system. I think we do over 10,000, 20,000, over 10,000 trainings, individuals each year when schools request. We also do post-vention trainings. In other words, if there is an event in a school or some loss, we go in and work with the community. So there's a lot of direct suicide prevention work going on in the schools, and any school that wants any of those services or trainings, we're available to provide them.
Okay, and all that information is tracked in the schools as well?
Yes. Oh,
Okay.
yes. We can give you all the data. We can give you the numbers.
Is that by county or by
where-
school district or just?
And we have it by school district. We can show you. We can get it to you which school districts, how many trainings have been done across the state.
All right, great. I'm just about out of time. Thank you.
Yes. Thank you.
Thank you. Senator Webb.
Good morning, Commissioner.
Oh, I'm sorry.
I was having a little technical difficulty. So, first of all, thank you for being here. I just have two questions. One, I want to talk about the governor's proposal with regards to beds. I know last budget we increased funding. So, can you provide us with how many beds are online for forensic inpatient residential or psychiatric centers, trying to get a sense of kind of where we are with beds being online?
Yeah, of the beds that were offline, 640 in the community, 642 beds have been brought back online. And if you add to that the additional beds the governor has funded for mental health, is another 275 beds that have opened in the civil side of our system, and another 83 that have opened on the forensic side. But in last year's budget, there was also an additional 100 that will be opening on Ward's Island on forensic. And that will bring the forensic total up to almost 900 beds total. We have about 2,400 beds on the civil side in the state system. So about 1,000 beds have been opened under Governor Hochul's leadership, combination of state, community, and forensic.
Okay. Is it possible that we can get a review of these beds that have been fully funded, especially in the mental health billion?
Sure. Yeah, we can
Okay.
give you the breakdown by hospital, exactly where they are and which ones have opened.
Perfect. And then my my last question deals with Daniel's Law and most certainly the work of that task force. So the executive budget does not include any additional funding for this particular initiative. Do you think or anticipate that there will be other supports that'll be granted, especially a number of the recommendations that the task force had included in their report?
Well, the work that we're going to be doing, the pilots are being opened. We will be sending out the results of the pilots in mid-February, and then the Technical Assistance Center is already begun to be up and running. So the work of the Technical Assistance Center will spread across the state, and that will be available to jurisdictions that aren't pilots, for example, but need technical assistance. So we're hoping that the Technical Assistance Center can have a bigger impact than just the initial pilots that were there. And so we will see how things go over the course of this year.
I know with the initial pilot, only $6 million was allocated. Do you feel that that is sufficient?
For the 3 pilots, yes. For those 3 pilots, it should be sufficient for those 3 pilots.
Okay, and then the timeline again for those pilots that are being awarded. You said that's going to
They'll
be
be the
when?
awards will be out in mid-February. We expect it usually takes several months to get the pilots up and running. So we're hopeful by the summer the pilots will begin their work.
Okay, thank you.
Thank you, Chair. Good morning, Dr. Sullivan. Nice to see you. I want to thank you first for the provisions in the budget relating to co-occurring disorders. It's been a long time we've been talking about it, so I appreciate that. A couple of questions. What about the dual background checks for clinicians? Are we going to integrate that, make that a single background check?
Yes, yes.
And how long before you anticipate the new integration be set up and running?
If we can get it through, if it passes through the legislature, we then have to put out the regulations. So it takes several months. I would suspect within 4 to 6 months we should be able to have it up. We have the regulations already, so we can put those out. So it should go quickly, but we do have to then put the regulations out.
So,
So it
question,
should
but is it
be.
going to be two
It
sets?
should be by absolutely towards the end of the summer, fall of this year. We should be able to have it.
So silly question, but is it going to be 2 sets of regulations? So
No,
that
it'll be one.
one set of regulations that both agencies are going to adhere to?
Absolutely.
And-
Yep. That's why it'll be similar. That's why it'll be better for the providers.
Great. And could you provide any details about what the reimbursement structure would be for the new dual license? And will it erase the parity that we've seen with the private insurance and government insurance previously identified in the Ghost Providers report 2 years ago?
There will be a simpler billing system under this. So basically, yes, it will combine. The rates will be developed. That will be something that will come out as the regulations come out, exactly what the rates will be under the license. And then it will be uniform. So it won't be a difference between, what you might get paid if you were in an Oasis clinic or a mental health clinic. It'll be one rate.
Great, great. I really appreciate your testimony with the new initiatives to address mental health of our teens. It's so important to give them the coping skills that they need as young adults to deal with their problems. But I would love to see something, with respect to that, for training school personnel to identify children who are in crisis and get the help that they need as soon as possible. Has that been discussed at all?
Yeah, when we do the teen training of teen to teen, the other piece is training school personnel on what we call youth mental health first aid, which is how they can then relate to across the board to all the kids in the high school. So yes, it's a combined training. So we train staff in the schools as well as the teens talking to each other, and the training includes both.
Terrific. So we are seeing in our state increases in problems related to legalization of marijuana as well as sports gambling, online sports gambling, with the significant funds in the past few budgets and the state opioid settlement fund, the money generated from the MRTA, as well as the money generated from online gambling. How is OMH measuring whether or not the significant investments in mental health and addiction services is truly reaching and helping the growing number of New Yorkers that need it?
I think you'll hear from Commissioner Cunningham, I think, about a really impressive package on gambling that she has in the budget this year, and we will be working very closely with them to incorporate what's in that package in terms of educating, following up, getting those kinds of statistics with her. So we're going to be partnering with Oasis on that.
So my concern, though, is that we're tracking the money and making sure that the money is getting to the people who are delivering the services and that we're seeing outcomes for it. So what are we doing in terms of making sure that the money is working?
Oasis will be kind of tracking that pot of money. We
Okay.
don't track that particular pot of money that deals with gambling.
I don't mean just gambling. I mean overall, right? Because we're seeing problems that are in
All
both.
the dollars that we received through the Office of Mental Health, we track very clearly where they are going, and we are also tracking outcomes for each program. So what you will be seeing very soon on our website within the next month are something that we're calling infograms on, for example, if we increased a certain service like an ACT team, how many of those slots are filled, and then outcomes, how many individuals are getting services, how many individuals have been successfully treated and are now back home, that kind of thing. So all those kinds of things we are tracking. We're tracking where the money goes, and we're tracking clinical outcomes on all the initiatives that came into mental health. And we've asked people to do what they call infographics in an easy way, so you could just go on the website and say, oh, you put up this particular team, what have they done? And that will be there. That's just going to be on our website within the next month or so.
And in the 20 some odd seconds I have left, what is your office doing to help address the growing concern we have with the veterans' mental health crisis and suicide prevention, to coordinate more with the federal government and the county agencies?
Yeah, one of the big initiatives has been the Dwyer program, and we're doing a lot of work on suicide prevention with them because there's a Dwyer program in every single county. We're also, the first responder money will also go for veterans as well.
Great, thank you.
Senator Borrello.
Thank you. Commissioner, I'm over here.
Sorry.
I first of all, I would like to talk about Kendra's Law. And just to give you a little background, it's named after Kendra Webdale. I knew Kendra Webdale. We grew up together in the village of Fredonia. I know her family, so I take this very personally. For a long time, former Senator Diane Savino and I worked together to try to strengthen Kendra's Law, and I'm proud to say that in the last year's budget, we were able to get some changes, and they're important changes because it says that people who cannot provide for themselves, medical care, personal safety, food, clothing, and shelter due to their mental illness, should be able to be cared for under Kendra's Law. My concern is this. We are now seeing in New York City that the current mayor is saying that he is not going to do anything about these homeless encampments. These are places where people who suffer from mental illness that meet the qualifications of Kendra's Law are obviously being not cared for, and they're a danger to themselves and others. So this is not just happening in New York City. We have other communities in New York State where these homeless encampments are, which are in direct violation of this, have become an issue. Obviously, violence, drugs, the quality of life, sanitary conditions are horrible. So my question is, what are you going to do to ensure that Kendra's Law is used effectively and that we can actually get these people the help they need? And it is in direct conflict with apparently the policy of the new administration in New York City.
Well, we have, in terms of the state, we have our Save Option support teams that work with the homeless mentally, both in the subways and now are expanding sometimes above ground on the streets. Those teams work specifically with engaging people to get the services that they need. But if someone is
Kendra's Law is
dangerous,
involuntary. It's involuntary.
Yeah, I know. But if the person can't be engaged and needs that, then we would bring those individuals, for example, to an emergency room where they could either get hospitalized or they could be under Kendra's Law. But often you can do the engagement without doing that. When you need to, we will be continuing to do everything we have done. We have over 4,400 Kendra's Law orders each year. And over the past 2 years, those have gone up by 8%. So we are doing more Kendra's Law orders than we were before.
How
and that's
are the
across
outcomes
state.
now after these changes? I know it's early, but how are the outcomes?
The outcomes are good. The outcomes continue to be good. Homelessness is decreased by like 60%, hospitalizations by 70%, threats of violence by over 60%. The outcomes for Kendra's Law continue to be effective.
I'm glad to hear that. How do you rectify the direct conflict with the New York City administration and their policy on this? How are you going to be able to effectively help those people with facing opposition from this new mayor?
We work closely with the city. I don't know what I can do personally but we work very closely with the city, with the Department of Mental Health and Department of Health in the city, and we continue to do that.
Thank you.
Thank you, Assemblyman Ra.
Thank you, Chair. Commissioner, just following up on Senator Borrello's comments and Kendra's Law, can you just detail how those changes are working? Do we have any, data at this point in terms of the implementation and how those changes from last year are working?
The major change last year was one of the changes in the law last year was an additional ability to making clearer how you could, if someone was off Kendra's law, could easily be put back on with over a period of 6 months. That is still beginning to get utilized. So we have not had yet a big uptake on that across the state. I believe it's like about 25 individuals. But Kendra's law overall has been increasing in terms of the number of orders by about 8%. And I think that's because of an awareness on the part of communities and the judges of how effective Kendra's law can be for individuals. So hospitals are using it a bit more, but also your DCSs across the state are using it more. So we have had about an increase of Kendra's orders of about 300 from last year to this year.
Thank you. Can you detail any strategies that are being used by the office to address the shortage of mental health professionals, especially in underserved areas and rural areas of the state?
Yeah, we're working very closely with SUNY and CUNY to get local individuals involved in a whole host of activities. One of them is like a little bit of an internship where individuals can come and get an experience working in a mental health area. We are also in the process of developing a credential for mental health paraprofessionals, which would only require a high school degree and would be an entry level for people to get the experience of working with mental health issues across the state and then go on in their careers. And that's something which we will have effective by early next year. We're also working on loan repayments, and we are especially trying to get some of those loan repayments into the rural areas so people will work there and get loan repayments for working in those areas as well. And we are working very closely with the DCSs in those areas to recruit and retain individuals. So we are trying our best to get more and more individuals, and we're expanding telehealth as much as possible in the rural areas.
Okay. So we have in the proposal $17.5 million for teen mental health first aid. Can you just provide an overview of what that is? And I think one of the things a lot of us have heard from professionals that work with our youth, particularly in the schools, that they just, goes back to the prior question, they have, trouble finding. They get through a immediate concern, but they know that they need to find help for that individual, and they have trouble finding providers to get them in front of.
Yeah, so Teen Mental Health First Aid helps youth understand mental health issues, things like depression, anxiety, stress, also how to talk to each other about those issues, and also what resources are available. So in addition to Teen Mental Health First Aid, we still have our school-based clinic programs, which we offer to any school that wants to work with us, and we are very excited about the number of schools that have joined. So you want to have Teen Mental Health First Aid to provide that education within the schools, but then you also want to connect schools to services. And one of the best ways we can do that is through the school-based clinics, which we have been growing across the state.
Thank you very much, Commissioner.
Senator Weber.
Good morning, Commissioner. How are you? Good to see you. So I have just a couple of questions regarding the Joseph P. Dwyer Veteran Peer-to-Peer Program, a great program that really helps veterans in crisis. The funding has been stagnant, I know, for the last number of years at $8 million. I guess the question I have is, have you assessed and looked at the unmet demands for more money, and how do you really evaluate the success of the program, and is there information that you can supply to us so that we can try to get more funding? Because I think having more money in those programs is vital to our veterans in need.
Yeah, we can get through that information. We've been gathering information from the various sites and getting what they consider the needs they have, and also the outcomes they've been having in terms of working with the veterans. And there wasn't a kind of uniform way of gathering some of that data before, but now we're working with the sites to get it. So I think that will be very helpful with what you're saying in terms of what is still the unmet need and what we need, but we can get that information to you.
Right, and I guess my follow-up question is, with the flat funding, has it constrained staffing and program expansion? I assume it's yes. And what would you like to see improved on that program?
I think what we I think what we need to do is make sure that we are especially working with, and this is why we've instituted something called CARES Up, that transition year with veterans. And some of the Dwyer programs are working with us very closely on that because that's that high risk time when the vets first come back to the community after being in service. And that's a very high risk time for them. So that's something that we'd like to emphasize with all the Dwyer programs, something that we call Ops Forward, that we work on really helping them work with that particular group of veterans. So that's something that we're trying to expand across the Dwyer program.
Great. And my final question is, in terms of the funding, how is the funding distributed to the counties? Is it done equally through the counties? Is it done based on needs or assessments based on information you've gathered back from those agencies?
There was some legacy funding which we weren't really involved in that I'm not sure how that was allocated, but the money that we're allocating now is based on the number of veterans and the needs of veterans. But the legacy funding has complicated it a little bit because certain had more than others. So we're in the process of trying to even out some things, but we are doing it based on need, yes.
Okay. Thank you, Commissioner.
Assemblyman Burdick?
Yes, and thank you, Chair, and thank you, Commissioner, for the great work that your team is doing. And I also want to especially give a shout out to your Legislative Liaison Office. I'm quite pleased with the Governor's proposal for the new First Responder Behavioral Health Center of Excellence, which I understand is supported by $1 million investment. I've been working with first responders who wish to see even more resources for peer-to-peer support, which my colleagues have been talking about a good deal, including grant availability. And in my districts and across the state, there are smaller local agencies which would like to provide that kind of support. I'm wondering if you could explain modifications that have been made in the eligibility under the CARES Up program, and particularly for smaller volunteer first responder agencies, and also whether there's grant availability under the new program, the First Responder Behavioral Health Center, and whether small agencies might be eligible.
Yeah, thank you for that. You know, we, as you're saying, we noted and we got calls from some of the volunteer fire agencies and the volunteer police, services across the state because they weren't in that first round of funding that we did with CARES Up. And so now we've expanded. CARES Up is a program that works with the jurisdiction and works with the agency. So now we've expanded that. So that's very exciting. And I think it's going to be different, a little bit different what we will be doing with the volunteer agencies. I believe that in that new dollars that are coming, they will also be working with the volunteer agencies in the other parts of the state. But that was a need that we had not recognized, which you and others brought to our attention. And now we are funding some of those dollars for those groups, which is really great.
We greatly appreciate that. And so does the new program have a grant element to it, component?
Yeah, it will be. We'll be working with Oasis on this, but we will be putting out. It will be having someone do the training, but then they will be going out and asking for voluntary groups to come forward and say they
would
want
that
the training.
Include smaller agencies?
Yes, we're going to
Great.
make sure it does. Yeah.
Well, very much appreciate it. And again, very much appreciate working with your Legislative Liaison Office. They do a great job.
Thank you for that. Thank you.
Thank you. I think I'm the last senator left. So, Commissioner, we all know that issues of homelessness and mental illness together are probably some of our most difficult to deal with from a government perspective, community safety perspective, and individuals in trouble perspective. We have a new mayor in New York City, and he's announced that he's going to take a new approach to police working with people with mental illness and homelessness, and that he's specifically going to create a new agency to try to ensure that when police are being called in to deal with people known to have mental illness issues, and that seems to disproportionately be people who are on the streets, not always, but a decent number, that he's going to want non-police to be part of the team that goes in. And there have been a number of pilots around the country and even the city of New York. And I'm curious, it seems to me it's going to have to then set up a new system of how the rest of the mental health system works with these people once they are brought into somewhere, not necessarily police headquarters, but likely emergency rooms, at least initially, and then a new protocol of some sort in dealing with application for state services, various organizations who may have state contracts versus city contracts. And so it seems that you have to play a role here. And I'm curious what your understanding is now of what your agency or other state agencies might also need to be doing in response to changes at the local level.
I think, we're going to be working, and I assume this will work out fine with the city on the new plans. It's not clear yet exactly what, I think they are still working out what they are thinking, but we have been in touch with the Office of Department of Health and Mental Health and Dr. Wright, who is our liaison there, and we've been talking definitely with him about these issues. The issue here is, I think, that all the systems have to work together. I mean, I think you can design it in various ways, but I think what they are looking to do, and what we are also looking to do with our pilots, is a health-led response when it's appropriate. When it's appropriate for it to be a health-led mental health response, that it's mental health professionals or peers who go out and work with those individuals. Now, it's also just as critical that whatever that response is integrates well into the rest of the system. And that's where your point is very well taken. And the system is city-based, some of it's our services in the city. It has to all connect. So we're very excited, I think, about working with the mayor's office on making sure not just whatever that response team looks like, which we hope will be a significant health-led response, but how does it interface with the rest of us? And that's something that we'll be working very closely with them on. And if it's going to be successful, that interface is critical. So we're looking forward to it. I think it's still in the very early stages, but we've already had some preliminary discussions about wanting to be involved. And I think that that's what we're going to be pushing for.
I agree with you that that is critical. I mean, even on various programs we've all been working with for a long time, the outreach teams, for example. I represent, I know you know because you live in Manhattan. So I represent the areas of Manhattan that are the most densely populated, probably have the largest number of people on the streets, going through Grand Central, going through Penn Station, searching for places to be that are perhaps most protective for them and most likely to be places where they might be able to find some shelter and food. And so it's just an everyday conversation. And we now have, and they're all well-intentioned, well-designed programs, but we have contracts at the state and the city and health and not health for outreach groups to work with people on the streets. But they're all different contracts. So they all have different computer systems and tracking. And a constant complaint is people saying that the client or the patient spoke to X person from contract 1 on Monday, Y person from contract 2 on Wednesday, and Z person from contract 3 on Friday. So that person thinks that they're working with 3 different groups, none of whom knows the other one is working with the person, and there's no way for anybody to even keep track of what each person is being told or telling them. So I really think that coordination really needs to be at the very street level of who's talking to the people and working with the people, so that I'm not surprised when so-and-so says, no, they were promised X, by this person and this group. So do you think that we can sort of up the ante, so to speak, of how people do work together and coordinate and share information?
I think we're working on it. And let me just say that the safe option support teams we have, most of the individuals a lot, not all, but a lot of the individuals have been referred from those other teams. In other words, they say, I've seen Mr. On the street, and he just isn't responding to what we need. They then come to our team, and our team kind of works as a case management team that follows that person over time and tries as best as possible to keep in connection with the referring teams and the other teams. So the teams are coming together to say who can best serve this particular individual. Do they need like what we provide, which is this ongoing connection, or can Bowery residents or someone else who's working with them make sure just help this person get into the shelter because that person is willing to go and they can go. So yes, there's increased dialogue going on between those teams now than there was before. And I think we're not perfect yet, but we're trying to really coordinate those services. And then there are also some of the teams that are primarily working with individuals who have substance use. So it's a connection of talking with them as well so that we know and trying to make sure that the engagement is they aren't overwhelmed, as you said, with multiple people talking to them, but so that the teams talk to each other. And I think we're getting better at that. But it still needs work. But our teams in particular do a lot of that networking with the other teams because they refer a lot of people directly to us, and then we stay in contact with the teams.
And I think it was last summer, Bellevue opened this new model program that with the 100 beds for people who were brought in pretty much by the police based on mental health actions and being homeless. And, forever we've known that people got brought into an emergency room, very often a public hospital emergency room, by the police. And then a couple of hours later, they get let go out the back door. And everyone knows that isn't working and hasn't been working. And so, to I think the credit of Bellevue and Health and Hospitals, they said, okay, let us take a stab at a new kind of unit, 100 bed, I believe it was 100 bed, and people can stay for, I forget how long they can stay, but
I think it's up to several months.
I think
it's
it is.
It's several months. It's not brief.
Right.
Yes.
Exactly. And so is it operating, and do you have any sort of experience from it yet?
It's operating. What we're hearing is good. We also have, they had placed some clinical services also in that building, which we worked with them on so that they could have a clinic for some of the individuals who would be in the building. And as far as we know, I haven't seen real outcome data from them yet. I'm sure they're collecting it because Health and Hospital does. But so far, it has been very helpful in terms of moving forward. And I'm sure they'll have some outcome data soon.
And is there going to be any kind of state funding available for replication or continuation of this program?
What we're doing is a little bit different. We have critical time intervention teams that are connected to transitional housing, and that housing was in not this budget but the prior budget. And they're about in the city there'll be about 15 teams, and there will be housing connected with them. So it's a similar model from the state that does transitional housing for individuals. And again, it would be up to 6 months that people could be in the transitional housing, and they would also have a team wrapped around them to work with them so that they can recover and move on to the next level of care. So that funding was in the $1 billion funding, and those teams are coming up. They are particularly connected to emergency rooms and discharges from hospitals. So those transitional beds are being set up. And so it's a similar model. It's not quite just one big building. It'll be spread across the city.
Okay. And my time is up. Thank you very much.
And thank you, Assemblywoman Tapia.
Thank you. I have a question for Commissioner Sullivan. Nice to see you. Thank you for all you do, day in and day out. What is the current status of the review of whether mental health club houses may be eligible for Medicaid reimbursement? If eligibility must move forward. What rate structure is OMH currently considering as most appropriate for clubhouses operations such as daily or weekly reimbursement model?
Yeah, we are working very closely with clubhouses, with Department of Health, et cetera, to look at a model. Some states have done some medicating of some of the services in clubhouses. It's best to do a kind of bundled rate of some sort rather than individual service rate. So we are looking into it. At the beginning, we will not be billing Medicaid. Probably that will take a year or so. It has to go through a whole host of things even after we design it. But some of the work that the clubhouses do can probably never be paid for by Medicaid. So they will always need some degree of funding from the state as well. But yes, we are looking at it, and we're working very closely with some of the well-established clubhouses across the state who are very interested in doing this, because this can enable us to expand more clubhouses if we can get some of the money from Medicaid, and some of what they provide should be billable. So
Okay.
yes, we're working on that.
I have another one. What is the anticipated timeline for the OMH recently released RFPs for the clubhouses?
They are due back in February, and they will be awarded some. They're already due back. They will be awarded in March. So we will have those clubhouses out. The 8 clubhouses will be awarded in March of this year, in March, and then hopefully over the course of this year we will begin to see some of them opening. But yes, the awards will be made in March.
Thank you. Thank you very much.
I just want to correct that. I think the awards will be made in April. They're due back in March. The awards in April. Awards in April, back in March. Okay.
Thank you.
So
We've
April,
been joined
April.
by Assembly Members Anderson, Chandler Waterman, and Jackson. Our next questioner is Assemblyman Otis. Who passes to Assemblyman Eckes.
Thank you, Chair. Commissioner, great to see you again. When they talk about vulnerable populations, there is no question in the world that you deal with the most vulnerable, because obviously all of your clientele come to you with some sort of need right out of the bat. With that being said, and with a daughter who is under daily OMH care, I want to extend my gratitude, my great gratitude, not only to you, your staff, but every one of your tens of thousands of workers that are out there right now working and doing a great job. I get to see that on a weekly basis because I get to see my daughter on a weekly basis also. And so it's not just an one occurrence situation.
Thank you.
You're very welcome. I did, when I first started this job 3 years ago, ask about, cross programs between OMH and OPWDD. If you could just send me some examples or the examples that you have created over the past, and I know you have over the past few years, I would be grateful for that. I'm also talking about the workforce. I'm also interested in how many open positions we have and how much overtime that maybe is incurred, and the need to not only hire new but retain those that we have, and what part we could play as elected officials, as concerned, in my case, parents and so on like that, to help increase with the hiring process. I also am very, very interested in being sure that all of your facilities are safe spaces. We know what's going on out there. We know what's happening, and yet I have not seen any indication that your facilities are considered or going to be considered safe spaces for both your workers as well as, your clients. If something happens in one of your buildings, it will create chaos. We know that. So I hope you're pushing the governor. I certainly will push the governor to add that to her list of safe spaces. I only have like 35 seconds left. I took the youth mental health first aid program. Since this was mentioned in the governor's budget, I can tell you personally, 40 years as a high school teacher, I've been contacted by numerous teachers saying, why? Why don't we get the training first? We are mandated reporters. So how are we going to deal with this? It's great giving teen to teen or peer to peer type of training, but if we have no training and we have to report it, who do we report it to, and what happens ultimately? So I would strongly recommend the 17.5 million to go towards teacher training.
Yes, it's a combination. So yes, it will be offered to teachers in those schools as well as to the students. So
Thank
there's
you
youth
very
mental health
much.
training for the teachers. So that is there. Thank you.
Is Assemblyman Palasamo still here? You're on.
Thank you, Mr. Chairman. Thank you, Commissioner. It's good to see you again. I want to kind of go back to what Mr. Sumpelitz talked about, the issue of rural suicide. As we talked about my constituent, Senator O'Mara's constituent, Mr. Joe Tobia, who I know you mentioned as a part of your task force. He's been very proactive on this issue because we know he tragically lost his son, Matt, to suicide. And this all started with the legislation a couple of years ago, which he was very active in pushing. The governor vetoed, and then the idea was it was going to be in-house with the task force, which we appreciate. And I hope you continue that engagement with Mr. Tobia, because his perspective and the ideas he's bringing to that are going to be very helpful. Actually, Mr. Semplinsky and I just met with him the other day, and we just asked him how things were going. He's really excited. He's interested, of moving forward. But he said something that just kind of made me pause a little bit. He said some of the discussions, and maybe we heard it wrong, or hopefully heard it wrong, said that there's a look at going about it by a county by county approach. And I would think on this issue, the state needs to lead, because if we go by a county by county approach, certainly there's some counties don't have the resources that others, especially that's the issue we have with rural inequity. And so we're hoping it's really a state-led effort, because you at the state can bring in the best experts with the best practices and have a better better outcomes. So I guess what I'd like to ask of you, I know you probably can't do it all here, but afterward, could you share with myself, Mr. Sumpelitz, Mr. Mayor, I'm sure everyone would want to know on this because it affects everybody, what your plan is, what your strategy is, how this task force, how OMH is addressing the issue of rural suicide, the best practices, and to confirm that this is going to be a state-led effort to address rural suicide and the problem it is in our communities. And anything you want to elaborate on here, but then certainly the follow-up would be what that plan is, would be very helpful to us.
Yeah, sure. We'll get back to you. But I think it's a state-led. We just have to work very closely with the counties. We're not
Sure.
trying to put the burden on the counties, just to make that clear. But
Thank you.
But sometimes we've done things from the state without really involving the counties too much, and that's not going to work for this. You really have to have the counties intimately involved in the work that you do. So yes, you're right. It's a state-led, and it will be a state-led initiative in conjunction with the counties.
Perfect.
But we're not going to be pushing the burden onto the counties. It's going to be joint, and we really need to do it with them because they know their areas best.
Right.
So
And-
we need to work with them.
That's what we thought and hoped, but we just wanted to clarify that for the
Yes.
record, because obviously the state has the resources. You got the best experts. You can bring in the
Mhm.
smartest, brightest people to work with the counties. And we know the counties are on the forefront of delivering services in their
Right.
communities, and they know their counties best. So
Mhm.
we appreciate that, and we certainly would love to see what your plan is
Yes.
as it developed. To share that with us,
Yeah,
we would really
absolutely.
appreciate that. I'm sure everyone up here would. Thank you, Commissioner, for your
Yeah.
work. Appreciate
Yeah.
it very much.
Absolutely.
Thank you, Dr. Sullivan. Assemblywoman Chandler Waterman.
Thank you, Chair. Thank you to Commissioner. Thank you for you and your team being boots to ground in my district. We kick off the year, unfortunately, with several police-involved incidents. With a person experiencing emotional crisis, some fatal, some non-fatal. Michael Lynch at Methodist Hospital, a place that's supposed to be safe for both the patients and the staff workers there. We strongly recommend incident panel reviews to be activated, incident review panels to be activated in these cases, even those Michael Lynch didn't present with former mental health, conditions, but obviously it was a crisis. And then it was in the Queens and the Bronx. Also, there was several incidents as well. So we just want to make sure that not only is activated the incident review panels, but to share recommendations to the legislature and to the public, so we know better how to understand the gaps in the system, because we have to make sure that that's better. Also, for $6 million for Daniels Law teams, it limits the scope of their work. And will they be able to operate 24/7? How would they capture? How wide would the capture be without a serious investment, additional investment? And of course, we want to fully pass Daniels Law. And two more things, youth space grants. My feedback from the community is that a lot of small nonprofits are not really getting those grants. I'm not exactly sure how much is per regions, and we're not sure who got the grants. I know there's more investment that's going to be this year to make sure that we get more people involved in that, more groups, but we just want to make sure who's receiving it and how the services are being dealt with in the community. And lastly, INSET. The New York City teams based in Brooklyn, they are meant to be alternative to Kendra's Law, as we know. How are these working, and is there a goal to expand them? So I know there's a lot, but I had to get them in.
Let me go from the back first, and I hope I don't forget. On the inset teams, there currently are 5 that are fully operational, and they are seeing the number of clients that they should be seeing, and so far have been very successful. They were in previous budgets. There's an additional inset team that came in the last budget, which the RFP is out for, and it will be awarded within a couple of days.
Yeah.
So that's
Incident
there.
review panel, sorry. Thank
No.
you, yes.
And incident review panels, we have been doing the incident review panels. We have done one each quarter as we were asked to do. And we have come up with a series of recommendations, which we are putting together. And we're going to be kind of doing that over a period of time, so that basically we will gather all those and then be able to report the recommendations and the actions on the recommendations.
Okay, so would
at the
these
time
particular
frame.
incidents be considered in the next quarter? Michael Lynch and the other ones?
We do one each quarter, so we will be looking at those. Not specifically, we'll be picking one, but that will be in the pool. I think you've suggested those. So we will be looking at those as
Okay.
possibilities.
And the youth spaces, sorry.
The youth spaces. The youth spaces, there will be a total of 10. 4 have been awarded. 1 is in Queens. The other 3 are rest of state. I think Wayne County, Central New York, and I forget the other place.
Okay.
But there are 4. There are 4 that are about to be awarded, and then there are 2 in this budget, which would bring us up to 10.
Thank you very much, Assemblyman Anderson.
Okay, got it right this time. All right, good morning. Good morning, Commissioner Sullivan. It's always a pleasure to see you. I appreciate you in the fall visiting my district to talk about the comprehensive psychiatric emergency program that is offered in round 2. So I'll have 2 questions. The first question is with regard to that program. Wondering if in this budget, if there's additional funding or resources to expand programs and provide technical assistance for hospitals or any other entities that want to apply for the CPEP program.
Yeah, that RFP is out, and I think that one should be back and awarded sometime in March or April as well. But that there is an RFP for additional funds for comprehensive psychiatric emergency programs. Yes, so that's out.
Excellent. But is there technical assistance to help folks?
Yes.
Okay.
yes.
Okay, great.
At the same time, yeah.
Okay. And then I get thank you, Commissioner, and thank you your team for all of their hard work and commitment. I have another case or answer a question I'd like answered. So I had a constituent who it's a really tragic story that happened in the Rosedale section of my district. A constituent who struggled with mental health, unfortunately, allegedly killed his father. Now he is on Rikers Island, or he was transferred to Rikers Island, and now was deemed by a judge to be unfit to stand trial. So this is, of course, a very painful incident, and no one wants to see this type of thing happen. But I guess the question I have is with regard to the process in which when someone is deemed unfit to when they're assigned to a facility until they become fit. Right now, an article came out earlier this year in the city that said there are many people who are in limbo, like this young man who was in limbo, not yet sentenced, but sort of in limbo at a facility. Can you speak to what this budget does, if anything, to help that class of people that are in limbo?
Yeah, there's a couple of things. One, which will take time, was last year those individuals are waiting often for an inpatient bed. to be converted to competency. There were 100 beds that were funded in last year's budget for Wards Island. Unfortunately, they won't be coming up right away. So in the interim, we are working with the city, working with Bellevue and Elmhurst to be doing some of these competency hearings. We are also looking at outpatient competency restoration, and we have a small pilot. This is technical; it's a little difficult to do with the DAs, but we are working with the DAs in Brooklyn to do some temporary. And the other area that we are looking at is working with the judges to be able to have an evaluation while someone is in Rikers if they are doing better, to be able to get.
Thank you. Sorry.
the
Thank you,
services they
Commissioner.
need.
Thank you. And to close, Joanne Simon for her 3-minute follow-up. No.
No.
Healthcare can last for 3 months. You only get 3 minutes to ask questions.
Thank you. I have 8 minutes of questions for 3 minutes. One question I wanted to ask you about, there was a study that was commissioned a couple of years ago with regard to the use of INSET teams and ACT teams with people who did have AOTs, for example, showing that those programs were just as effective. I know that study is still ongoing. Do you have anything to report on that at this juncture?
Not at this point. That study is due the end of, I think, July. It's due in
July of this year?
Yeah, this year.
Okay, great. And then the other thing is the Children's Behavioral Health settlement that came out, was reached. Can you tell us where we are in getting the movement on those issues? I know the settlement's been reached. How are we implementing that? Because I know it's about an 18-month time frame that these changes are going to be made.
Yeah, the settlement was signed in January, so we now have 18 months for the planning and development phase. And we will be meeting with tons of stakeholders, families, youth, providers across the state for the design of what the settlement will look like. Then after that 18 months becomes the implementation of the design, and that can go on out several years. So that will, and it focuses on the intensive services that families and youth need. So the home-based services, the crisis intervention services, the mobile crisis services for youth. So the first 18 months is a really in-depth planning and input from the stakeholders, and we are funded to do that over those 18 months. And then we will have the design for the system, which will be implemented over the next 2 to 3 years. In the meantime, we are expanding some of the crisis services for kids, et cetera. So we're not waiting for everything to come out of the settlement, but the settlement will provide a structure that we think will provide better coordination overall for all the services these kids and families need.
And then engagement process, is there an element of public engagement
Oh,
or
absolutely.
hearings
Yes.
that somebody who may not be a current stakeholder that you know of would have an
Yes.
opportunity?
Yes,
Okay.
it will be very wide, it will be broadcast, there will be public participation.
Okay. And then the other thing I just wanted to piggyback on the incident review panels. I think we'll be corresponding with you about a couple of particular situations that recently occurred
Mhm.
that really seem to be exactly the type of situation where incident review panels are needed. And also
thank
there's
you.
some recent data on Be Heard that shows a real lack of effectiveness for the most part of that program.
Thank you. Thank you, Commissioner, for being with us this morning. Apparently, we could ask you many hours more of questions, but we are going to let you go on with your day and invite up your 2 colleagues, Dr. Chinazzo Cunningham, Commissioner, the New York State Office of Addiction Services and Support, and also Dr. I'm not sure she's a doctor, Willow Bear, New York State Office for People with Developmental Disabilities. There's no penalty for not being a doctor. And then if our colleagues can take their questions for Dr. Sullivan out to the hall, thank you. Okay. Also, I think we've been joined by John Liu, Senator John Liu, since the last time I made announcements. Hello, Senator Liu. Sir. Okay, we'll let these two women get themselves comfortable. Again, the magic trick is make sure your green ring is lit when you go to talk, because otherwise we can't hear you. And you have to press the button just in the right place. Or it just hates me. It never wants to go on. I don't know which. Okay. And we're going to go in the order that you're listed on the agenda. And you each get 10 minutes. Then you're a panel. Therefore, when we ask you questions, if we, let's say, are a chair and we have 10 minutes, it's to be used for both of you, not 10 minutes for each of you. So you don't get quite as intense a run through as your predecessor did, mental health being such a large agency. And you feel ready? All right. Senator Cunningham. Senator Cunningham. Ooh, that sounds good. Where did you live again? Sorry. Dr. Cunningham. Do you live in Manhattan? Well, everyone in Manhattan is not running again, so go for it. Every day I wake up and another one of my colleagues is not running again, so.
Good morning, Senator Krueger, Assemblymember Pretlow, Senator Fernandez, Assemblymember Stack, and distinguished members of the legislature. My name is Dr. Chinazo Cunningham. I'm the Commissioner of the New York State Office of Addiction Services and Supports. Thank you for the opportunity to present Governor Hochul's fiscal year 2027 executive budget and to discuss how it strengthens New York's addiction services across the state. This marks my 5th year presenting the OASAS budget. During this time, New York has navigated a global pandemic, a nationwide overdose crisis, and an evolving federal landscape that continues to shape behavioral health systems. Through it all, Governor Hochul has remained steadfast in her commitment to the people we serve. Our work reflects that commitment, one grounded in stability, innovation, and equity. The fiscal year 2027 executive budget proposes an OASAS appropriation of over $1.3 billion, including more than $198 million for state operations, $1.1 billion for aid to localities, and $93 million for capital projects. These investments help ensure we maintain a stable, comprehensive system of care for everyone impacted by addiction. Across the nation, federal policy and funding shifts pose real challenges for states seeking to maintain addiction services. Uncertainty around Medicaid coverage also puts pressure on programs New Yorkers rely on. The executive budget responds by reinforcing state investments and prioritizing system stability. It maintains funding across prevention, treatment, harm reduction, and recovery, ensuring continuity of care even amid federal uncertainty. With strategic planning and efficient use of opioid settlement fund resources, OASAS remains focused on what matters most: saving lives, supporting families, and strengthening communities. To date, more than $454 million in settlement funding has been made available, including existing multi-year contracts meant to ensure provider stability and sustainability. It represents one of the largest and fastest distributions in the nation. This year's budget includes nearly $102 million for settlement-funded initiatives, including expanding low-threshold treatment models, youth prevention efforts, and recovery supports. These long-term investments help sustain essential services while building resilience across the system. New York has made meaningful progress in reducing overdose deaths, a testament to our data-driven approach and our dedication of providers and community partners. Since 2023, overdose deaths have dropped by over 30%, saving over 1,800 lives. Behind these numbers are real people. This progress reflects a coordinated approach that pairs life-saving harm reduction strategies with expanded access to compassionate, effective treatment. The OASAS Harm Reduction Portal remains a national model for public access to life-saving supplies. More than 390,000 naloxone kits and 25 million drug test strips have been distributed statewide, each represented a potential life saved. Medication treatment remains among the most effective tools we have for preventing overdose deaths. The fiscal year 2027 budget continued to support proven models that expand access to these life-saving services. Mobile medication units deliver medication and clinical services directly to people facing transportation barriers, while comprehensive outpatient programs provide medication, counseling, and harm reduction services all in one setting. In addition, medication treatment in jails and prisons is now available in all 58 jails and 42 prisons, and has reached more than 16,000 incarcerated individuals. This nation-leading effort addresses the elevated overdose risk people face during incarceration and reentry. A strong addiction system depends on a strong workforce. Governor Hochul's budget continues support for leadership development, scholarships, paid internships, and peer training. Roughly 3,000 individuals have already benefited from these initiatives, building long-term career pathways in addiction. The executive budget also includes nearly $18 million to support our providers, including a 1.7% targeted inflationary increase to address rising costs and enable them to offer more competitive wages, and a minimum wage increase for the 5th straight year. Prevention remains foundational to New York's effort to address addiction. OASAS continues to expand evidence-based programs in schools and communities, strengthen early intervention services, and promote public education campaigns that reduce risk and support healthy choices. That includes our Cannabis Prevention Toolkit, which offers practical, age-appropriate, bilingual guidance to help adults talk with young people about cannabis use and related risks. To further reach young people, OASAS will host a youth-led substance use prevention symposium, empowering students to learn from their peers about the risks of substance use, strategies to support mental health, and how to access community resources. We will also launch a youth-driven media strategy featuring messages developed by young people and delivered across media platforms, meeting youth where they are in ways that they can understand and trust. For young people on a recovery journey, OASAS will create up to 15 new youth clubhouses. These community-based spaces will provide non-clinical supports such as life skills training, recreation, and peer connection, helping young people build stability, confidence, and a sense of belonging. OASAS also continues statewide anti-stigma efforts through the Don't Know, Don't Judge campaign, promoting appropriate language and reinforcing that substance use disorders are treatable health conditions. In terms of expanding collaboration and integrated care, our partnership with OMH remains critical to serving individuals with co-occurring mental health and substance use disorders. Over half of the people receiving addiction treatment also experience a mental health condition, yet services have historically been siloed. Governor Hochul's budget will cut red tape by allowing clinics to provide mental health and substance use services under a single license. OMH and OASAS will also develop a new co-occurring capable designation for providers meeting the highest standards for treating complex cases. The budget also invests over $6.4 million to increase rates for behavioral health supportive housing programs overseen by OASAS, sustaining housing for roughly 1,500 individuals annually. In addition, we will collaborate on a first responder behavioral health center of excellence supported by $1 million investment to develop culturally appropriate, peer-led programming and supports accessible to emergency response agencies statewide. As gambling expands, as access to gambling expands, the executive budget advances a comprehensive strategy to prevent and treat gambling harms. This includes integrating gambling recovery services into recovery centers, creating a gambling health workforce institute, expanding insurance coverage for treatment, launching a long-term statewide study, and strengthening peer supports through specialized certifications. OASAS continues to strengthen problem gambling and responsible gaming efforts through research, public awareness, and expanded supports. Our Take a Pause public awareness campaign encourages New Yorkers to reflect on their betting behaviors and educates youth about potential gambling harms. In addition, through our partnership with the New York Council on Problem Gambling and the Gaming Commission, we monitor trends and enhance prevention and treatment services. Despite progress, inequities remained. Communities of color continue to experience disproportionate overdose impacts driven by stigma and barriers to culturally responsive care. To address these gaps, Governor Hochul is launching GRACE, Guided Recovery Action through Congregational Engagement. This interagency initiative, led by OASIS in partnership with the Department of State's Interfaith Advisory Council, equips faith leaders with training and tools to recognize substance use, reduce stigma, and connect individuals and families to services. In closing, Governor Hochul's budget reflects her commitment to protecting access to care, advancing equity, and strengthening recovery across New York State. Together with our partners in the legislature, our providers, and the communities we serve, we will continue to strengthen our system that meets people where they are, honors their dignity, and offers hope for the future. Thank you, and I welcome your questions.
Thank you very much. Appreciate it. And next up, Willow.
Thank you. Good morning. I think it's still morning. Chairs Kruger and Pretlow, People with Disability Committee Chairs Fahey and Santa Barbara, and other distinguished members of the legislature. I am Willow Bear, Commissioner of the New York State Office for People with Developmental Disabilities, or OPWDD. Thank you for inviting me to be here today to speak about the investments included in Governor Hochul's fiscal year 2027 proposed executive budget that will benefit people with developmental disabilities, their families, not-for-profit providers, and our vital direct care workforce. Since we last met, OPWDD has been laser-focused on ensuring that people with developmental disabilities and the families that support them have a voice in our service system. This is demonstrated by initiatives like the implementation of our Office of Advocacy, which includes a team of people with developmental disabilities who advise me and my leadership team every day on our messaging, policy development, and program implementation. This year, we supported the first full year of the Independent Ombudsman Program, which has assisted hundreds of your constituents. We helped increase awareness and reduce stigma through the creation of person-centered content like our Accessing Life podcast and Know Your Rights booklet, both created by and for people with developmental disabilities. Our new Family Resources webpage makes it easier for new families to understand and to navigate our system. And we are proud to have made remote video interpretation services available to families 24 hours a day, 365 days a year, ensuring equitable access to supports for all families statewide. We continue our commitment to improve access to services for people of all ages and across a continuum of support needs. This year, we expanded access to specialized services for people with the most complex needs in our 9 state-operated comprehensive adult transitional homes, opened a second specialty hospital for children with neurodiversity and complex medical needs, and in partnership with the Office for Mental Health, launched home-based crisis intervention and critical time transition programs for children and adults with developmental disabilities who have co-occurring mental health diagnoses. We opened 122 new units of supportive housing for people with developmental disabilities, moved close to 900 people into certified residential opportunities, and authorized nearly 7,000 people for housing subsidies to support them to live independently in the community. We continue to see significant growth in our self-direction model, are about to launch our Home Enabling Supports technology service statewide, and we annually spend nearly $50 million on family support services like Respite, which assist families who are supporting their loved ones at home. Over the past year, OPWDD has engaged directly with thousands of self-advocates and families throughout every part of the state to better understand how OPWDD programs are working for them and where we should prioritize transformation efforts. Through these discussions, facilitated in multiple languages, I have continued to learn about the lived experience of people with developmental disabilities and their families when it comes to navigating this service system, and I am focused on how we can improve the customer experience for all people who interact with our agency. Based on community feedback, we are focused in the coming year on 3 fundamental areas: effectiveness, customer experience, and sustainability. We are working to drive better outcomes for people, to promote positive customer experiences with state government, and to make sure that our service system is strong and able to provide needed supports for people well into the future. I'm now excited to highlight some of the proposals included in this year's proposed executive budget that respond directly to those fundamental goals. Not only does the proposed 2027 executive budget continue the historic investments we discussed last year, but it provides new resources to address critical areas of need. Growing state spending on OPWDD programs by about $343 million to over $7.8 billion total, the executive budget represents a 4.6% increase in the OPWDD delivery system. And this during a year when the federal government's actions chip away at the Medicaid system. When including the federal share of reimbursement, the fiscal year 2027 budget makes $13.8 billion in public funds available to support the OPWDD delivery system. I would like to highlight first and foremost, and for the 5th year in a row, Governor Hochul has proposed funding that recognizes the critical role that our providers and direct support staff play in the lives of people with developmental disabilities across New York State. The fiscal year budget proposes a 1.7% targeted inflationary increase, building on our momentum to address the rising operating costs throughout our service system. This investment, especially when combined with Governor Hochul's proposals to make New York State more affordable, proposals like a historic $4.5 billion investment in child care and pre-K services that will help working families, a plan to lower the cost of auto insurance, and measures to ensure access to health care and affordable housing, will all support our workforce to continue providing vital direct care services while taking care of their own families. When added to funding that has been invested since Governor Hochul took office for cost of living increases, inflationary increases, rate updates, and bonuses, the additional 1.7% would equal a $4.6 billion invested in the developmental disability service system. These investments have helped to improve recruitment and retention of staff for OPWDD's not-for-profit service providers. According to survey data from our providers, direct support professional vacancies have decreased by 43.5%. Turnover has decreased by 6.1%, and starting wages have increased 28.6% since 2022. Coupled with initiatives like OPWDD's More Than Work recruitment campaign and collaborations with the National Alliance for Direct Support Professionals, as well as the State University of New York, to provide certifications, credentialing, and college credits that professionalize our workforce, we have not only been able to improve retention and recruitment in our field, but we have also increased the level of professionalism and job satisfaction and significantly reduced the state's reliance on mandatory overtime. You might recall that last year, OPWDD enacted a short-term housing strategy to help stabilize access to residential services and housing across the continuum of our system. We know that access to safe and affordable housing is paramount to everything, which is why we launched the build-out of a new housing capacity management platform to better match people to housing opportunities, establish state operations as a safety net provider for New Yorkers with the most complex needs, are working to streamline administrative procedures, and continually provide technical assistance and training to our nonprofit partners. In addition to the work OPWDD has done to stabilize access to housing, this year's proposed investment includes a much-needed investment to enhance reimbursement for our family care providers, modernizing the rate for providers who support people with developmental disabilities in their homes. This rate enhancement is expected to increase utilization in one of OPWDD's most integrated certified residential services and continue to further our goal of stabilizing the continuum. Additionally, to further our goal to increase independent housing opportunities for people with developmental disabilities, the proposed budget includes another $15 million capital investment in community-based supportive housing projects. And on the other end of the continuum, this year's budget will fund the final stages of construction of a 39-person intensive treatment facility. The governor has made it clear through her 2026 State of the State and fiscal year 2027 executive budget that people with disabilities are not an afterthought in New York State. She has advanced proposals related to accessible subway stations, adaptive clothing, rent freeze programs for New Yorkers aging with disabilities, access to higher education and health equity, and expanding accessibility at state parks. OPWDD is particularly excited to highlight the proposed $5 million investment in an assistive technology innovation center to support research, commercialization, and startup of companies that are developing technologies to help people with disabilities become competitively employed and live more independently. This will build on the assistive technology partnership with SUNY announced last fall. This project is part of a greater push to make New York an employment first state and will help grow employment for people with developmental disabilities. I am proud of the progress OPWDD has made to better meet the needs of people we serve as we work to improve our service system, making it more effective, more responsive, and more sustainable. This work would not be possible without the incredible support that Governor Hochul and the members of this legislature have given our service system. Together in collaboration as we enact a new state budget, I have no doubt we will reach our goals of a more person-centered, inclusive, and accessible New York for people with developmental disabilities and their families. Thank you for inviting me to be here today and for your support of this service system and of your constituents year-round. I look forward to your questions.
Thank you both very much for your testimony. And our first testifier will be Senator Fernandez. Oh.
Thank you so much. Hi, commissioners. So wanted to start with the Recruitment and Retention Fund. I mentioned before that I've heard from some OASIS providers that their employees get taken into the OMH side. So do you believe that we need more support for OASIS to have those retention and recruitment funds?
Yes, we certainly know that, supporting the workforce is critical, and I'm proud of the work that we have been doing for that. So in addition to the targeted inflationary increase this year and the minimum wage increase this year, we have many programs and initiatives that really focus on supporting the workforce. And over the last year or two, over 3,000 people have taken advantage of that. That includes like 1,800 people who have gotten scholarships, 400 people who have paid internships, 500 people who have taken advantage of a leadership training program. And then we also have a fellowship program. So I think the loan repayment piece is something that we are working on right now. And we have dedicated $10 million to that. And so in addition to another $2.5 million for nurses, addiction nurses. So we anticipate that that's going to be rolled out in the coming months.
Okay, great. The executive budget includes $65 million for OMH supportive housing program and only $6.4 million for OASIS supporting housing programs. Do you know how these monies will be dispersed and if OASIS will seem to get a fair share too?
Yeah, I think in terms of the housing program, our housing program is much smaller compared to the OMH housing program. So that $6.5 million will go to support the cost of increasing rent for approximately 1,500 units. And so that, we know that will really be a critical piece of the recovery support.
Thank you. I'm really happy to see all the work towards or the intentions about problem gambling and making sure that we grasp that before it could get worse. You mentioned research. Could you detail what this research would entail, what it's looking for, what kind of data we're trying to collect from this?
Yeah, so right now we, use data really to guide everything that we do, including problem gambling. We are closely monitoring gambling behaviors, who is coming in for treatment for gambling, calls to our Hope Center. So this additional, dollars will help to provide a 10-year statewide survey so that we can even more closely track what's happening with gambling behaviors. And so that's in addition to what we're already doing. In addition, we do work with the Gaming Commission to get data from the industry. This is something that we've continued to strengthen over the last couple of years to get very specific data so that we can have a better understanding of exactly who has accounts in terms of sports betting and when their betting occurs and how their betting occurs. And so this is complementary to the ongoing work that we're already doing as well.
Okay, I know there's a proposal too to have insurance providers cover gambling addiction services. Could you just describe what those services look like so people understand?
Yeah, so we have really been building more capacity in our treatment system to address problem gambling. And so I can tell you that the number of problem gambling designations for outpatient clinics has really increased by 33% in the last year. So we now have 53 outpatient programs that have specialized designation for problem gambling. That's in addition to a network of private practitioners of over 100 private practitioners that also have specialized training for gambling. We've increased our workforce as well to be able to have specialized training for gambling, and that increases by over 40% in terms of both the CASACs and the private providers. And so we really are, integrating gambling services into our outpatient program. Our addiction treatment centers also provide that in the inpatient setting, and really supporting the workforce. This year's budget also includes the peers to get a designated gambling designation specialty as well, and a specialized gambling health workforce institute to, again, continue to strengthen training. So in terms of that, insurance is ensuring that gambling is part of the addiction treatment for insurance.
Great. The opioid settlement fund. Last year, the budget enacted my bill to include reporting of the funds being used. Have you seen these reports come in?
Yes, so we have. So we report 100% of the initiatives and the
report,
dollars
but
that
is the
come
whole
through
state
OASIS.
reporting?
We report what comes under us. So I think what you're speaking to is what goes directly to the counties or the
Yes.
cities.
Are we seeing a report from them?
Yes. So right now we see about 2/3 of the counties or cities that have given us their reports, and we provide those links on our website.
Are there counties that are not complying and reporting?
Currently, there are 22 counties that we are still waiting to receive reporting from.
Okay. And is there any way to make sure that they do? Because waiting could be a long time.
So our authority here is to provide the information that they give us. So we, we rely on them to provide that information, and then we provide that in one place on our website.
Okay. The budget includes a $20 million increase for cannabis addiction services. Is this money here right now? I was told that the money technically hasn't come in yet from our cannabis funds. And when do we expect that money to come in?
That's correct. So the increase in the $20 million is an appropriation, and we're still waiting to see what the cash revenues will be for that. We know that there, is increased funding for the downstate casinos, that are not open yet. So, we're not totally sure of the timing of that. I'm sorry, I misspoke. So
Yeah,
for
like, this is
cannabis,
money
we're
coming
still
from-
right for the adult use cannabis. Dispensaries, we're unsure of exactly when those dollars will be coming in. But right now, we have the appropriation of the $20 million. We are using our dollars currently for cannabis, really focusing on prevention and treatment. So working with schools, working with school boards, having a cannabis toolkit, and working with, PTAs and schools to provide training, and also continuing to support our treatment system to make sure that they have the training for evidence-based treatment strategies to really incorporate focusing on cannabis.
Well, I think that's great that we're going to be using revenue from cannabis sales to help with harms of cannabis, but we don't see those direct funds going towards, say, alcoholism. Alcohol sales has no funds going towards services to address alcoholism, and same thing with the opioid sales. There is no direct funds into the public education and drug treatment pools. So would using these revenues from these two areas or creating a revenue stream, do you think that would help us further secure dollars in the future, especially with uncertainties of what the federal government is doing to us in the next couple years?
I mean, we of course, would be happy to continue to support our programs and continue to build capacity in our system to make sure that New Yorkers have the prevention, treatment, harm reduction, and recovery services.
For sure. This summer, I have 2 minutes. We had a hearing to discuss the Treatment Court Expansion Act in New York City, and this hearing, your office submitted a testimony in which you shared all the work that OASIS has done in recent years to provide more community-based mental health centers and substance use treatment resources for anyone that comes in contact with the legal justice system, the criminal justice system. It sounds like more services are on the horizon as we see in this budget, but do you think the behavioral health system would be able to accommodate more individuals who might be diverted from jail or prison if this legislation were to pass?
Yeah, we've been doing a tremendous amount of work across agencies, both with DOCS and SCOC, and certainly with the courts as well. We, have our providers working closely with them to make sure that medication treatment is available, and really accessible, particularly to this population, which is at very high risk of overdose. We also are working with peers to make sure that peers with lived experience also are part of that treatment process. And so we continue to expand this work in this area. And I think it has been really successful. We are really leading the country when it comes to this work in addiction and the criminal justice system.
Thank you. For my last 30 seconds, the crisis stabilization centers. We know there's a delay. We're supposed to have 24. We don't have all of them. What can you tell me about this delay and what we're doing to make sure that they open up soon?
So 8 are currently open. 5 should be coming online this year. And we are working, it's really
Do we know
about
the locations of where those 5 are coming?
I don't have the exact, well, I mean, I can get you that information. But we know stigma is a big problem, and we are working on that. That's why we had a public awareness campaign directly addressing stigma, and that is part of the issue with the citing.
Yes, and I always implore my colleagues to help push the stigma away from the situation. But thank you so much, Commissioner.
Thank you.
Thank you, Assembly.
Assemblywoman Simon.
Thank you. It really is a sweet spot on this to get the thing to turn on. So thank you. Dr. Cunningham, I had a couple of questions for you about there's a $71 million in the budget for existing OMH and OASIS supported housing programs. And I'm curious how they're broken out. It appears that 26.8 million is used for SRO programs. And so then the question is like, how is that determined? How is that worked out?
We are receiving $6.5 million for our supportive housing, and our supportive housing portfolio is just much, much smaller than OMH's. So that $6.5 million will go to support 1,500 New Yorkers with addiction annually.
And are those folks that are just served by OASIS, or any of them the folks that are dually diagnosed, for example, and are just falling under your catchment?
I mean, right, they can be duly diagnosed, but these are under the OASIS,
Okay.
Provider system.
Okay. And I appreciate that. And then there was a People's Action Institute's report analyzing insurer prior coverage, prior authorization denials under Medicaid managed care. And there are external appeals, I think, with regard to the OASIS population that are overturned about 64% of the time, which is about 25% higher than other managed care. Are you seeing or hearing about these troubling denial rates, and what can we do to impact that or make it better?
Yeah, we're also very supportive, obviously, of parity when it comes to insurance. We know this is a big issue. We work with our other state agencies, OMH and DOH, to really ensure parity. I think, we have our CHAMP program that works with individual people so that when we hear about these problems, we're able to address them, in real time. And, I know in last year's budget, there was also a lot of work to make sure that there was availability of services in the behavioral health system.
Okay, thank you. And also, we have coming down the pike new federal work requirements and a real concern about a spike in uninsured individuals. And I know that OASIS at least distributes net deficit funds to some providers. And the question really is, are the resources that we have going to be sufficient to sustain impacted providers? And at what current reimbursement rates? 100%, 50%, but do you have a sense of that? And whether organizations can sustain the magnitude of cuts?
Yeah, I mean, obviously, we're very concerned about the federal cuts that are happening. And, I think, as the governor has said, no state can really backfill all of the potential cuts and the threats that are coming our way. I think that, the good news is that obviously there have been a lot of potential cuts coming our way. New York has really fought them off. But in terms of Medicaid, I mean, we are being very proactive, knowing which one of our providers do provide sort of the highest levels of uncompensated care and are providing funding for them in a proactive way to really help stabilize them. And then we're also working with, our sister agency, Department of Health, obviously Medicaid under them, to make sure that that we have a way to really address the carve-outs, the exemptions for people with substance use disorder and the treatment that they provide.
Okay, thank you. And Ms. Bear, or Dr. Bear, I think we gave her a doctorate before, right?
I'll take it.
Okay. Yeah, take it. Don't worry about it. So thank you for your testimony and for your hard work. As you know, OPWDD is an agency that's needed a lot of work for some time. So I'm very excited to hear about several of the things you're doing. But I just want to say that I think probably the most important words in your testimony today are that people with disabilities are not an afterthought. I think that has been the leading reason why we have had the problems we've had in this state. So thank you for that and for leading in such a way that evidences that that's not the case. I know that you've also talked about engaging with community. I'm very glad you did that. And B, how are we doing in turning things around, right? There has always been concerns by people who are with the agency, advocates, parents, throwing up their hands with OPWDD. What active steps are you taking to actually sort of change that picture? And what can we do to help?
I think that's a great question, and thanks for the recognition of how important it is to have that lived experience at the very top of the organizational chart, and it is absolutely the core of everything that we do. When I came into this job, I came in partially as someone with lived experience, as a family member of someone with a developmental disability, and so it has been very important to me and my leadership team that we remember why we do what we do. That community engagement has been the form of individual meetings between me and family members, large listening sessions. I met with a group of family members from the Bengali community using interpretation and was told that it was the first time any state leader, city leader, county leader had ever come to meet with that group of people. So we have done a lot of that grassroots work to rebuild trust with as many people as we can. It's an agency, as you note, that has a history of maybe not having as good a relationship with our advocates. So that's been really important. I feel anecdotally, right, this is hard to put quantitative data to, right, that we are turning a corner. We do have a lot more of those stakeholder meetings and just a gained trust with a lot of our advisory bodies. We have people with disabilities working in and for the agency that I sit with every day that text me directly on my personal cell phone, right? So it is very important that we continue to make it more customer friendly, not just for people with disabilities, but their family members and our providers, right? They're all at the top of our organizational chart, and we as a state agency exist to make sure that they can do their jobs and live their lives.
Great. And let me ask you a question. I know that Dr. Cunningham has referenced this before, and I saw the commercials, and that is the issue of stigma with regard to people with disabilities, oftentimes in terms of housing and siting. Do you have any, are you working on that? Is that a big issue for the agency? I can imagine it is, but I don't want to imagine.
Stigma? Stigma is absolutely an issue for people with disabilities, not just developmental disabilities, but the entire disability community, particularly when it comes to employment. We have done a lot of work with marketing campaign dollars that we receive from one-time federal monies to make as many people aware of the diverse community that people with developmental disabilities can provide, right? They live in every community in the state, are perfectly capable of being wonderful employees, neighbors, loved ones, friends. So a lot of work has gone into sort of combating that stigma and making sure that we are issuing videos, taking pictures, right? Including people with disabilities in all of our community events. I think particularly when it comes to employment, as I said, that's where there really is a barrier. You ask what you could do to help. I think in terms of partnerships with businesses and business councils, really helping to get that word out that these are a group of people that are ready to work, want to work, are capable of working, and make really good employees. And so trying to expand how many businesses will partner with our providers to hire people with disabilities has been one of the biggest obstacles in terms of where I see stigma.
And another issue that comes up in employment and what people consider employment is the subminimum wage issue. And I'm curious what position, if the agency has one, about subminimum wage, because there are many people working in jobs where they could clearly earn more money and are capable of doing more. I'm curious what efforts you've taken to address that issue.
It's a really, really complicated issue with a lot of rich history. Obviously, in an employment first state, we want as many people with disabilities employed competitively with a meaningful wage, right? There are providers throughout our disability service system that still rely on subminimum wage for people that are working their way up to being able to make a wage. So it really is a complicated topic that I know our employment first director is hard at work to figure out how to transition out from New York State.
Okay, great. And just 15 seconds. Are you doing workforce development with folks who are served by OPWDD to help them get into that
Absolutely.
state?
Yeah, we have a whole continuum of employment, pre-employment, and vocational services.
Great. Thank you very much.
All right, thank you. Next, we have Senator Weber.
Good afternoon, Commissioner Bear. How are you?
Good, how are you?
It's great to see you again. Just want to start off by thanking you for coming down to Rockland in October and spending many hours not only touring facilities, but meeting with big and small providers at a roundtable we set up. I still get such amazing feedback from everyone that was there that really was appreciative that you came and listened and really had some great advice for them as well. So I wanted to start off by at least acknowledging and letting everyone know how accommodable you were and how open you were to coming to Rockland. So thank you.
Thank you.
I just have a couple of questions that my constituents and some of the people that were there continually bring up with me. One of them is regarding the housing subsidy. And I think we may have spoken about it at that roundtable, but they're telling me that it's becoming more and more difficult to get a housing subsidy for their adult children. And I guess they tell me that the recent changes to the housing ADM has restricted access to this vital service. Maybe could you speak to that if that's the case, or what you're doing to improve upon that?
Sure. We actually haven't released an update all that recently. We're working on one now to make it even more flexible than it already is. Our data would not suggest that it's becoming harder to get a housing subsidy, but it certainly is an area where I hear that concern, right? We want as many people as possible to live on their own in the community and make use of things like a housing subsidy. So there are revisions underway to make that just as person-centered and flexible as we possibly can with those state dollars.
Okay, thank you. And also on related to self-direction, there was some, or actually on the community classes, let me get to that first, but parents, again, I think brought it up, and some of the providers, that the beneficial services to people with this, that they're getting pushback related to some of the community classes that they're trying to access. Has there been any further discussions on really maybe creating less gridlock in terms of those community class ratings?
Yeah, we've had a whole lot of work done on this over the last year. This was a hot topic at last year's hearing. A lot of questions about community classes, which for those of you who don't know is a budget item within the self-direction model, where you can spend up to a certain amount taking integrated classes in the community. Those options are almost endless. But because we are a Medicaid-funded agency, there's rules that we have to make sure we're following. And so there's been a lot of work on community of practice and training with the fiscal intermediaries to understand what those rules are and why. And we have a lot of other sort of recommendations and things we're working on to make that a more streamlined process so it's easier for families and they don't have to feel like they're fighting with us over those things.
Right. No, I appreciate that. And I was encouraged to hear some of the statistics you mentioned since 2022 about the continual investment we make as a state, trying to get not only wages up to where they should be and some of the other investments we've made as a state. I know a lot of the providers are concerned about the 1.7. I know it's a struggle every year with that, and I'm sure when the Senate and Assembly One House come out, I'm sure that'll be an increased amount. Hopefully, we can land on a higher number. But the 1.7% as listed in the executive budget, what does that equate to in terms of dollars?
In the OPWDD system, it's about $95 million for the 1.7%. There's also a $39 million investment to cover minimum wage. So it's $134 million just on the OPWDD side to make those investments. And keep in mind that 1.7 grows the prior four cost of living adjustments as well as the $850 million investment we made last year.
Okay, great. And thank you. And again, thank you from Rockland County, from all the providers for coming and listening. And we hope to see you again there soon.
It was a great day. Anytime.
Excuse me. Assembly?
Assembly Member Sip Lewinsky.
There we go. Thank you. And first, I want to give a shout out to my daughter, who I mentioned last year. She's 7 years old, and she has Down syndrome. So I'm very passionate about what OPWDD does. I like what OASAS does too, but I'm particularly passionate about OPWDD. So my question is going to be for Commissioner, I guess now Doctor. Congratulations, Bear. And we'll start with. I want to point out, as I did with OMH, about the TII, and the point I made there, where we have now a big chunk of the economy that's going to get a true inflationary adjustment. Those who are on a minimum wage going forward in 27 and every year after. That's just going to increasingly put pressure across the system to keep up with everybody. And I would, as I said to OMH, want to prioritize non-minimum wage workers, those who are at a higher wage within our government system, within OPWDD's purview. But I'll ask you a slightly different question to just not be repetitive. Where did the 1.7 come from? Why 1.7? Why not 2? Why not 3? Why not 0? Where is that number coming from?
Well, at one point in time, there was a requirement that it be matched to inflation. That's not there, right? So the calculation, as far as I can tell, is what makes sense in a balanced budget with all of the other investments, right? In a year where we were expecting to make cuts, I think 1.7 is an incredible investment, especially when you recognize that it grows all of the investments from last year.
Yeah. So my point would be, we've decided as a state to lock in statute minimum wage. Maybe we should lock in the TII as a true amount. I have heard from constituents, especially in my rural district, about concerns as far as how far they have to travel to get services like OT or PT. Can you talk about rural access for those type of supplementary services?
Yeah, rural access is an issue for people with developmental disabilities, addiction needs, mental health needs, right? I know that the Department of Health is working hard on its Rural Transformation Fund and making $212 billion available, billion dollars available to address. In terms of IDD services, our state operations always looking to expand where we are able to hire staff to make safety net homes available, as well as clinic services in those parts of the state, and really leaning into making telehealth available, which is a big part of the Department of Health's Rural Transformation Fund. So excited to spend those dollars for sure.
I do love telehealth, but for instance, I remember during COVID, my daughter had to do PT over Zoom. There's some things that work with telehealth, and there's some things that really, don't. That was more of a COVID thing. You mentioned about vacancy decreases by 43.5%, which is great, and I think that's a fantastic thing. I just wanted to clarify that it says how much it decreased, but where are we at as far as a vacancy rate now? Because the mention in your testimony, you talk about the decrease, but not the actual vacancy rate.
No, that's a great question. I don't have that information. This was data we got from our provider associations. I certainly can see if we have the current number of vacancies. I believe we are at or higher than the rate of employment before the pandemic. So
Okay.
we have made significant inroads to be able to recruit and retain staff across nonprofits and in our state operated programs.
Awesome. Well, I mean, anything we can do to increase that retention and recruitment is wonderful, and just these people are doing God's work. So anything we can do to improve their morale and the quality of life for what they're doing, I'm in favor of. And one follow-up question from last year's budget. Last year's enacted budget had about $25 million in capital funding for regional disability clinics. Do you have any update on how that's been rolled out and sort of where in the state it's been rolled out?
Yeah, I'm really glad you asked because I forgot to put this into my answer about rural
There we go.
health, right?
Yeah.
So that $25 million, we issued RFPs last year, got back an amazing response from existing Article 16 clinics. So those are licensed by us, and Article 28 clinics licensed by the Department of Health. We're in the final stage of review, and we'll announce those tentative awards this month.
Okay.
So very excited to spend those capital dollars, particularly in areas like rural areas where it's hard to get access to those services.
Well, I appreciate it. And as a dad of a little one with a developmental disability, thank you for what your department does, and appreciate the line of communication.
Thank you.
Yep.
Sorry. Thank you very much. Next is Senator John Liu, but we've also been joined by Senator Bino.
Thank you, Madam Chair, and thanks to the commissioners for joining us once again. Commissioner Cunningham, I appreciate your testimony and the fact that the governor included additional money, about double, for gambling addiction services, up to a little more than 22 million. Is that in line with the many years long referendum that was passed, I think back in 2012, that authorized all the casinos in New York State and requiring that there be resources given for gambling addiction?
Well, so that $22 million, as you said, it's an increase in $12 million. And some of that is from increases from the casinos, especially ones that will be coming online, the 3 downstate, in addition to the online sports betting. So it's from both of those sources of revenue.
Okay, so I mean, those are pretty much required by those pieces of authorizing legislation, both for the online gambling as well as the casino licensing.
Yes, and we have used these dollars to really build the capacity in our system.
And is that all that was required by those respective actions, the casino licensing as well as the online gaming?
Yes.
All right, so this is not really a discretionary increase. It's really kind of in line with what was supposed to be.
Yes, I mean, these are statutory requirements.
Got it. All right. And you had mentioned that that there are disproportionate impacts on communities of color when it comes to substance abuse
Yes.
and overdose. Is there the same recognition for gambling addiction?
Yeah, so we definitely follow the data in terms of looking at, equity, because this is one of our guiding principles. So when we look now, for example, at sports betting, we don't actually have that information, and we're working with the Gaming Commission to get more granular information, exactly what you're asking for, so that we can better understand specific subgroups and then be able to provide the support in a targeted way.
Yeah, if we could get culturally sensitive treatment and prevention programs along the lines of gambling addiction, that would be very helpful. Thank you very much. I have a quick question for Commissioner Willow. There are advocates who are pushing some sort of legally recognized Bill of Rights for people with disabilities. The word on the street is that your agency doesn't really like it. Is that true, or have I been misinformed?
So to be clear, I think what you're talking about is a Bill of Rights as related to communication devices. Obviously, OPWDD supports people's rights. It is the core of what we do, and that includes the right to communicate. We have a large portion of people who don't use speech to articulate, and fund and support all kinds of ways to help people autonomously and independently communicate.
I'd like to work with the office to further that along.
Thank you. Assembly.
Assemblyman Stick.
I'm losing my time. Commissioner Cunningham, really, the OASIS budget is relatively flat. a 0.1% increase. I do know that one of the reasons for that is we lost $55 million from the opioid stewardship fund that had to be returned pursuant to some litigation. I also am aware that the opioid settlement fund has been earning interest, and because it's large, there's about $33 million of interest that is being generated by the opioid settlement fund. Could that interest be used to, in other words, substitute for most of what was lost in the opioid stewardship fund?
Just in terms of the overall budget, our budget is increased by 6.5%, which is 83 million. But yes, in terms of the decrease we had to pay for litigation, that is part of what made up the budget. We have heard from the Opioid Settlement Fund Advisory Board about their recommendations and including the interest from the opioid settlement funds into this budget, and that is why it is included. And we plan to basically follow the recommendations of the Opioid Settlement Fund Advisory Board in addition to the data in terms of how those dollars will be used for programming.
So you also have your increasing rates for OASIS supportive housing. What particular type of housing does OASIS provide?
So we, even though our housing portfolio is relatively small compared to some of the other mental hygiene agencies, we have really a variety of housing supports. So that includes recovery residences. So those are new and those are voluntary, and we support more of those coming online. We also have transitional safety units. So those are for specifically individuals leaving residential treatment or incarceration for transitional housing before they can get more permanent housing. And then we have permanent supportive housing as well. And that $6.5 million is to help increase the cost of rent for those. And so that will go to support about 1,500 New Yorkers annually.
My understanding of the recovery residences is that these were not funded by OASIS, that there was, I believe, Medicaid or Medicare, one of the two, funding available for that, and that the voluntary certification program was really just so that there wouldn't be corruption in those things, and that the people who went into those homes would have an understanding of what they were doing, and it would be guaranteed by OASIS certification. But I didn't understand that OASIS was funding those residents.
We are providing one-time incentive funding of $75,000 per recovery residence. That comes from the opioid settlement funds for housing and recovery services. And so that is to incentivize recovery residences to really come under the OASIS umbrella. And as you said, to make sure that there are standards that are kept and that then New Yorkers know which ones are really trustworthy.
So there, in the 25-26 budget, $18 million was set aside for OMH Workforce Recruitment and Retention Initiative. We know from your testimony and from our own communications with you that OASIS does a lot of those things as well, but the money that you use comes from the opioid settlement fund. Is that correct?
Some of it does. I mean, there are other. So we have about $37 million that we've invested in workforce initiatives and through a variety of sources. So some of it is from the opioid settlement funds, which again is the recommendations by the board, but some of them have been from other funding as well.
My understanding of the opioid settlement fund is after they make the recommendation, it then has to go through the OASIS procurement process, which can be lengthy and time consuming. And it may explain why a lot of the funding is not in the field maybe as quickly as we in the legislature would like. Is that accurate?
Well, we do have to follow state finance law, as you know, and so that is a process. But I think in addition to that, we have a lot of multi-year contracts. So we wouldn't expect that all of these dollars would be available in year one because we want to make sure that there's sustainability and stability. And so over several years, these dollars will go out for these initiatives. And that is what we heard from programs, and that's what we heard from the board in terms of recommendations.
Is it fair to say that if the legislature allocated funding for a specific activity, that it would go out pretty much instantaneously instead of going through the board? Is that fair to say?
I mean, again, we have to follow state finance law in terms of our procurement process.
So the money for problem gambling, I think Senator Liu, if I understood this correctly, that is money that is essentially distributed to you from gambling, such as sports betting and that sort of thing. It's not new money that the governor has allocated for this purpose. Is that correct?
So there's $1.6 million from the general fund that goes towards gambling, and then the additional money from sports gambling and from the casinos.
So on the loan forgiveness front, is your loan forgiveness program simply for CASACs and perhaps peers, or is there funding that you provide for social workers and nurses, for example?
So specifically for loan repayment, right now we have $2.5 million that comes from the Department of Health for nurses, addiction nurses. We're in the process right now of, refining, developing our loan repayment program that's supported by $10 million that we anticipate will be rolled out in the coming months. Those dollars will be for anybody working in the OASAS system. So not even just clinicians, it could be the staff that works in finance or the clerical staff. So anybody in the OASAS system can be eligible for that loan repayment program.
And what would you say the trends are in admissions right now? As admissions comparing opioids, alcohol, other drugs, and gambling?
So most of the admissions for our treatment system are either for alcohol use disorder or opioid use disorder. We know that there have been changes in kind of who's coming into our system. We know we've really invested a lot in a lot of the rural communities, and so we can see for example, 50% increase in rural communities of the number of people receiving methadone treatment, whereas in New York City, it's more flat and it's a different population that's an older population. So it depends on the specific population that you're talking about in terms of the trends that we're seeing, but we absolutely use our data to make sure that we're following those trends so that we can, invest in our system accordingly.
So you're saying it's different geographically throughout the state?
Geographically and by age as well.
So do we have plans for increasing funding of programs that go beyond the 28-day that insurance customarily pays for?
So the 28-day programs are typically the inpatient programs, which are the most complex, right? And that's really based on, having that clinical judgment and need, and then we're getting the insurance approval for that. In our residential treatment programs, the stay is much longer. And usually, that is dependent on the specific needs of the individuals. And so the intensity of the services differs.
So the one final thing I think we have time for, which is that many addiction professionals who have seen hundreds and hundreds and hundreds of cases and have a lot of experience are subject to stigma because they don't have the so-called lived experience of their own. What are we doing to try and make sure that these professionals in the field are not subjected to that kind of stigma?
Yeah, so stigma is a big issue just in general, and we have, we're doing a lot of work to really address stigma. We have a public awareness campaign and other work as well with the workforce. We really need it all. We need people who are highly trained, and we need people with lived experience. And we're providing, we have initiatives to really support those individuals who are in the workforce and to bring more into our field as well.
And have the counties been using the money as intended by the opioid settlement fund?
So we receive reports from the counties. Right now we've that about 2/3 of the counties. And that information's on our website.
Thank
What they
you.
use it for?
Yes.
Sorry. Thank you very much. Next, we have Senator, excuse me, Canzaneri Fitzpatrick, and she's the ranker.
Thank you, Chair. Thank you both for being here. I want to say thank you because I distributed Narcan kits to some of my libraries, and it is through your office that we did that, and one of my librarians actually had to use one of the kits and saved a life. So that brings what your work is to a real, very real situation. So I just want to mention that because I feel like that's a good thing we're doing, no matter what else goes on. I wanted to highlight your statistic that you said that overdoses have dropped by 30% since 2023. It was suggested to me that that statistic may be skewed a little bit because we don't have data regarding xylazine overdoses. And I'm wondering if you have a comment on that, and what is being done to address those overdoses, and what should we be doing more legislatively regarding xylazine to address that issue?
Yeah, so that number, the 30%, includes all overdoses. So it's not specific to any one substance. And so, again, we're really proud of that work. We do look at the also substance specific overdoses. So xylazine is part of that, fentanyl, opioid stimulants, all of it, and constantly looking at trends to make sure that we're identifying where the needs are. Also, we have distributed over 25 million drug test strips. So about half of those are fentanyl test strips and about half are xylazine test strips. So we are giving people tools to be able to check for xylazine in whatever substance they're using. I mean, I have to say just overall, the drug market changes all the time. And we are constantly playing catch up in terms of what is the next substance that is, shows up. We don't know. Is it a veterinary substance? Is it made for human consumption? We don't know. But we do work with our, safety officers, police officers, in terms of learning what they see, in terms of what they're detecting from seizures. And then we also, work with our sister agency, Department of Health, that also has a drug checking program as well across the state. So there are different ways where we are getting those data and making sure that our providers are informed about what's out in the drug market, that we're providing that information. And then as tools become available, we're certainly making those available.
Okay. Shifting gears, and I apologize if you answered this already, but you mentioned in your testimony 15 new youth clubhouses. Where do we know where those are going to be? Have that been identified, and how do you determine where to put those?
Yeah, not yet. So right now we have 21 youth clubhouses across the state, and we have 31 funded recovery centers. So we are, looking at our data, looking at the geography, talking to our programs to see about what their capacity is to expand. So we have not decided yet, and so that that will be coming up, and we will use our data to guide us.
Okay. And then the governor's budget did not give a lot of detail, but I believe there's an expansion of the outpatient residential SUD capacities. And I'm wondering, again, the same question, how do we determine where to put those? And have you decided where those locations are going, increased beds?
Yeah, so we know we've continued to expand really services across the board, and we look at specific geographic areas that don't have services, for example, methadone, and then we'll target RFPs for those areas. So we will continue to build on that. I mean, I have to say that we have really increased the amount of services in a lot of rural counties. Now 2/3 of our counties, for example, have access to methadone. That's been a huge increase in the last several years. So we'll continue to build on that, using our data, using the geography to make sure that all New Yorkers have access to services.
Okay. That's all I have. Thank you so much.
Thank you very much. To the Assembly. Sorry. Assembly Member Brown, I believe ranker. Yes.
Hi, Doctor. How are you? Nice to see you. First, I really appreciate the efforts that you and Dr. Sullivan have made when it comes to co-occurring disorders. I really appreciate that. A major concern I've heard from the clinicians out there is that co-occurring disorders is something that needs to be prioritized not just on the treatment level, but across the entire continuum of care: prevention, early intervention, treatment, and recovery. Do you want to comment on that?
We agree, definitely. I think this is a great example of how we're working. Well, we work closely with OMH all the time, but specifically for young people, as OMH is increasing the number of clinics in schools, we're working closely with them to make sure that addiction prevention services are included in part of that. So that's like one great example. I mean, I think another is the symposium that we're planning to do this year with young people. Part of that will be about supporting mental health supports, in addition to making sure that individuals know how addiction services are there. And that really builds off of the work that OMH did with the Young Adult Symposium in the prior years.
Yeah,
So
that goes into my next question. That recent training for OASIS providers towards their adolescent designation didn't include OMH providers. Just want to make sure that we're really in the field, we're practicing what we're preaching. So just something to note.
yeah, and the adolescent designation, we are continuing to support expansion of that. We know that it's needed.
Great. Also concerned about the marijuana programming does not include co-occurring disorders and looks at the person through a holistic lens. Just want to make sure that the various agencies like OASIS, OMH, and the Office of Cannabis Management is looking at marijuana use disorder as self-medication and include it not just in treatment, but also in prevention as well.
Yeah, absolutely. And, we actually use some of our cannabis dollars specifically to work with OMH and OASIS programs to make sure that they are trained in providing evidence-based treatment specifically for cannabis use among young people. So that's, we're absolutely aware of the need for addressing the mental health piece along with the addiction piece, and that is happening.
Great. And one of the things we talked about when we got together was with respect to reimbursement rates for the 3 separate tiers. Could you explain what you and other agencies are going to be doing with respect to those 3 tiers so we can understand?
Right. So now, we will have a single license option so that providers, can then provide mental health and substance use treatment under a single license. And so the reimbursement rate will be one rate. The regulations will be one set of regulations, right? The background checks will be one set of background checks. So that really will, bring everything together. So that's the sort of top level of the single license. But then we also will have a co-occurring designation so that the programs can really have the, staffing patterns and the expertise to provide care for complex cases. And so we will be working around what what the sort of reimbursement rates will be for that.
And I guess when the regulations come out, there'll be comment period for people, for the providers to comment back and make sure that this reimbursement rate is going to work.
Yes.
Great. How is your agency measuring outcomes with the significant investments for addiction services that are out there, whether it be the MRTA money that's out there, the problem gambling money, the Office of Cannabis Management, and then as a corollary to that, how are we making sure that the counties are using the money for the intended purposes that the opioid settlement fund designates?
Yeah, I mean, I have to say I'm very proud of the work that we're doing, really to have a data-driven approach. That is one of our guiding principles. And since I became commissioner, we now have a Bureau of Evaluation and Research that has grown tremendously to address exactly the questions that you're addressing. So to know what works, how much are we investing, and if it's not working, then what do we need to do differently?
Yeah,
so,
maybe we could follow up with that because I really like to dig deeper on that.
Absolutely, and we have many published papers and addiction data bulletins that go into some detail, so we can definitely follow up.
Okay.
In terms of the counties for the opioid settlement funds, about 2/3 of the counties have provided reports to us.
Yep.
We put them on our website, but about 1/3 have not. Our authority is to post what they give us when
Yeah.
the money does not come through
With
us.
the 7 seconds I have left, I would like to follow up with you about how we do more for the veterans.
Okay.
Okay, thanks so much.
Thank you very much. Next is Senator Fahey.
You want to give
Thank you, Chair, and thank you to both commissioners. As Chair of the Disabilities Committee, I think I'm going to focus a little more on questions for you, Commissioner Bear. Let me just start with the targeted inflationary increase. I appreciate the 1.7, and I more than hear you that we are in a very tight budget, especially given some of the federal cuts that we are incurring. And I appreciate the study or the survey, the updated data that you've seen a decrease in vacancies of 43%, which is rather extraordinary. Turnover, it looks like, has not decreased as much. Any comments on what more we can be doing? And obviously, the groups have been quite united in still looking for more to help get at this turnover and retention rate.
Yeah, I think we're doing the things we need to do. We've made this would be 5 consecutive inflationary increases for providers on top of billions of dollars in one-time bonuses and stipends. We've implemented professional career paths with micro-credentialing and free college credits for providers for that direct care workforce. At the University of Minnesota, we just released a report this week, did a deep dive on all of our workforce initiatives over the last few years to assess its effectiveness. So I can certainly send you a copy, but I think we are starting to really do all the right things. We've brought providers up to the cost of doing business, and a 1.7 would just compound and increase that to keep things current. So
Okay. Thank you, Commissioner. With regard to the self-direction, a lot of attention, particularly in the past few years. There's been a lot of growth there. You've just launched, or you're about to launch, the coordinated assessment system. How do you see the impact of that, and will that assist here in assisting families, the CAS program?
So our coordinated assessment system has been in place for a few years already. It replaced the prior
Right.
assessment for people. It's much more person-centered, much more in-depth, requires that assessors meet with the person receiving services and understand what their day-to-day looks like to assess what type of services they need. So in terms of overlapping that with self-direction, I'm not entirely sure what the question is, but we have worked very hard to provide as much information about that coordinated assessment system. It came with some trepidation, of course, from advocates and families about whether it would change what services look like. We did a whole road show this summer with about 3,000 people
Yes.
attending those information sessions and really trying to make sure that people understand how to prepare for that assessment, what it entails, and that we really can trust and validate the output from that.
Sorry if I merged a bit of those. Housing, I know last year and a few times we talked about the list that's not the list, the waiting list on the housing. But can you just talk about how many individuals are approved for the residential placement but remain unplaced, as well as some of the needs there? And I appreciate that there is a small increase, and I get how challenging this is, but it just helps to understand where what we're meeting and what challenges remain.
Sure. It is very nuanced and complicated. We've spent a lot of time, multiple years. The list that's not a list, just to be clear, right? A lot of states operate a true waiting list where you don't receive services until somebody stops receiving services. And then you're next up and you get plugged into wherever that person left off. That's not what we do in New York. We're very proud to be what's referred to as an entitlement state, where we provide an investment to support people without a true waiting list. There is a list of people, right, that are waiting for those opportunities. It is a very individualized, person-centered process. We need to make sure that a provider lives and operates in the area the person wants to be in, that they have staffing, that they have the right sort of physical plant in terms of barrier-free, single bedroom, right? There's just so many things that go in to that assessment. We do move close to 1,000 people every year through that list. Currently, there's about 4,300 people on that list, a third of whom already live in an OPWDD residential facility and are interested in moving somewhere else. So it's very complicated data that we can sit down and dig into anytime.
Okay, that's very helpful. Thank you. I appreciate that. The increase, the overall increase, I will say I'm pleased that Overall, I know that's been a flat budget, a very challenging year, again with the cuts, but overall, we have a 4.6% increase for your funding. And what's the driver on that, and where do you see the bulk of those dollars going?
Sure. So it is a 4% increase overall. That is the 1.7% across those providers. It's also $120 million in new service dollars for people whose needs have changed or are new to the system. It's also the $15 million investment in support of affordable housing, right? So it's all of those things. It's growth, which is so much more than we expected this year.
Yes, okay. That's encouraging, and I appreciate the governor prioritizing these services given the need. And I also noted your comments on that we are an employment first state. We, like every other state, still have a painfully low employment rate among those with IDDs. Any any initiatives, anything that we should be doing here, anything to partner that we can be partnering with you about there?
Yeah, the shift to employment is slow. It is an entire culture shift. I sit on a national committee of state directors, and we all talk about this very incremental change to making sure that people with disabilities have access to employment. I think with the hiring of the Employment First Director this year through the Chief Disability Office, he has really taken the reins. A self-assessment was required of every involved state agency to understand the barriers internally and externally to making sure that those employment opportunities exist. So we have been fully engaged with him and that team to develop the employment first principles and make sure that our continuum of employment supports really meet the needs of people the way that they need to receive them, be that a job coach for ongoing work or very baseline vocational skills as part of a day program.
Thank you. And I know a question was already asked about facilitated communication services. I appreciate that you are prioritizing those and that technology is really opening up all sorts of new doors. Want to continue to work with you. I know there's the concern about validating those, and want to continue to work with you on that. And with that, thank you again, Commissioner, for your service and your passion for this work.
Thank you.
Mr. Santa
Thank you.
Barbara.
Thank you. Commissioner, great to see you again. I want to commend you on the announcement at the ODHEC campus, expanding those clinical services, very important to my community. So that was a big win, I think, for everyone. It's a great
for attending.
project. I do want to circle back on Senator just mentioned the bill that I want to talk about, the Communication Bill of Rights, and Senator Liu mentioned it at the end of his comments. Last year, we were able to pass it in the State Assembly. We've had conversations about this bill. The bill was put together because we believe every person with communication struggles with developmental disabilities has a right to be heard, understood, and respected. That's the premise of the bill. Developed by advocates, a lot of input from advocates from everywhere, from across the state. And the bill basically guarantees the right of every person to communicate in their preferred method, whatever that may be. And I shared a story about my son just yesterday with you, and he has a number of different preferences that should be respected. And a situation where I think this bill actually would have helped. That includes typing-based communication, letterboards, we talked about, spelling systems, sign language, speech-generating devices, basically any method that works for the individual. And I think that's important that we put that into law, that people are guaranteed these rights to communicate. It required agencies and providers to respect, support, and not restrict those methods. And that's been happening. There have been stories of that happening in different settings. And the bill is intended to stop that. Now, we passed the bill in the Assembly. It did stall in the Senate. Now, my understanding is OPWDD had concerns about this. So that bill in the last days of session did not move. I was very disappointed. So let me start here. Why did OPWDD oppose this bill, which guarantees people the right to communicate in a way that works for them? As I said, we've heard from advocates. Some communication devices have been restricted. We've heard stories. I don't know if you've met with individuals that share these stories. In some settings, one situation where an individual was placed, they only could communicate with sign language. No one around that knew sign language, so she couldn't communicate with anybody. So things like that are a problem. That's a failure in the system. That is a rights failure, and this bill is meant to stop that. So my question is what is the opposition from the agency? Is it normal procedure for the agency to dictate what's going to be in a bill? Because I think that's our job, not the agency job. And what happened that bill got stalled in the last few days of session last year?
So let me start by reiterating that everything you describe as the intention of that bill absolutely aligns with the mission and the position of the Office of People with Developmental Disabilities. I said earlier, we have an increasing number of people who don't use speech to articulate, and it is absolutely paramount that we find and support ways to communicate with people the way that they communicate. That has to be done autonomously and independently, and there is so much great technology. I would defer to my colleague in the Senate about why the bill itself didn't progress, but there are certainly concerns about the sort of...
Well, the concerns, let me stop you, because the concerns I understood from talking to my colleagues stem from the agency, conversations with your agency.
Yeah. There are a number of concerns that we've talked to advocate groups about with respect to supporting the end of the spectrum of supported communication, which is facilitated communication. So if you ask Commissioner Cunningham if she's okay and she pushes a button that says yes as part of a speech generating device, absolutely supportive. If I have to move her hand to press the button to say yes, that's where there's a question. A lot of national associations, New York associations, professional groups, self-advocacy groups have a lot of concern about a facilitated communication that's involved in expressing someone's consent to something, right? Expressing their will and making sure that we're really hearing the voice of the person that's trying to communicate with us. Also fully understand that it is very emotional and nuanced, and I have met with families who really rely on some of these facilitated communication devices, and it is very compelling. And as a parent, right, the desire to be able to communicate with your loved one is, there's nothing that I can think of that's more important than that, right? But there are just a lot of complications when you talk about creating an affirmative right for something that we wouldn't be able to pay for or support in that service system. There are language access laws already. We have policies around linguistic competence. Providers absolutely should be meeting that person's sign language needs, right? And those types of incidents should be called out immediately so we can address them. But it's sort of the broad scope of what the bill could mean is where the concerns come in.
We had advocates come up, and one in particular, Elizabeth Bonker, who has written a book, and she's a non-speaker. She uses a communication device, and what she said when she came up here, and I don't know if you had a chance to meet with her, non-speakers suffer in silence. That's why this bill is so important to her and the people she represents. This bill is the ADA for communication. We are the last to get our civil rights. This is a very important bill. I hope there is a path forward. This bill is still live in the Senate. I would expect that we can work on something to move this bill forward. It's very important to a lot of people. I hope that we can continue and get a bill that we can pass this session. But I want to move on to another topic my colleague brought up is the wait list, the non-existent wait list. And I say that because we have had conversations about this as well. Whether there is or isn't a wait list, whatever you want to call it, the bottom line is people are saying something much different. I've experienced this myself when my son aged out of school. He was waiting somewhere on a list. I don't know. There's been conversations about an emergency list, and that takes priority over another secondary list. So maybe there's several lists that are not being acknowledged. What it boils down to is people waiting years for placements. And when they're finally approved or go forward, the placements are just inappropriate. I mean, I was offered a placement in Long Island. I live in upstate. I'm not going to send my son downstate, and I'm never going to see him or see him very little. So these are the things that I'm hearing, my committee is hearing from people. And it's a real problem. It's a real problem. When people are screened, approved, and they're left waiting, that's a wait list. So I don't know what else to call it. And I think my colleagues will agree with me. Just because we refuse to name it doesn't make it go away. It just becomes unaccountable. That's a problem that we need to correct. We need to have an understanding how many people are waiting, because we don't know that either. Those numbers really haven't been published, and we don't have any information on that. So that's really a system failure. And when people are waiting for years, families struggle, aging parents, we talked about this issue. They're forced to provide care that sometimes they struggle to provide. People get stuck in unsafe conditions, inappropriate institutional settings, and as I said earlier in my testimony, that the system is going to get overloaded somewhere else. So you're going to have emergency rooms, shelters, police departments. It's going to get overloaded somewhere. So today I'm asking, if you don't call this a wait list, what is it? And do we have an idea how many people? Do we have data on how many people are on this list? Because I talked to a lot of people waiting, and they really, it's hard to give them an answer when I don't have the information.
Sure. So I'll answer similarly to I did to Senator Fahey, which is that there is a distinct difference between what the federal government considers a true wait list and what we use, which is a list to manage people that are waiting for services. I understand that it sounds like semantics. Federally speaking, there is a significant difference. We have about 4,300 people on what are essentially 3 lists: emergency, current, and substantial need categories. We move about 1,000 of those people a year, including people aging out of residential schools, which we've done significantly better at over the last couple of years. I know that when you are waiting for your loved one to find a place to live, it's hard. It takes a long time, and we strive to do better every day, right? That's by not only making that system easier by all of the things I outlined in my testimony, but by moving more people into community-based settings to support them in their own homes and their own apartments with technology and housing subsidies and support services so that they don't need to be on that list to access a 24-hour supported group home, which is just not the right outcome for a lot of people. We support more people residentially in New York than any other state's IDD system, and we have more state-operated residential programs in New York than all other states combined. So certified residential services are something we have a rich history in, and it will not go away. And we strive every day to make that process more efficient and to match people faster. But there are so many other components of the service system that we don't become overly reliant on that 24-hour staffing model.
What is the longest time people have waited on that list? What's the average time? Do we have an idea how long people are on this list?
Yeah, we do. We do have an average of about 8 months, and we've pulled that data. It's super unreliable and complicated, but
That
we'll
does
sit
not
down
match
and
up
sit
with
down
what
and
I'm
go through
hearing
it.
from my constituents. Not even close.
Thank you. Senator Rollison is next.
Thank you. I appreciate both of you being here today. I have for Commissioner Bear a couple of quick questions. Regionally throughout the state and programmatically throughout the state, where do you see the highest turnover and vacancies within the types of programs, and also, specifically the types of programs, but also regionally? Where are the challenges for your agency, OPWDD?
Are you asking about residential services specifically?
Yeah, I mean, pretty much. I would say broadly, but if you want to talk about that, that's fine. That's residential is fine.
Yeah, I don't know that I, off the top of my head, have that data by region. I mean, we certainly have parts of the state where we have more robust pockets of providers. Certainly, the downstate New York City area is very highly populated, a lot of people moving around throughout different boroughs, right? So a lot of activity there in terms of where people want to live, and a lot more affordable housing options, so much more movement. But I'm just not sure I'm understanding the full question. But I know you're rushed for time, so we can sit down.
And we need to do that too. Thank you. And then just I had a provider reach out to me on insurance costs. We've heard it quite often. We've been doing these affordability roundtables and bringing nonprofits in. Insurance has been a major topic. What do you offer? Some guidance on being able to find more cost-effective insurance for some of the providers, whether larger or smaller? I mean, is that I'm saying you're probably hearing that too, right?
So insurance for the providers, not for the person
Correct.
Receiving services.
Yeah, for the
That's
provider.
actually a great question. I don't know that we have any expertise in the cost of insurance or how to ameliorate that for our provider agencies, but it's a great thing for me to connect with my partners in state government on and
yeah.
see
Thank
if
you.
we can come up with some technical assistance there.
And Commissioner Cunningham, in a minute and 5 seconds, we've spoken quite a bit about SOS and their activities in the city of Poughkeepsie, especially when I reached out to them over Thanksgiving weekend. They worked hard over 3 days to relocate a woman who was living in a bus shelter not far from where I live. And I want to thank you for that. publicly? And how is the housing model that it's attached to SOS working out? In other words, when you actually are going to get someone into supportive housing or more permanent housing, is that working out okay?
Yeah, I mean, the SOS programs are mostly under OMH as compared to OASIS, but we certainly work together to make sure that, with our outreach teams, that we're placing individuals in the most appropriate place. But we have various types of housing. So, for example, we have transitional housing, which, sort of may help people as they're trying to get more permanent housing. And so it really depends on the individual need and the various types of housing that's available, and there's a whole continuum.
And I appreciate that because I couldn't get that question into Commissioner Sullivan with 3 minutes, so I thought I would wait and try to talk to you about it. Thank you.
Thank you, Commissioners. Commissioner Cunningham, I have a question from my colleague, Assemblyman Brian Marr, who can't be here with us today. He's currently overseas serving our nation on active duty. So he wanted me to ask you, there are resources available in communities throughout the state that are not always known to individuals fighting addiction and to their families. Assemblyman Marr and many of our colleagues have met with countless community organizations and local agencies, and this same question comes up often. Are there conversations taking place in your office on creating either some type of app or an AI digital concierge that can direct folks to a list of nonprofits and resources in their areas to ensure they are aware of all of the charitable and governmental services that are available to them?
Yeah, so we have a couple of different ways to be able to address that. So the first is the Hope Line. So the Hope Line is available 24/7 across New York for all kinds of services, substance use and gambling. And we train the operators to make sure that they're aware of the kinds of services that are available in the location. We also are in the process of revamping our website so that can also be utilized to better understand how programs are organized and where they are across the state. And then we also have regional services and resources. So we have regional addiction centers where, again, that individuals can go to find out what's available in their regions to address their specific needs.
Thank you, Commissioner.
And I think to close for the Senate, Senator Webb.
Thank you both for being here. I'll try to get both my questions in, mindful of time. So first, I want to start with Dr. Cunningham. So with regards to the opioid settlement funds, do you anticipate with the Attorney General's office that there's going to be any further settlement monies coming into that fund?
So we know in terms of the Sackler funds, we anticipate that those receipts will be received. We don't know any of the specific dates in terms of that, but we do know that that it's constantly changing in terms of the receipts that come in, and when we have them available, we certainly work with the board to get recommendations for them.
Okay, great. And just another question for clarification: the $71.5 million for supportive housing, is that equal to the supportive housing carve out on HMH Part P? Is there a difference?
So the dollars that we have for supportive housing is $6.5 million. I think the dollars that you were talking about include also OMH. And so our portfolio is much smaller, and that goes to support about 1,500 supportive housing units.
Okay, thank you. And then my last question for Commissioner Bayer just deals with care coordination organizations. I have a number of entities in my district that provide some really important services. And so my question for you is, do you think there are enough resources in this budget for our care coordination organizations to carry out their respective responsibilities?
I agree that the care coordination organizations are the absolute vital link between people, families, and our service system. So our care coordination organizations are included in our budget, funded and grown. They don't, as you know, get the 1.7 targeted inflationary increase, just like other health homes across the state do not. But they are resourced to do the job that they do, and we support them every day with training, technical assistance, etc.
But do you feel there's enough resources that have been proposed in this budget to help these respective organizations?
I do.
Okay, and then my last question, I think I'd have time, is the current housing need for the folks that you serve through your agency, do you think that the 15 million that's also proposed in this budget is enough to address that need?
I'm sorry, for the
for
supportive
the
housing.
current housing, yes.
Yeah, I mean that's a $15 million investment that we've made each year, totaling $170 million at this point. We opened 122 new units last year. There's always going to be a need for housing. That's 122 new units for people to live in that they didn't have before. It's about as much as we're able to build.
Okay, thank you.
Thank you, Assemblywoman Giglio.
Thank you, and thank you both for being here. And Willow, thank you for your passion for people with intellectual and developmental disabilities. We know that you have a true passion for it and care for the people that you serve. So my questions deal with the executive budget and a 1.7% targeted inflationary increase. I mean, it really is not enough. We're still catching up from 10 years of no increases at all. And inflation is real when it comes to keeping the lights on and feeding people. So in the homes, it's really 1.7 is what is proposed in the executive budget, and the ask is for 2.7. So I'm hoping that you will help get that across the finish line as you helped get those increases last year. But assuming the budget is passed on April 1st, when can the providers expect to begin receiving the increase?
So I think you know that the rate process in New York State is complicated and includes a number of agencies, including our own. We work with the Department of Health to get those rates in the pockets of providers as quickly as we can. It is a process. It takes some time, but they are paid retroactively to the day that the budget was enacted.
Understood. But as we know, we've had those discussions, and thank you for coming to Long Island and coming to Angela's house, where we did talk about the importance of OPWDD setting the rates. So taking that back from Department of Health, because they have a lot of things on their plate and this is not their number one priority, and providers are sometimes waiting 6 months to a year to see these increases while they're laying out this money for the increases for the DSPs that work for them and for all the other things that keep the operations going. So I would really like to continue those discussions, because there doesn't seem to be a bridge between OPWDD and DOH when it comes to setting these rates. Also, I want to talk about co-occurring disorders, where people that are under OPWDD don't have immediate access to mental health, inpatient mental health, when there are co-occurring disorders. I love the idea that you had mentioned about the crisis intervention at home. That's a great thing, but a lot of times they need to be in inpatient, and because there is no bridge between OPWDD and DOH, how can we address that effectively?
So we've actually worked more with the Office of Mental Health over the last couple of years than historically has ever happened. They have been absolutely fantastic partners and have committed a lot of that $1 billion investment into people with co-occurring diagnoses. The home-based crisis intervention also includes enhanced step-down. There's community transition programs for both children and adults, some that have opened, some that have not opened. So really trying to create that bridge between the two systems. We've been very active over the last 2 years with making those available. We have about half of those programs open, some in the process of opening, and as Commissioner Sullivan outlined, some issues with a couple of the proposals in terms of siting.
Okay, and then I'd like to talk a little bit about the CCOs. And 2 years ago, they were taken out of the budget as far as increases that we're seeing for other agencies throughout the state. So I want to see the justification for that, because a lot of the CCOs, as you know, are doing the work up front and they are not getting paid. They are not seeing a dime from Medicaid, and they are helping people through the OPWDD process and qualifying them for the Medicaid waiver once OPWDD says, okay, you can now go and apply for that waiver, which we know could take years in order to get that Medicaid waiver. And that consists of about 80% of the population that are going through that process to try and access services, but 80% of the population are falling through the cracks when it comes to becoming, to getting the Medicaid waivers. So how do you think that we could streamline that process? And when they finally do get everything and they get the okay and they go before the quality review board, even then they may be rejected after jumping through all those hoops and getting the Medicaid waiver. How can we fix this?
So I have to disagree with the 80% falling through the cracks, but we do work incredibly hard at making sure that we are reaching every family, every person with a disability in every underserved part of the state of New York. Our numbers do not suggest that we are decreasing that effort. We have actually increased twofold in terms of children moving into the system. We have half of our service system at this point, people under 20 years old, and that just continues to grow exponentially every year. So people are making their way to OPWDD and through that process.
Thank you.
About the Senate, we have 3-minute follow-up from our chair, Senator Fernandez.
Thank you so much. I wanted to ask for a little more elaboration on the GRACE proposal and what this would look like for a house of worship or any faith-based initiative in working with OASIS.
So this is something that we're in the process of developing right now. We have worked and listened and heard from others who have faith-based initiatives across the country. And there's really a variety of ways. You know, there's a one-time way, there's a year-long curriculum. So part of what we're going to do is make sure that the faith community knows that we exist, our system exists, knows the resources that are available in their community, and then listen to them about what they want and how we can best support them.
So this is OASIS offering resources. There's no funding that the faith-based institution could receive, right?
Right now there is funding, it's in state operations, but we see this really as the beginning, and then again, hearing from the faith-based community about what their needs are to build off of.
Amazing, Grace. But the joint license, would love to know the collaboration between OPWDD and OASIS when it comes to people not only with co-occurring disorders, but anyone with a disability that might have an addiction.
Yeah, right now the work that we're doing is really closely with OMH in terms of the joint license, a single license. That's what we've heard from the field, really about the need, and we know that over 50% of the people in the OASIS system have mental health conditions, so that has been our focus. I mean, of course, we also work with OPWDD to hear about what the cases are, what the issues are, but really our focus has been on OMH just because we know from data that that's really where a lot of the need is, at least right now, and then, again, continue communication with OPWDD.
Great, thank you. I think that might be it. Thank you.
Thank you, Assemblymember McMahon. Anderson?
No, I'm
Oh,
here.
I'm sorry. Okay. You're in the
Thank you,
wrong side
Mr.
over there.
Chair. I'm
Okay.
here. And thank you, commissioners, for being here. Commissioner Bear, I too would like to talk about housing in the Crow list, not surprisingly. I appreciate your testimony regarding the 122 new units that were brought online and moving 900 people into certified residential opportunities. But when I talk to constituents who are aging parents of adults with IDD, housing is the most frustrating and challenging issue for them, even though, as you noted, it is of paramount importance. And as a parent, I can't even imagine the psychological burden of thinking what is going to happen to my child when I'm gone. But that is the reality for aging parents of kids with IDD. That's where they are. So other colleagues have talked about the Crow list. So you've said there's about 4,300 people on it. I think it would be helpful for us to know, like, regionally where those people are placed and priority too, not to mention just the number of opportunities and vacancies. I think we don't really have a baseline and a starting point to figure out, like, how big is this problem. So I would hope that we could collaborate on getting those numbers. I don't expect you to have all that data at your fingertips now, but I would really like to dig into it a little deeper with you if we could do that.
Yeah, absolutely. And we've talked a lot internally about really the need to be much more transparent about what those numbers
Mhm.
are. They are so complicated and nuanced, and
Yeah.
we have such outdated reporting systems, right? There are so many caveats
I
to
get
each
it.
number,
I
but
know.
absolutely working on a
Yeah.
more reliable way to
Yeah,
report those so that
that
we
would
can
be
make
great.
them
And at
available.
what point does that number on the Crow list become so significant that you must build more housing?
Yeah, no, well, it's an important question because we have the housing, right? We have vacancies in our nonprofit providers that are it's actually a higher number than the people waiting to move
Uh-huh.
into those vacancies. So it's not about building more
Uh-huh.
buildings. It's about
Okay.
making sure we have the right staff with the right training in the right locations to
Okay.
provide sort of the changing continuum of services that are needed to meet people's needs. So that's really where we're more focused. And also
Okay.
moving people into the community instead of relying on that as heavily as we
Yeah.
have historically.
Okay, I've got like 30 seconds left, unfortunately, but I wanted to talk a little bit about self-direction, and it seems like OPWDD is encouraging that where appropriate. And are there legislative or administrative measures that OPWDD can do to ensure that people can live successfully and safely in those settings? For instance, regulations about medication administration in non-certified homes. Also, uh, designating personal care staff or house manager staff as categories of staff that can be put under a self-direction budget.
Good one.
My most important question I will not get to ask, but thank you.
Happy to meet with you and talk
Assemblymember
about all of
Anderson,
those.
right here. Assemblyman Palmisano.
Yes, I'm here. First, thank you to both of you for what you do and your people do for our communities and our state. Commissioner Bear, my question is for you. I have a strong passion for the quality of life and quality care for individuals with developmental and intellectual disabilities and the direct support professionals that care for them. I worked as a direct care worker back in the 90s. I know now they call them professionals, and thankfully, because they are. I worked 2 summers at Summit Developmental Center in Tupper Lake. My older sister, Teresa, spent her whole short life serving individuals with developmental disabilities. The reason I bring that up is I've seen firsthand the direct impact to improving the quality of care and quality of life these direct support professionals have for our most vulnerable citizens. And with that in consideration, I mean, we've talked about the 2.7%. We know there continues to be a growing gap between the minimum wage and the living wage for people working in our not-for-profits serving individuals with developmental disabilities. That gap's going to grow with indexing of inflation. It's going to grow more if we don't get up to the 2.7%. We see the disparity between someone working at the state level versus someone working in a nonprofit. I think the starting wage is $5 to $7 difference. With that in mind, and I'm heartbroken because I've talked to people who work at or work at not-for-profits, and they have to leave. They want to be there, but they have to go. They go work at McDonald's or Burger King because they can make more money for their family, and that's just something's just not right there. But knowing this gap exists, and a lot of people who are working in these not-for-profits, some when they don't make that living wage, they're relying on public benefits like HEAP, WIC, SNAP, TANF programs. Has there ever been a cost study to see how much is being spent on these programs for workers in these professions and see how we could save it? And if there hasn't been, maybe shouldn't that be something we undertake? Because we could say, it seems like it'd be better to pay them a sustainable wage rather than paying for public benefits. If there hasn't been a study, has there been? And if there wasn't, shouldn't we look at that and see when that makes sense?
I think it makes a lot of sense what you're saying. We have close to 500 separate not-for-profit agencies that have their own individual staff. So a data collection exercise like that would be incredibly robust, but worthwhile, right, to understand what those direct support professionals are relying on in terms of benefits. I just want to address the delta between what we provide in salary to our state operated DSPs and on the nonprofit side has closed so dramatically. There are pockets of the state where they're the same, or the nonprofit provider starting salary is even more competitive, and that's thanks to all the investments we have made. So it's certainly something we look at. We don't want anyone to rely on public benefits when they don't have to, and as you noted, is just the most vital workforce in the state.
Right, and I know, like I said, budgeting is about priorities. We have tough budgets. I just think our most vulnerable citizens, like individuals with developmental disabilities, should be our priority when we can look at other program fundings like the
Thank
Empire
you.
Phillip tax credits. It's $800 million that we're spending. That would be better for our individuals with developmental disabilities. Thank you.
I'm going to have to stop you. Thank you very much. Assembly.
Assemblyman Burrows.
Good afternoon. This is for Commissioner Cunningham. You said that your counties are giving a report of 2.3% of counties that are updating your system and letting you know who's applying for the mental health money that was given through the state. So of the 2.3, do you have the counties that are not giving you that data?
Yeah, so I just want to be clear. So when we talk about the opioid settlement funds, the dollars that come to OASAS, we have 100% transparency in the reporting. I'm talking about the dollars that go straight, do not go through OASAS, that go to the counties or to the cities. So now they're required to report to us, and 40 have reported to us, 22 have not reported to us. So we put the information on our website for those that have reported to us.
Okay, so those that are not reporting to you, do you try to make communication with them? And if you do, and I'm sure you do, are they giving you a good explanation as to why they're not?
Yeah, I mean, I certainly can get the details about the communication, but we do not have the authority, right, to sort of oversee this. We post what we're given, but
I think that's good while we're here, because that's some of the reasons why I'm here specifically. If there's a way that I think that we could work together to, implement processes where they have to give it out, because I know specifically in my county, Nassau County, county executives has, I think, given out only $5 million of $100 million towards the mental health and opioid addiction agencies, and I think that's a travesty. And I just wanted to know if you knew the counties that were cooperating in a sense. And
we can certainly get that list to you. And again, this information is on our website for the counties that have given us information. All of that information is on our website.
Okay, it's just, I think, when we look at what we're doing, and especially in this situation, in this instance in particular, where we're saying we're helping out individuals, but we're not actually applying the money to where it should be. And, we're calling ourselves elected officials, but to not, give that money out to where it's needed, and now want to run for a higher position, I think is a travesty. So I just wanted to know if, you were in communication with those people. So, thank you.
Yes.
Assemblyman Burdick.
Thank you, Chair. And this is a question for Commissioner Bear. And I first want to thank you and your team for the great work you're doing. And I'm really delighted about the governor promoting her executive order for making New York an employment first state for people with disabilities. And I wanted to talk a moment about the work that we're doing with your office in terms of the closed residential facility in North Salem and possible conveyance to Arc Westchester to develop it as a new certified residential facility. And in the hope that this might be a model, a pilot for other closed facilities. And I understand your agency is working on procedures, and I appreciate your updating us on the status of that, and particularly whether there's possibility of providing support to such potential providers, because if they don't have title, they can't get funding even through a CREST grant or other abilities, other programs that might be available. And also the reimbursement rates that would be commensurate with high needs individuals.
Yeah, so you know that as a state operated healthcare system, OPWDD has a pretty vast physical plant footprint throughout the state. There's been historical resistance to getting rid of those buildings that are no longer being used, particularly campus based. I feel very motivated. This governor feels motivated to make better use of space, community space, and tax dollars. So we have worked this year, as you note, putting together an internal process for how to take the steps to move that surplus property along, including the one that you referenced with the Arc of Westchester. So that's an internal process document that we're working on to make sure that we are being the best neighbors and the best stewards of tax dollars and of those properties, and excited to work with the Arc of Westchester.
And so could I ask you, will it address what I was asking about in terms of reimbursement rates and possibility to help with feasibility as to what should be done with the facility? Should they be demolished and replaced, that sort of
Yeah.
thing?
I think to the extent that any of those buildings end up being transferred to our nonprofit partners, we would absolutely have to think about what that timeline looks like and how to line up those processes so they're not in a catch-22 like we've experienced and you've outlined with
Right.
with the ARC.
And do you have any idea when these internal processes might be finalized?
They're close.
Okay.
We have a draft. We've actually started implementing them. The very first step is to make sure that OASAS or OMH, as the mental hygiene counterparts, don't want access, and they have a need for buildings and properties as well. So we've created that first step to move lists of properties to our partner agencies. We've had them come and take a look at some of those, right? So this is
Super.
new process for us, already up and running.
Thank you so much. Appreciate it.
Thank you.
Assemblywoman Simon for a 3-minute follow-up.
Got it. Thank you. Sorry. So, Commissioner Bear, so a question that my colleague wanted to ask, and that is those individuals who are in non-certified group homes, when the key participants in their circles of support are no longer able to provide that support for them, whether it's parents or others in their orbit, what happens, and where do we go from there? How can we, make sure that people don't end up, falling off the edge?
Yeah, that's the hardest question, and it's the most heartbreaking part of my job. We, in our evaluation of the self-direction program, asked that question of our consultants, and there are some recommendations in there about how to make sure you're building out more natural supports and a bigger circle of support for someone who wants to continue to self-direct but maybe can't rely on that natural support anymore. Also a question ongoing right now with our Commissioner's Task Force on Aging in general, not specific to self-direction, but in general, when you are an adult who has been provided caretaking by a parent into late in life, right? What is the best plan for you? This is the first generation of seniors with developmental disabilities. So this is a sort of a novel issue that not just New York is facing, but every state. But we are very focused on trying to identify some solutions for that what aging creates across the board, whether it's self-direction or not. Yeah. I know you want me to give you
An answer.
the answer,
So it's a work in progress.
as is everything.
Well, I would just say there are a number of legislators who are very interested in this issue and would like to be part of that conversation. If we could have those
Welcome.
conversations going forward, that would be great.
Absolutely welcome the partnership.
Thank you.
Assemblyman Steck for a 3-minute follow-up.
This question is for Dr. Bear. With respect to the sub-minimum wage, is it fair to say that most of the people who are so employed are doing piecework?
Yeah, 14C exemption.
And
relates to piecework.
piecework can produce extremely low wages. Is that correct?
Yes.
And you're familiar with the program known as Living Resources?
Yes, I am.
And is it fair to say that many of the people who could, who are doing piecework for sub-minimum wage might enjoy the benefits of a program like Living Resources?
Sure. I think we have people working for sub-minimum wage throughout the state that are meaningfully engaged in that job that they show up to every day, and it gives them something to do and feel good about, right? So as a state, our job is to figure out how to transition that cohort of people into a competitive wage environment.
Okay, and is there any evidence that these jobs where they're being paid $2 an hour because they do piecework are leading to a competitive wage environment?
There are some people that I just met with last week, actually, that introduced me to folks in their programs that started out doing piecemeal work
Mhm.
for less than minimum wage and got that confidence, got those vocational skills. It's not going to work for everyone, and I'm not pretending it will, right? But that's why, as part of the Employment First work, we need to create other pathways for people so that we can transition away from the sub-minimum wage for
And
those.
isn't it fair that programs like Living Wages do give people, or Living Resources do train people so they'll have job skills that they might use in a competitive environment without having to go through the sub-minimum wage? Isn't that fair to say?
Absolutely. It's part of our continuum of employment services to meet people where they are.
I think that covers it. Oh, no, there's one other thing. Some of the parents actually have come in and argued that they wouldn't have anything else that their children could do if they didn't have sub-minimum wage jobs. Do you think that's accurate? Or do you think there are other programs they could be engaged in?
I think there's absolutely alternatives for people. I remember my mother-in-law, when we closed sheltered workshops, thought there was nothing else my sister-in-law would ever be able to do. And she gets a ride to work every day, is competitively employed, and loves that for herself, right? So people are capable of so much more than we know.
Thank you very much.
Thank you. I am Assemblyman Santa Barbara. 3 minutes.
Thank you. Yes, just Commissioner Bear, just to follow up on our discussion about the wait lists and housing. Just wanted to ask, is there anything in the budget to support innovative housing options and opportunities? We discussed some of those proposals in the past that people have had difficulty with because of the regulatory structure, because it didn't fit inside what I think is an outdated regulatory, not updated to modern times of what people are preferring for more options. We talked about various places that I visited across the state. So I wanted to know if there's anything we could do with the budget to support options outside the normal structure.
Yeah, there's nothing in the budget that specifically is entitled innovative, right? Which we've had previously. We've had a lot of pilots and learned a lot of lessons through those. We do have $120 million of new service dollars, right? And we provide housing subsidies to people to live in the community every day. I think people are creating those innovative models all the time, whether we have a dedicated line item to it or not. And we've talked about my commitment to making sure that people have as much choice, as much flexibility as we can within the structures that we need to live within to be a steward of Medicaid dollars. But that innovation is happening all the time.
And I do have legislation that I think already passed in the Senate, and I'd love to have your support on it because it actually does expand some of the innovative housing opportunities. We had a hearing with the committee not too long ago, well attended, and everybody was talking about the same thing, more options outside that regulatory box that we've seen in the past. I wanted to just make you aware, and this is the Center for Disability Services. I talked about their issues earlier in the hearing. The governor talked in the State of the State about the health equity study conducted by Department of Health and the Office of Chief Disability Officer to collect data on healthcare access and the outcomes for people with disability. And that's going to be used to close the gaps and improve health quality. In 2024, there was an issue in the state budget. The legislature passed a $10 million add-on to clinic rates that primarily serve individuals with disabilities. And half that was coming from New York State, half from the federal government. And that money has not been added to the rates. It's 2 years now. So Greg Sorrentino at the Center for Disability Services, they're having a lot of other issues. I told you the psychiatric services have shut down. But this as they wait for this, this is causing other problems for the population that they serve. They haven't seen a rate increase since 2007, and this would be a good step in closing that gap. So want to make you aware of that. Just ask if anything's being done from OPWDD to help move this along so they can get their funding.
Yeah, no, we're definitely aware of it. That clinic is licensed by the Department of Health, not by us, but as you note, serves primarily people with IDD. That rate enhancement was submitted for approval to the federal government by the Department of Health and is waiting approval there. Yeah.
Thank you.
We have completed the list of people who wanted to ask you both questions. So thank you very. Oh, excuse me. You have one more.
Well, you didn't go on the list.
Well,
Assemblywoman Zimmerman.
All right, here I am. Good afternoon, everyone. Thank you, chairs, for allowing me to ask a question. Commissioner Bear, very nice to meet you. I actually have two sets of questions. One is around transportation, and the other one is around workforce development. If you could just go over what tools you use to identify the transportation barriers that our New Yorkers are experiencing, and then once it's established that people do have significant barriers to transportation, do you then track specifically their missed medical appointments, employment opportunities, and other barriers to their lives? And then I want to talk about later how we can help each other to make that happen. So with regard to workforce development, how do you currently assess and address the workforce career development needs of people with disabilities? And I really am interested because I know we have a wonderful career exploration programs, but I really would like to know at what age that you actually start. And then I'd like to talk to you a little bit about what I would recommend, what age I would recommend that we would start as well. So those are my two sets of questions for you today.
All right. Well, it sounds like we should schedule a
We
sit
should
down.
definitely schedule
In
a
terms of
sit down.
transportation, it's such a great question that I don't have a great answer for because there are some of our services that include funding for transportation and many that do not. And we definitely recognize that transportation comes up as almost the number one barrier for people to have access to employment specifically, but also community integration and healthcare services. So our care coordination organizations do collect data about things like missed healthcare appointments and the needs for things like transportation. But there is not a great way now where we're connecting that information with the counties and the entities that control funding for transportation, right? And is certainly something we've highlighted internally and with my partners in state government as something we really need to dive deep on. So it's a great question without a great answer. Workforce
Development, yes. So we have these wonderful career exploration programs, but I want to know at what age do you actually start targeting those programs to individuals in schools?
So students are entitled to stay in their education until they graduate or till the age 22, right? And so we've been working with schools and providers of certified residential school
Elementary,
programs.
middle, or high school?
High school.
Okay, we're going to lower that. So let's talk about
Let's
that
talk.
later on. All right, thank you. I yield my time.
Thank you, Senator.
To say that you have completed everyone's questions, and we thank you very much for your work on behalf of the state of New York every day and your agency's work. And we excuse you to go on with the rest of your day while we call up Panel B, the New York State Conference of Local Mental Hygiene Directors, the Mental Health Association in New York State, the National Alliance on Mental Illness.
Another
That's
person.
Panel
goes-
B.
Everybody's falling down these stairs. It's the second person.
Oh, again.
I just do high heels, you know.
Okay. All right. We've had 2 stair falls in 2 days. Everybody must be very careful going up and down the stairs.
She's not wearing high heels either.
She has a little bit of a high heel. Yes.
That's next.
I think we're supposed to do Justice.
Oh,
No.
wait. I apologize.
Lisa Marie's next, so.
I blew it. I'm so sorry. Thank you, Ian. This is why you have staff to trust. Because you can't, because I can't be trusted. So I apologize. Hope nobody fell in vain. We are now going to have the New York State Justice Center for the Protection of People with Special Needs, Maria Lisi Murray. And you did fall, didn't you? So I'm so sorry. Because you knew
Yes,
you were
ma'am.
supposed to be here. You
I
were
was
like,
ru-
no, no, no.
I was rushing
She's wrong.
down.
I'm going down there. So thank you.
So it's a heck of an entrance. I'll own it.
Okay. Make sure you're settled in and comfortable. Okay. Good. All right.
Okay.
Okay. And you have 10 minutes, and then we'll ask you questions. Thank you.
Thank you. So good afternoon, Chairs Kruger, Pretlow, committee chairs, and other distinguished members. My name is Maria Lisi Murray, and I am the Acting Executive Director of the New York State Justice Center for the Protection of People with Special Needs. Thank you for the opportunity to testify about Governor Hochul's fiscal year 2027 executive budget and share updates on the Justice Center's work. At the heart of the Justice Center is a simple but powerful mission to create a safer, more inclusive New York for all. With Governor Hochul's investment and support from the legislature, we will continue our efforts to advance that mission. Over the past year, my main priority as acting executive director was to listen. I traveled across the state, listening to state agency colleagues, advisory council members, legislators, providers, people receiving services, their families, and my staff. I heard their stories and their challenges and focused on identifying where my support could be the most helpful. Through these conversations, my goals for the agency became clear. Prioritize process improvement and data sharing, increase engagement and collaboration, and heighten our focus on prevention and quality. When I met with agencies and providers to see their work firsthand, I recognized, and they shared, the need for more efficient case processing to help reduce administrative burdens. These visits helped me better understand the daily realities of those providing care and identify powerful ways to modify our work. We updated our online reporting form and piloted new options for video interviewing. We launched a new quality management dashboard to help providers identify the information needed to move cases forward. And we reorganized our office structure, creating a new region downstate to better distribute our workload. These changes led to big results, reducing systemic burdens and allowing us to close 1,600 more cases in 2025 than the year before. Through these listening sessions, I also heard the call for increased training to support those who interact with New Yorkers vulnerable to abuse, groups the Justice Center exists to protect. That's why I made workforce training and quality control a key focus this year. We expanded our law enforcement and first responder training offerings to include district attorneys' offices and educated more than 700 professionals in 2025 alone. We developed a new trauma-informed investigations training that teaches participants how to conduct more effective, person-centered interviews. And through our annual Justice Center Summit, we convened more than 2,300 state agency and provider staff, creating space for learning, dialogue, and reconnecting to the shared goal of protecting people in state care. My dedicated staff also continued to support system-wide quality control measures, conducting 300 audits of service providers. These audits strengthen accountability by assessing whether agencies implemented necessary actions to address abuse or neglect. From conversations with people receiving services and their family members, I've recognized how much they value our advocacy role during challenging times. Through roundtable discussions and resource sharing, we have developed deeper relationships with parent and family groups and found better ways to address their needs. The Justice Center employs a team of skilled advocates that answer questions about the investigative process, accompany victims to interviews, and connect families with relevant services. In 2025, our advocates engaged with more than 5,000 people and families across New York State. The stakeholders we have engaged over the past year share in our commitment to preventing abuse and neglect in the service system. I know this because providers have sought our data so they can identify areas for improvement independently before incidents occur. Our fellow state agencies want ready-to-use abuse prevention tools and training programs to bolster their broader educational efforts. And families want more advocacy resources to equip them with the knowledge they need to keep their loved ones safe. Governor Hochul's budget proposal allows the Justice Center to continue these abuse prevention efforts and respond to these requests. To date, Governor Hochul has supported the Justice Center's launch of a work group that leverages the expertise of Justice Center staff to identify trends that help prevent incidents before they happen. And in the year ahead, we will expand these efforts by continuing to gather input from those connected to our mission, including other state agencies, family members, providers, and people receiving services, to develop prevention solutions based on data and emerging needs. These solutions will decrease burden on providers by offering resources they can implement right away, increase knowledge and education for direct care workers, and strengthen our outreach to people receiving services and their families. The goal, keeping people safe. This work underscores our role not only as an oversight agency, but as a driver of system-wide quality improvement. Taken together, this direction for the Justice Center's future, along with our accomplishments this past year, tell a clear story. We are closing cases more efficiently, engaging more deeply, and investing in prevention to create safer systems. Guided by a strategic vision that honors our history and anticipates our future, I look forward to listening, learning, and addressing the needs of our stakeholders. Before I close, I'd like to thank the dedicated Justice Center team for their work to move the agency forward, the many agency, provider, and family groups that inform our direction, and Governor Hochul for her continued investment in our nation-leading protections. Thank you for your time. I'm happy to answer your questions.
Thank you very much. Senator Fernandez to start.
Thank you so much. Sorry, I don't have my notes in front of me right now for you, but how has the Justice Center continued to protect individuals that may have been harmed by employees? And do we see these employees still within the scope of this work after an incident has occurred?
Right, so the Justice Center's core mission is to investigate allegations of abuse or neglect in the jurisdictions we protect. So when there is an allegation of abuse or neglect, we do identify who the specific individual or subject could be. That investigation is completed. And if there is sufficient evidence, that allegation can be substantiated. And depending on the category of allegation, that individual could receive additional training, guidance. Was there a second part of your question?
Yes, like say there is an employee who has been found to have abused, hurt an individual, and they are removed from that position, but are they still able to come back into this field of work knowing that there was an incident that a patient was harmed?
I apologize, I misunderstood your question. So only in the circumstances where an individual is substantiated for what we call a Category 1 finding, which is the most egregious level of abuse or neglect, like sexual abuse, significant physical abuse. In those situations, that individual could be placed on our staff exclusion list and therefore not permitted to return to work with the populations that our agency protects. That really is the only instance where the Justice Center makes decisions with respect to hiring or placement of employees. Those decisions really lie with the providers.
Thank you. No further questions.
Sure.
Assemblywoman Simon?
Thank you. Thank you for your testimony. I have a couple of questions, and I'm very happy to see the work that you've been doing to reach out to stakeholders and expand their engagement to improve the work of the agency. I'm curious about you talked about expanded training of first responders, and I'm curious, and DA's offices. Who does that training? Who is it? Your agency? Is it people with your agency? Is it outside contractor? And what once you do training, having done training myself, you do a weekend training, and then what happens after that? Is there follow up? Is there ongoing support, for example, in that training?
Thank you for that. So it is the Justice Center training staff that typically offers this training. This is the first responder outreach I talked about last year, where we are trying to provide information and tools to first responders in the community who are responding to community residents where individuals with disabilities may live. We are trying to assist them in identifying when they respond to a home that there may be individuals with disabilities, and understand the environment in which they're, responding to, and how to, respectfully communicate the individuals who are there, and how to identify if there's potential abuse or neglect occurring so they can report to the Justice Center.
So I guess another question I have, as you mentioned it briefly, is communications. Some of the people who are, of course, in state care have significant communication issues. They also have, other languages and cultures issues as well. How much of your training addresses those issues, and does it vary by region? Where, for example, you have certain groups of folks. There are a lot of, Somalis, for example, in certain parts of the states, and other parts of the state, you have people from other cultural backgrounds. In Brooklyn, we have a lot of Haitians, for example. We have, a lot of Latinos. We have a lot of South Asians. How does your training vary to address those issues?
Absolutely. Thank you for that. So we do have obviously a language access office. We can translate any of our materials in, a language that's requested. We have a individual and family support unit that offers, advocacy and support, and can assist individuals if they require additional language access or support or training. We can absolutely do that for people.
Great. And I'm also curious how many, maybe probably a relatively small portion of the population of people who are being served by the state who are deaf, or those, for example, with developmental disabilities who may be in state care with family members who are deaf. The communications in that regard, usually they're less frequent. So I'm curious whether that's part of your part of your agency's work, or whether that just hasn't really come up.
No, I completely understand and appreciate this question. One of the I think less known areas that the Justice Center oversees is what we call our trade program. This program assists individuals who have disabilities, issues with being able to articulate themselves. Our programs can connect those individuals with assistive technology to better facilitate communication. So we do utilize, the 12 sites across the state to make sure that people are getting connected with technology to help them in that regard. But specifically with respect to deaf services, we absolutely have the ability to locate translators and make sure that these people have access to Justice Center services.
Okay, great. And you also mentioned a new trauma-informed investigations training that teaches participants how to conduct more effective person-centered interviews. I think one of the issues that we tend to not recognize very often is the effect of trauma on people's lives. whether it's this population or it's even the population of people who are providing that care. Can you tell us a little bit more about the trauma-informed and how that differs? Because it's clearly something that we'd like to make sure other agencies also address those issues.
Absolutely, thank you. So when we talk about a trauma-informed investigation process, we talk about specifically not requiring somebody who is maybe subjected to sexual abuse to multiple interviews. You don't want to re-traumatize the individual to the extent things can be coordinated. So if law enforcement needs to be involved and Justice Center investigators are involved, we really do try to be sensitive to how we conduct these interviews. And that's just sort of a piece of the focus that we use.
Okay, great. Thank you. Yours is a unique agency that I think probably a lot of people don't know very much about. So, number one, do you want people to know more about you? Or do you really like being like, on the down low? But I'm also thinking about workforce development, people who want to go into this kind of work, or what you do to partner with others who are doing workforce development to either help with, getting the right people in those jobs, so you're not doing as much investigation work?
Thank you. I love that question. I absolutely do want more people across New York State to know more about the Justice Center and what we offer. We are a one-of-a-kind agency in this country. We offer protections and services that no other state has. I have spent a lot of time over the last year, as I talked about in my testimony, going to meet with providers, meeting with my sister agencies, trying to understand better how the Justice Center can, leverage its experience and data over the last 10 years, understand better how we can serve and, support our workforce. So I very much so, hope to make the Justice Center more well known, and encourage people to avail themselves of the services that we offer. New York State has, I can't say it enough, nation-leading protections for vulnerable persons and advocacy services for families who have, vulnerable people in their lives that they love. So we're very happy to be known and leveraged in any way that makes sense.
Great, thank you.
Thank you.
And so next year you'll be going on the road nationally to tell everybody about it?
I have spoken at an Adult Protective Association event in New Mexico, and we have spoken to other states who are extremely interested in our model and our statute. So we are gaining traction, but as always, New York is leading the way.
Great. Thank you very much.
Thank you.
Thank you. Our next questioner is Senator Canizari Fitzpatrick.
Thank you, Chair.
Oh, I think I've got it.
I have to admit that I'm not familiar with exactly what the Justice System Center does. I understand that you're trying to protect people with special needs. Does that include individuals in, say, a group home who have a developmental disability? Does it cover elderly people that are in a nursing home? Who actually comes to you for services?
So our jurisdiction is set by statute, and it's extremely nuanced. We don't currently have jurisdiction over nursing homes. If there's a specific entity you want an answer to, we can absolutely have a conversation. I can get you that answer.
I have had many people come to me when a loved one is in a nursing home and they've suffered abuse. And if this was a resource that you would step in and help the family, it's certainly helpful for me to know that. But so to my nursing home question, you said no, but what about people that have developmental disabilities that are, say, in a group home and maybe are abused in that situation? Is
Certainly,
that something that they would come to you for?
Certainly in certain circumstances, we would have jurisdiction. Again, it's just highly dependent on the state agency that has oversight, whether it's, licensed, certified, or operated by that state agency. Bed counts, what the specific services are. But again, if you have a specific entity, we're more than happy to get you that specific answer.
Okay. So in your testimony, you said that you allowed, that the results of their changes allowed us to close 1,600 more cases in 2025 than the year before. So contextualize that for me. How many cases on average would you close so that we now had 1,600 more cases in 2025?
Well, certainly. So it varies year to year, but as I spoke about in my testimony last year, we implemented some new process changes, and those process changes included increased use of what we call our 3BDR, our 3-day business day review. It's a model that providers have been very excited about. And what that means is when we get an allegation of abuse or neglect that comes in, we have this specialized unit that takes a look at the allegation, obtains all of the documentary, evidence, the typical things we would require. It enhances our categorization and making sure that we're doing it more efficiently, and moves the case along faster without impacting quality in a negative way. So, when I said 1,600 more cases, that is 1,600 more cases this year as compared to last year. And we continue to make process improvements to ensure that we're moving along more efficiently. But
So
without
in 2025, how many cases in total did you close?
we closed. We closed total abuse and neglect cases 11,500, and that's up 1,600 from 2024.
Okay, and when you consider a case closed, does that mean that you've investigated, assisted the family, and there's been some resolution to the abuse allegation that was made? Is that correct?
Yes.
Okay. You also testified that you educated more than 700 professionals in the law enforcement first responder area. Last year, I believe your testimony was it was about 200. That's a tremendous increase. What do you attribute to that to, and are there plans to expand that even further?
Thank you for that. So last year, the program was new. It was something that I implemented as the new acting executive director for this agency, and it had only been in existence for 2 or 3 months at that point. We were just getting started. So over the course of this 2025, we were able to expand our offerings. We were able to, I think, really get the word out in terms of what value this training could offer the first responder community. And I think it's been met with a lot of positive reaction.
Okay, great. One last question. You mentioned also that you had roundtable discussions, and I was curious who participated in those roundtables. Were they law enforcement, administrators of facilities? Who did you speak to gather the information that you did?
Are you asking specific to the first responder training, or?
Yes.
Okay. So when we gather that information, what we do is we utilize the skills of our investigative team internally, and we also utilize the skills of our advocates internally, because oftentimes we found that the need for first responders is to bridge the gap in understanding about the community with which they may be, serving and encountering in our communities. So,
thank you.
Thank you.
Thank you, Assembly.
Assemblymember Simplowinski.
Thank you, Chairman. And I sort of want to pick up a little bit on what Chairwoman Simon was saying, where this is something that isn't very well known. So I wanted to illuminate sort of how some of the process works. Am I correct that sort of the purpose of having you separate from other agencies is to maintain independence so that the investigation is fair? Is that a fair statement?
I think that's fair.
And how do you what processes do you use to maintain that independence so you get a fair outcome for people that may have been victimized?
Well, first and foremost, we are the oversight agency, and when we conduct an investigation, it is, based upon the facts of that case. When I talk about roundtables and meeting with my sister agencies we may have oversight over, those aren't case discussions, those are process discussions.
Okay.
We are looking for ways to reduce duplication and make sure that we're communicating in the best way possible. These aren't case-specific discussions.
Okay. And then obviously when you're doing an investigation, that probably takes a lot of legwork. You got to get into some, very, in this case, very sensitive situations. What procedures do you use to get access to witnesses or evidence because it's a little different from if you were a DA with a subpoena or something like that. How does that work to get the facts of the case so that you can adjudicate it fairly? What procedures do you use?
Sure, absolutely. So as I said, our intake office will take the report of abuse or neglect, and at that time it will become, categorized. We'll have a general idea in terms of what is going on. We do have relationships with the providers, and they are required to provide us the documentation that we need. Most frequently, we want to look at care plans, we want to look at schedules, and we do have, I think, excellent participation by the providers. They give us what we need, and honestly, we're entitled to it. So we assemble our documentation up front. Our investigative staff will take a look at what we have at that point and then schedule, interviews. We'll interview the witness, interview the potential subject, and interview anybody else who may have seen what had happened, and ultimately, obviously, interview the victim. And it's a typical investigative process you might find in any other sort of, law enforcement type activity.
So if you're, let's say, in a situation where you're looking at a provider and there's concern that the provider may have had a misconduct, and so if you're relying on them for information, how do you get around maybe that problem where if to get the information to illuminate a situation that maybe they don't want to provide? What tools do you have to do that?
Well, thus far, we haven't had an issue. They're obligated to provide us with the information that we ask for. So it's, we really have not encountered resistance in that respect. And I think it helps to frame also that, like, the providers, the thing that we have in common is they don't want bad actors in the service system. It impacts their morale. People go into this profession in order to take care of people who have, disabilities. It serves the provider also if they are able to, remove a bad actor from a situation, for a number of reasons.
Gotcha. Well, again, I appreciate it. I think it is great that we have the Justice Center. As you point out, it's something that isn't in a lot of other states, and having this sort of independent watchdog. I just want to make sure you have enough teeth to be a good watchdog, to use a metaphor. So thank you very much for what you do.
Thank you. Appreciate it.
Thank you. Senator Rolson.
Thank you, Madam Chair. And thank you for being here this afternoon and talking about the important work that the Justice Center does continually. And I know it is not easy in the work that you do with the special populations that you serve. I have just a process question for you. I know, and I've heard this before, but it's specific to my district. A organization that has been around for a long time, serves many people in different settings, had been getting, their calls were being made to the Justice Center, several dozen calls actually. 10 to 15 were probably specifically related, and I just was curious, because of course, I mean, you get these calls, you have to assign someone, and does there come a point in time within the scope of these calls where it is clear that probably someone or someones have a problem with this particular organization or home that are calling these, and turned out to be, of course, unfounded reports, where there's a threshold that's met where you would be able to either contact local law enforcement or law enforcement contacted by the organization to work with you to stop this from happening and tying up people and also causing a disservice to the group homes and other organizations that are doing the great work.
Thank you for that question. I really do appreciate it. We have, over the last year, really focused our efforts on combating malicious reporting, which is what I think you're referencing here. This has been one of the benefits of sort of reestablishing our relationships with our provider and our agency communities, because when a provider recognizes that they may have an issue, they know who to call, and they know, to let us know that they believe there may be a malicious reporting situation going on. Obviously, when we receive an allegation of abuse or neglect, we have to take that very seriously, but we have to take false reporting very seriously also. It's a significant drain on our provider and agency resources. It's a significant drain on Justice Center resources. And as a result of these communications and really trying to get a good understanding of how to combat this from our perspective, we've developed some new guidance and incorporated guidance into trainings, and we'll be facilitating distribution of this guidance over the course of this year.
Thank you.
Thank you.
Thank you. Assembly. Assembly Member Giglio.
Thank you. So can you walk us through the process of what happens when a formal complaint is made by a parent or a family member to the Justice Center about alleged abuse within a group home?
Absolutely, thank you. So when our our call center receives a complaint of alleged abuse or neglect, and we handle about 90,000 complaints each year that come in through this 24-hour a day, 7-day a week, 365-day a year call center. So it's a busy part of the organization. These individuals who answer these calls are typically, have experience typically in, 2 years or more in the social services field, or have worked for providers under our jurisdiction. So they have, a good understanding of what an allegation of abuse and neglect, looks like. Once they take that and enter in all of the information, as I said earlier, it may very well go through what we call our 3 business day review model. We have found that model to be very, very helpful. We believe that's a significant reason we were able to close more cases this past year. It allows for appropriate categorization of the case and early, evidence review, right before we start the investigation. So it gives us a little bit more of a roadmap. It's then brought to investigations. The investigator will identify, again, the subject, the victim, potential witnesses. What are we looking at? What other records do we need?
Is it the group home that starts the investigation and then gives you all the information that you need in order to make a determination, or are the investigators physically going in and talking to everybody that is involved?
No, when we have an abuse or neglect allegation, our investigators will do the interviews.
Okay.
Yeah.
And do you think that your investigators have the knowledge and the clinical expertise to evaluate these cases? I mean, they're investigators, probably a lot of them are former law enforcement, which I have a tremendous amount of respect for, but do they have the clinical expertise in order to properly investigate these cases?
Yes, absolutely they do. Keep in mind the Justice Center, yes, we have a significant group of investigators, and you're correct. We do often have, investigators who were law enforcement, in a prior career. That being said, we have nurses on staff, we have social workers and advocates. So we do have, a multi-layered area of expertise that we draw from.
Okay, and then there's also been a few complaints, I should say, I'll say a few, but when it comes to transparency during the investigation process and the length of time that it takes, that leaves a lot of families and the individual in the home and also the employees in limbo, because these investigations can take a tremendous amount of time.
Yes, I understand what you're saying. Thank you. That's one of the reasons that we have really looked very critically at our processes in order to ensure investigations are done in a timely manner. I'm always conscious about, we don't want to impact quality in any negative way. But I do hear your concern.
Yeah, and the transparency aspect too,
Mm.
because there are a lot of, when families tell me that they filed a complaint with the Justice Center, and some of them can hold up a stack of 20, which, and then they get a result that no, that's not happening and everything's fine in the home. But with the transparency, do you think that it would be wise to have the complaints come in and have a database that actually has a chronological time frame from when the complaint came in to when the investigator started to when the results came in, so that families can access that information by the case number and see where it is in the process for the transparency purposes?
So let me just back up to the first part of your question, if I can. We do have our individual and family support unit that if you have persons that you're referencing specifically, I would love to be able to connect them with this specialized unit we have in our agency, because these are our advocates and these are the individuals who can provide support and guidance and make sure family members understand what the process in the investigation is doing. We do have constraints in our statute with respect to confidentiality, which we're always very mindful of, and that can impact transparency also.
Okay, thank you very much.
Thank you.
Thank you. I believe I'm the last senator, just double checking. Okay, so I'm going to take mine and then pass it back to the assembly. So one of my colleagues just asked you about the role of the Justice Center and what agencies it oversees, and you pointed out that there's specific statutes that say what agencies do you have responsibility. And you pointed out that it does not include nursing homes. I've thought for many years it should include nursing homes. And I would like your opinion about whether your experience from running the Justice Center leads you to believe that that is a model that could effectively work for overseeing complaints from nursing homes. Because the truth is, we have a growing population of people who end up in our nursing homes. A disproportionate share of them are actually suffering from some level of dementia and or may have had recent surgery that triggered other inability to follow up for themselves, and or maybe just moving down a road where they really can't make the right decision for themselves, and they may not have family either nearby or who can take this role. I think probably as elected officials, we all hear from families who say, I'm very worried about what's happening to my family member in X nursing home. I don't really have a way to follow up for myself. I don't have a way to take them out of there or come up with a different location. And I'm just worried. They'll just say, Senator, I am worried what is happening to my family member. I don't think they're capable about articulating the things that are going on, but I come to see them and they seem to have all kinds of damage to themselves that's happened that I can't really understand how they could have been hurt that way. They seem to be very emotionally upset, literally incapable of even articulating how upset they are and how much they think is going wrong. I don't know whether it's people who are working with them, other people who are in the facility and just don't have the capability to control their own behavior. And we know it's a growing percentage of our population that's ending up at these ages and in these conditions. And I just am really very worried that New York State has not come up with the right answer about what we should be doing to do follow-up. So I'm curious, from your expertise, do you think we could expand your statute, maybe make some changes when you're dealing with a new form of facility, and address this concern via your agency?
Thank you for that question. So in terms of any proposed or pending legislation, I couldn't comment specifically.
Right.
I will speak a little bit to what we do and that, for instance, we do have a podcast, and we do have a blog, and these focus on prevention. And our most recent podcast focused on safety checks. So, there's parallel there, right? Where you have an individual who's maybe nonverbal, but you have staff who are conducting safety checks when they come on shift, when they go off shift, in those circumstances. And it helps you to identify if injuries are occurring, what the timeline might be. I mean, I can understand why there are parallels, quite frankly, to what we do every day and to the question you posed.
Okay. So, you're right, I'm not asking you to comment on a piece of legislation.
Understood.
Right, but I'm asking, given your expertise in working in this field, probably more than most anyone I could find, because as we point out, most states don't even have an agency like this for a sub-universe of folks who need special help, that there's almost no one better to turn to than your agency for opinions about how we would want to replicate, or perhaps not exactly replicate, than when working with nursing homes. So, I'm going to continue to ask, even if you can direct me to other people who have written about these issues and have made recommendations for what we think could work in New York State. Because I very much do want your agency's opinion about what do we think we ought to be doing about this situation. It's a real situation. It needs to be addressed in New York. And based on the numbers of people living longer and hence living with more issues as they get older, this is just going to become a bigger and bigger issue for us. And I just hope we don't spend too many more years refusing to do the things the advocates are asking, when in fact there may be something we absolutely could turn into a full-fledged solution for ourselves in a relatively short period of time. So I will just keep bothering you on that. So thank you very much.
Thank you.
Thank you. Assembly, I believe it is now your list.
My list, Assemblyman Brown. Is okay. Assemblywoman Zinnerman. Assemblywoman Griffin.
Okay. Thank you for being here. Thank you, Chair. I appreciate your focus and the strides you're making on workforce training. It's very impressive that over the last year you've even doubled your training to first responders. And that's the area I'm interested in. I represent a number of municipalities that their police departments have their police departments have invested in training for some of their officers directed at people with special needs and also older adults in cognitive decline. And the training is rather costly, so it's not widespread. It's not like everyone in the office gets it, in the department gets it, but they pick out certain people. And of course, they'd like to expand it. And I do think I've been at events where they demonstrate what they do, and it is like you can see that it would be effective. There might be an autistic young man that there's one man that I know in particular. He walks a lot. He loves to walk around. He's very big, and so his mother used to be concerned that he would perhaps get into trouble because someone would maybe think he was up to no good. So it made a big difference when that local police force got some training, because it really helped this young man. So one thing I'd like to know is this training isn't the Justice Center training. And I don't know specifically the name of their training, but it is expensive, and it seems like there's an investment in a cost investment. And I wondered, is the training that you offer, do you offer similar training, and is that training available, and do they pay for that as well?
Thank you for that question. We do offer similar training. Our trainings are free. Most of them are offered via like WebEx or an online platform, so they're cost effective for us to deliver. So if you would like to reach out to our office, or we could reach out to you, we could absolutely connect, you with those resources, and you could offer it to them.
Oh, that's great. And also, a second question on a follow-up is I know like your job is pretty immense and it's covering the whole state. Are there any staff that do outreach in certain areas to let these different departments across the state know about this training?
Absolutely. We're still developing this. It's still a relatively new program. I myself, being a former police officer and investigator, have utilized my contacts to ensure that that the message gets out as far as it can, because I do think it's a fantastic resource for first responders.
Thank you very much.
Thank you.
Thank you, Chair, and thank you for your testimony. So let's consider an individual with autism and a police officer without training in recognizing a neurodiverse individual may mistake noncompliance with disorderly conduct and so forth. I understand that in New York State, standards and training for police academies and most other law enforcement agencies are set by DCJS through Municipal Police Training Council. And I'm just wondering whether any thought had been given to including neurodiversity training in the curricula in police academies, and whether you've worked with them about this, whether this is something that might be helpful, and if so, how it might be accomplished.
Thank you for that question. Yes, and we have spoken to DCJS. We often work collaboratively with them. They do assist us in getting the word out with respect to our trainings, but we typically table their events each year, and we often have specific presentations, that we give to the individuals that go to their, conferences. So we do make an effort at the Justice Center to work with DCJS and get our word out.
No, I understand that, but they have specific curricula. And is there anything to try to get it into the curricula for the police academies?
Specifically at this time, that has not been
And
addressed.
is that something that might be discussed with them? I mean, I would prefer doing something like this administratively rather than through legislation. I always like to talk to the agencies first and question. Can we have a further conversation about that with you and perhaps with DCJS about it? Because I think it would be very helpful. These are suggestions that came to me from constituents who have neurodiverse relatives or children, and they have, I think, very valid concerns. And in fact, they've established programs where locally they do training for local police departments, which are extremely well received. But I think that we need to take it to a higher level. Is that something that I can pursue with your office?
I would encourage you to reach out to our office. We can have appropriate discussions around this, and I'm certainly happy to provide you, with the trainings that we offer currently, so you can see them firsthand.
Great, thank you so much.
Thank you.
Thank you very much for your time with us today. We've gone through our lists, and we will free you to continue with your day on behalf of the state of New York. Thank you very much.
Thank you, everyone.
Okay, now let's try panel B, New York State Conference of Local Mental Hygiene Directors, Mental Health Association of New York State, and the National Alliance on Mental Illness. Hello. Okay, good afternoon, everyone. And we'll start with Courtney David and then go that way. Each 3 minutes. So for the rest of the hearing, clock people, it's 3 minutes for everyone. Okay, thank you. Good.
Thank you. Good afternoon. My name is Courtney David. I'm the Executive Director of the New York State Conference of Local Mental Hygiene Directors, comprised of the Directors of Community Services, Mental Health Commissioners for the 57 counties and City of New York. Thank you for the opportunity to testify today. To stay within time limits, I will focus on the critical need to reform the state's competency restoration process. Our other budget priorities are outlined in our written testimony. The sections of law governing competency restoration were written more than 50 years ago before the unified court system existed. Today, this process has quietly become one of the largest, least transparent, and most unsustainable cost drivers for county mental health departments across the state. When a defendant facing felony charges is found unfit to stand trial, county mental health departments must cover 100% of the cost for restoration services in state-operated forensic hospitals, roughly $1,300 per day, without any input on placement, treatment planning, medications, restorative curriculum, length of stay, or discharge planning. Some individuals remain confined for years, even though many could be restored in months or would not meet medical necessity for hospital-level care absent competency restoration. These prolonged confinements worsen clinical outcomes, raise serious civil rights concerns, and represent a profound misuse of local public dollars. This issue is not new. In fact, the conference raised it publicly in its spring 2002 newsletter, seeking relief from this unfunded mandate. More than 20 years ago, it was already flagged as unsustainable. Under the state's 100% shift, these costs have grown dramatically. In 2002, Niagara County paid $178,000, and last year, $2 million. Chemung County, $27,000, now over $1 million. We are grateful for the Senate's leadership last year in moving these reforms forward through the One House budget proposal and passage of Senate Bill 1004A. As the conference marks its 50th anniversary, we face a turning point that demands more than continued discussion. For decades, counties have raised this concern, yet the system remains largely unchanged. With recent federal actions placing additional pressure on our local mental hygiene systems and shifting even more costs onto the counties, the fiscal year 2027 budget must be the catalyst for action. Let's make now the time to modernize a system that is failing individuals, counties, and taxpayers alike. Thank you.
Good afternoon. Thank you for this opportunity. My name is Glenn Liebman. I'm the longtime director of the Mental Health Association, New York State, commonly referred to as Mahaney's. Our organization is comprised of 25 affiliates in 52 counties, and we are boots on the ground, providing community services and support in the regions. We're also very engaged with advocacy training and anti-stigma efforts. I've had the honor of speaking before the committee for the last 22 years. That's a lot of budgets to talk about and highlight. Over the last decade, I've talked almost exclusively about the COLA for the workforce and provider agencies. The COLA is now referred to as the Targeted Inflationary Increase, TII, and I will discuss that as our top priority again this year. But I would like to digress for a minute and just talk about two innovations that are included in the proposed executive budget. The first one is teen mental health first aid, and I was glad to see a lot of questions this morning about it. The governor has proposed that any 10th grader, any 10th grade high school student that wants teen mental health first aid should be able to get it. We're incredibly supportive of this initiative. It is a tool designed to provide mental health skills training to young people to help identify, understand, and respond to mental health and substance use challenges. To date, over 15,000 teens have been trained in New York State, and the evidence-based numbers on this consistently show increased confidence to help peers with varied mental health concerns, reduce stigmatizing beliefs, and changes in perceptions of adults. We again applaud Governor Hochul and Commissioner Sullivan for recognizing youth mental health first aid and providing long-term solutions to the need of young people. The other initiative I also want to talk about briefly is the creation of a statewide first responder behavioral health center of excellence. The mental health needs of first responders needs to be addressed. Recent surveys suggest that 2/3 of first responders suffer from stress, 52% suffer from anxiety, and 53% from depression. It's probably even higher than that. This center will be peer-driven, create a mapping project for first responder support teams, and create a culturally competent clinical resource network to respond to the varied 6,500 first responder organizations in New York State. On my time remaining, of course, I want to focus on the TII. First, we want to thank you for what you added to the governor's budget last year. The reality is that we need you again to help support our workforce and our providers. The math is very simple this year. The CPI is 2.7%. The executive budget includes a 1.7%. We need your support to add the 1% to the budget. In recent years, the Office of Mental Health has created all kinds of innovative recovery-oriented programs, but the reality is they have trouble finding the staff to run these programs. The analogy I make is to a baseball team. They have a great minor league system, strong sabermetrics department, good manager, but they don't have any players on the field. And that's the sad reality. My time is up. So, yeah. Go Mets.
Good afternoon. Thank you for the opportunity to testify today. My name is Nathan McLaughlin. I'm the Executive Director of NAMI New York State. We're the New York State chapter of the National Alliance on Mental Illness. NAMI New York State appreciates the governor's continued leadership in prioritizing. We're encouraged to see these investments, for example, in youth mental health, first responder supports, gambling prevention, and meaningful increases in the OMH budget. In particular, we really welcome this focus on youth mental health and family supports, including youth clubhouses, youth mental health first aid, and stronger online and AI protections. For example, efforts aligned with the Stop Online Predators Act are an important prevention tool. Harmful online environments are continuing to create anxiety, depression, trauma amongst young people. As a parent of a teen living with mental illness, I've seen that firsthand. We also commend the administration for streamlining licensure for providers serving individuals with co-occurring mental health and substance use disorders. Allowing clinics to operate under this single license will reduce burden, improve access to care, and really help families avoid navigating separate systems. Equal access to care is a high priority for NAMI. At the same time, several critical gaps remain. First, the temporary disability insurance remains woefully outdated here in the state of New York. While paid family leave provides meaningful wage replacement, TDI remains capped at $170 per week. That leaves people unable to afford recovery after inpatient mental health or substance use treatment, and in many cases can be a hurdle to people seeking the treatment they may need. Second, the budget falls short on crisis response. Too often people in mental health crisis encounter law enforcement first instead of care. We'd like to see more investment in crisis intervention training and alternative crisis responders envisioned under Daniel's law. We would really like to see a system that delivers care, not handcuffs. And finally, as you've heard here today, the behavioral health workforce remains under severe strain. Before I came to NAMI, I ran an IDD agency and worked in that field for about 15 years. And a 1.7 cost of living adjustment is just not enough for any of these agencies to recruit and retain high quality staff. We urge the legislature to increase that adjustment, expand loan forgiveness, and just support the retention efforts and recruitment efforts in that important field. In closing, NAMI New York State really appreciates the progress reflected in this budget and hope we can do more to ensure access, equity, and sustainability across the mental health system in the state of New York. Thank you.
Thank you all very much. Our first questioner will be Chair Fernandez.
Thank you so much. Good afternoon. So how has it been like, if you could tell me a little experience with the back and forth of the federal funding cuts? We saw it got cut, we saw it got replaced, could get cut again. How is this adding to the uncertainty and management of care?
Can I take it, Glenn?
If I could figure it. Oh, okay. And then feel free to jump in from your perspectives. But Senator, it's obvious that it's incredibly difficult for planning. I feel for community providers, many of whom we represent, that there's this roller coaster of thinking you have support, thinking you have funding from the federal government, thinking you have backup from the federal government, and then all of a sudden it's cut, but then it's added again. So it's very, very difficult for us to be very planful in the process. That's why we were pleased to see the budget this year in New York State, that at least was a positive budget. Going 3-4 months ago, we were very concerned that we
So
were
I'm
going
going
to
to
be in
stop you
deficit.
there because I didn't know I had 3 minutes. I thought I had 5. But
Okay.
tell me what is good about the budget. What are your thoughts on these new programs? You did mention the teen mental health, that we have the EMT support program and the GRACE program. Like, what are your thoughts and how do you see these programs really helping, or if they can be improved by, from the proposal that we have?
And again, I'll be brief, and I'll hand it over to my colleagues. But I will say, in terms of teen mental health first aid, because that's something that we've been working on for well over a decade, I think that the possibilities of teen mental health first aid, taking 10th graders who are at that stage where they're 16, 17 years old, trying to figure out their lives, to basically create some sort of peer-to-peer model for them, which is phenomenal. The idea of, when they're having issues, when they're having concerns, that they can go and talk to a peer. And the way the system is set up in terms of youth and teen mental health first aid, allows them that ability. It creates that adaptability for them. And I think that is incredibly powerful. And that's the sort of preventive tool that we could see having years and years of impact. I could talk forever about a lot of things, but I'll.
Anyone else want to chime in?
Thanks, Nathan. Yeah, I mean, from our perspective, one of the major responsibilities of our members is on local planning, right? So they have a legal responsibility for the planning of the 3 mental hygiene systems. So that's mental health, SUD, and IDD for children and adults in the counties. So to your first question about the federal actions, very difficult to plan locally on what services are needed, what money is going to be available when it's ever changing. And then to the point of the budget, we agree with Glenn. The teen mental health first aid and the programming around that is critical. Our counties are very supportive of that. Sorry.
Sorry.
Thank you,
Thank you.
Assemblyman Burdick. Passes. Assemblywoman Chandler Waterman.
Thank you, Chair, and thank you for your testimony for NAMI. I have family members live with mental health conditions for almost over 30 years, and I know that the best way to recovery, not only being person-centered, making sure there's access to wraparound services, and including peers and those who live experience a part of the solution, but also the family support. So oftentimes, family members call us to try to navigate whether they're in the emergency room, in the hospital. What does that look like for support? What does NAMI have in place, and how does this budget help reinforce family getting support and as they navigating this very uncertain thing with getting resources at the same time? What do y'all have put in place, and what can this budget do to expand those support systems for the family?
Yeah, thanks for the question. And, family support is really at the core of what NAMI does. And we have a resource line that people can call to get help right in that moment. We're also developing a new family resource guide that will be both online and print, where people can easily access those resources, especially we're in the hospital and looking for that answer in crisis, At the end of the day, access to care, and I'll touch on that a number of times today. Access to care can keep people out of crisis to begin with, right? And that's the goal, is how do we alleviate crisis and lower those instances of crisis? And so, for example, and I mentioned the streamlining licensure for coexisting disorders. That's a great example of increasing access to care to keep people out of crisis to begin with.
Okay, and I do have a little bit of time, so I will also ask that maybe I have an in-district mental health task force. Maybe we could collaborate and have conversations so family members be able to navigate a little bit better. There's sometimes that people, when they don't have the resources, unfortunately, we had several police-involved incidents with those in crisis and those that needed extra support. And I think if we could find a more preventive way of informing family how to look for certain, because some people go without having any assessment or know that they have a mental health condition, and then by the time it's too late, and unfortunately we can't reverse what happens at the end of it. So making sure when someone goes in the hospital, what number to call, family members don't have access once the ambulance comes sometimes, and then once they're in that care of the within the hospital, they don't know exactly what's happening when they get to a room. How can they have those visits? Food is comforting. Sometimes there's issues with certain type of foods and culturally relevant. So just making sure that there's really a comprehensive plan on how families going to be engaged. And we know we're doing better with making it look, how can I say, more person-centered with the colors, but a lot of them look like jail cells when we go to visit, and they're not very embracing to family. So there's a stigma, and then we're treated and dehumanized as our loved ones is dehumanized as well in the process. So however we could collaborate with that.
Thank you. Yes.
Thank you. Senator Canzoneri Fitzpatrick.
Thank you, Chair. Thank you all for being here, and thank you for your advocacy in the mental health field. As the ranking member on mental health and the mom of four, I worry every day about my children as well as my mental health for being a state senator. But I will tell you, though, I appreciate what you've stated here today about the 2.7% COLA, TII, however we call it. I applaud your commitment to first responders because I see every day that our first responders are in need of support. I wanted to ask about the teen mental health program for anyone that wants to answer. What do we need to do better? Where is there an opportunity that we're missing? What can we do to help our youth?
Well, thank you for the question. I think that, again, the governor's program is very expansive. I think focusing on all 10th graders makes a lot of sense. And I think that hopefully people will even get even greater knowledge about the need for it. We have to do a better job in going into schools and talking about it. And that's sort of what this initiative is. There is, as the commissioner talked about this morning, there is legislation from 10 years ago now that mandated the instruction of mental health in schools. We have to make sure that every school is taking advantage of that. So we really have to make sure using teen mental health first aid as a lever to make sure that happens. Yeah. But we really think that we have to go into more and more schools around the state and make sure that they're educated. And earlier this morning, I think other people, other legislators made comments about teachers and other folks who should know about that. Senator Fernandez has a bill that we are on top of, where we're very supportive of teacher training as well. So it is much more than just, the students. It's the teachers, it's the bus drivers, it's everybody. And we have to do a better job of that.
Yeah.
Yeah, we fully support from the county's perspective on the 10th grader education and trainings that to expand that youth mental health training to those outside of the peers, right? So the teachers and school administration. Yeah.
And I would add to that, supporting the idea of solutions, not suspensions in school, right? Because children with mental illness, and I say that as a parent of a teen with mental illness, are disproportionately suspended from school due to behaviors that are actually rooted in their mental health, and trying to educate school districts on how to enter into that in a restorative way.
Yep. I keep talking about mental wellness, not to change the stigma. And I know that we've heard that a lot today about changing the stigma surrounding mental illness. And we need to continue that and start it at a younger age so that by the time they become adults, they don't have that stigma. So thank you all.
Thank you.
Thank you, Assemblyman Palmisano.
Thank you. I just have one area I wanted to ask you about. Earlier today, when I was talking to the commissioner, and we were talking about the rural suicide issue, the Rural Suicide Task Force. This has been an issue of strong concern for me, just because of a constituent of mine who lost his son tragically to suicide. And during that conversation, the commissioner said that they will be working collaboratively with our locals, our counties, which I understand because you are on the forefront of delivering those services. My question for you is, are you communicating with OMH on strategies, best practices, and how they can best help you? And would you mind sharing some of that with us at some point, whether it's here or because I know you only have a couple minutes, but I just want to make sure that they're definitely, and I'm sure they will, involve you because I know you're at the forefront, and what types of recommendations you would be making to make sure that Rural Suicide Task Force is operating effectively to address this issue because it's a strong concern, especially in our rural areas. And that's why I think we're moving in a direction. When we had the bill, the governor vetoed it. They said they were going to do in-house, so we're glad to do that. So I just kind of wanted to make sure that was on your radar screen. Anything you could share with us in the future after this, but happy to hear anything you might think on that from
Sure.
a best practices. Thank you.
Thank you. And I was actually going to follow up with you if I didn't see you here today, because I know we spoke about this last year. And ironically and most timely, I have a call on Friday with the team lead at OMH to talk about a new initiative that they're rolling out around rural suicide prevention. So I'm happy to follow up with you after I have that discussion. And we are, grateful to OMH for bringing us in as part of that planning process.
I appreciate it. And I think my constituent, Joe Toby, who spoke here last year, he's also a county legislator. So being from the local perspective, he'd like to, love to facilitate a call with him at some point too, just
Anytime.
because he's got a lot of
Be happy to. Thanks.
and expertise. Anyone else, if you want to, please do.
Sure. So just to point out that we do sit on a rural behavioral health group, several members of NAMI as well as some OMH employees. So we are engaging in that conversation, and I can share more with you about the activities of that group.
Great.
I serve on the Behavioral Health Advisory Council, which is comprised of professionals, peers, family members, and we often have conversations about the needs of rural communities. And I think that we agree with you completely on this front. And we're certainly, OMH has been great to work with in terms of the communication. They understand our perspective. So, but I think it's really important to sort of continue to highlight that. So appreciate you bringing it up.
No, I appreciate that, and I again appreciate the work your organizations do. It's really important work, impactful work, dealing with the mental health crisis we have in our communities across the state. So thank you, and good luck to you.
Thank you. Thank you. Senator Tom O'Mara.
Good afternoon, and thank you for your testimony today, and thank you for the great work that you do throughout the state and in our local communities. Really appreciate that, the great need that we have in this area. I want to echo the comments of Assemblyman Palmisano with regards to rural suicide and getting that the appropriate attention that it needs. My question is, given the prevalence of dual diagnosis of addiction and mental health, Governor has a proposal in here for a dual licensure for providing addiction and mental health services. What are your thoughts on that? And would you like to see any changes to the way that's been proposed by the governor?
From our perspective, we're supportive of that effort. We have, we've seen through, separation of licenses and, separate clinics. From the county's perspective, we see a lot of folks on all three system side always interacting. So, obviously we would like to take a look at how the regulations read for that before we can comment further about any changes that we would like to make. But overall, we're supportive of that effort.
Yeah, and just to elaborate on that a little bit, I totally agree with Courtney that for many, many years we've sat there as a system that's sort of bifurcated in many ways. And I think there's been a lot of frustration. I know the agencies have been working towards moving towards this end, and it's a long time coming. And I like that they're doing this tiered approach. I think it makes complete sense. I can't tell you how many times over the years people have come to us and said, why is my mental health and substance use not being looked as one entity? That's who I am. Why am I not treated as one person? Why is there a mental health piece and a substance use piece? That's who I am. So there have to be better combined services, and I hope licensure is sort of that avenue to get to there. I hope it's the pathway to get there. So.
Yeah, and I agree there with what Glenn's saying in terms of why are they bifurcated, right? And to be able to just lower the barrier to how someone gets to an appointment and seeks recovery, and that's a great way to do that.
Yeah. Well, thank you all. I agree wholeheartedly with that, and hopefully that will help. Why have to go to two providers? There's a limited number of providers, woefully as it is. So I think it makes a great sense. So thank you for your input on that.
Thank you. Assemblywoman Griffin.
Thank you, Chair.
Excuse me?
I'm going to thank you all for being here. Since time is limited, I'm just directing this to Glenn. I just wanted to share that last year I passed the Lieutenant Joseph Banish Peer Support Mental Health Act, and that was signed into law just recently. And so I very much appreciate the Governor Hochul's initiative to provide the 1 million to create a state first responder center. I think that's a terrific idea. And I just wondered how do you have like a vision for how this would best serve?
So and thank you for what you did with that. That's a very important, significant piece of legislation. So what I would say is that it we have 6,500 first responder organizations in New York State. What we have to do first is a mapping strategy to find out what they all do, how they can work with each other. So I think that is the first essential piece of what we need to do. And I think from there, once you do that, is you have to figure out how to identify supports for each other. You know, peer support is so essential. We all know, everybody knows it intuitively. And yet the fact is that we don't do enough peer support for those who are most struggling. And they're not going to share with me. They're going to share with a peer. So I think the idea is first we map, then we go through the process of identifying how they can support one another, how we can figure out how to identify that they work with each other, and then bring in the clinical tools that are necessary, and then add the necessary trainings as well. So we're very hopeful. So.
Okay, thank you very much. And since I have a little time, to either one of you, in addition to K through 12 students, the need for mental health has just risen drastically over the years. But we also see that same issue at college campuses, at universities and colleges throughout our state. And, it seems like a lot of schools' resources may be limited. And I just wondered what any of you, suggest or advise for this issue.
Sure. Ethan, can I go? So we actually have a grant from OMH through the conference to provide mental health first aid training in higher education that has a harm reduction element to it. So we have, this is our third year going into that, where we have provided like train the trainer programs through the National Council to folks within certain colleges. We've hit some SUNY campuses, we've hit some private colleges. This year we're looking to a more vocational angle for that. So working with our directors of community services, we have that project going right now.
Well, that's great to hear, and thank you.
Okay.
Assemblyman Burdick? Oh, you passed that, I remember. Assemblywoman Simon.
Thank you. Thank you for your testimony. I'm sorry I wasn't here for it. I was up getting another blanket because it's so cold up here. So I wanted to thank you for your testimony. And I know that a lot of the advocates have been talking about an increase to 2.7. I'm curious whether the panel are all in favor of this. Okay.
Fully
No,
supported.
we think it should be 1.7. No, we definitely, we could not have been more supportive. As you know, we spent a lot of last year. We saw many of you stopped by as we had our daily rallies for the COLA increase, and you listened and added to that. But I've got to say, even 2.7 is just the minimum piece here. But we are very supportive of a 1% add.
So you'd be happy with 5?
We'd be very happy with 5.
Oh, okay, good.
Yeah. 10?
Wave my magic wand.
Thank you, Senator.
Okay.
Appreciate it.
Thank you. Other issues that are in the budget, and Glenn, I understand you have a real interest in this and expertise, but I'm happy to hear from anybody, is this teen mental health. I can see this as being something that would be interested to NAMI as well as the counties. Yeah. The mental health first aid for 10th graders, what are your views about that? What are the things you think needs to be in there? The agency will be doing this, but it always helps to hear from stakeholders as to how to implement this in a way that works for the school community and for young people, because I know I keep saying that it's good for teens to have this. My granddaughter was really trying to help a friend of hers who was cutting, and she was very stressed out about it, and it was really hard for her to know how she could help and where to send her, right? When to say this is beyond me.
Yeah. So what I would say again is, as I said earlier, is I think that first of all, we think it's wonderful. We've been doing it for many years now at Mahaney's, and we see the efficacy of it. We see it's evidence-based practice. We see that teens really respond to it, and it becomes this peer sort of model of, that teens are talking to teens about it, and it's so much less stigmatizing than it was. And again, the one thing I would say is we have to make sure that we do a really good job of making sure it's infused in schools, that all schools know about this. We can't let, one school do a great job with it and another one not do a great job with it. So we have to make sure that we have that outreach to all schools.
And the rest of you, do you have any views about that or agree with him?
From the county mental health perspective, we had done youth mental health first aid for a long time. Fully supportive.
Okay. And you too.
Sorry.
Great. Thank you very much.
Any other assembly?
We're done, I think.
All right, we're just double checking. Is there any other member who wanted to ask questions? Okay, you've missed your opportunity. We want to thank you all very much for being with us today. Appreciate your help on behalf of so many New Yorkers. Thank you. And we're going to jump to the next panel. But everyone's going to walk down the stairs carefully, just letting everyone know. So, Self-Advocacy Association of New York State, Shamika Andrews, Fountain House, Ashley Miles, and New York State Coalition for Children's Behavioral Health, Kaylee Zaloga.
Missing someone?
Not sure. I think this lady's coming.
Oh, okay.
Let's see. Okay.
Use this one. It's working.
Are we waiting for one more person? We are. Okay. Okay. And which one of you is Shamika Andrews? Hi, how are you? So we're going to start with you and just go down the table, okay? Thank you. And you press the green, the light until it becomes green.
Yeah,
You got it.
I was fighting with this one and it came on, and now they're
Good.
both on.
Perfect.
Stereo.
There you go.
Okay. Anyway, hi everyone, members of the Assembly and Senate. My name is Shamika Andrews. I am the Community Outreach Coordinator for the Self-Advocacy Association. Thank you for this opportunity to speak with you. I am happy to be here once again after missing the last hearing you had, because I have been without a working wheelchair due to lack of providers and long wait times and not being sufficiently fitted and properly. So I am glad to be here now with a fully working chair, and continues to be an issue for many people due to lack of providers in this area. So just want to highlight a few things from my testimony that was submitted. New Yorkers with developmental disabilities rely on services from OPWDD and the Department of Health to meet our basic needs, realize our potential, and contribute to our communities. It is essential that the legislature build ongoing relationships with constituents with disabilities, to hear directly from us on a regular basis, to recognize that people with disabilities are a diverse group with diverse abilities, and no one single voice speaks for all. We are appreciative of Governor Hochul's proposed investments in the OPWDD budget, the DSP wage increases, focus on affordable housing, affordable and accessible housing due to the lack of housing to meet the needs of all. It's important that these entities work together to meet this needs, because without these services, we are not able to live the lives that we need and deserve. Along with that is transportation. Most parts of the state either have a lack of transportation, accessible, reliable transportation, or none at all. We do support the increase for the 1.7 targeted inflation increase, but we believe that this should be increased to at least 2.7.
Hi, thank you to the chairs and other members for hearing our testimony today. I'm Kaylee Zaloga, President and CEO of the New York State Coalition for Children's Behavioral Health. We represent 50 nonprofit service provider agencies across the state and the families they serve. We serve nearly 200,000 children per year, as well as their families, and employ about 21,000 staff across the state. We're all aware of the growing need for mental health services and the lack of capacity in our system to serve everyone who needs them. We heard a little bit more earlier about the recent game-changing lawsuit that resulted in a settlement, affirming what families and providers have been saying for a very long time, which is that our service system is failing to meet the needs of kids and families who have behavioral health needs. And now we have the legal obligation as well as the moral obligation to change that. We have more data each year on the scope of the problem. We know that only 1 in 4 kids who's eligible for intensive Medicaid behavioral health services is receiving them. We know that thousands of kids who have complex behavioral health needs and who have received a mental health diagnosis never get any treatment following that diagnosis. We have a lot of room for improvement. But let me be clear, this is not a youth feeling a little bit down crisis. Suicide is the 3rd leading cause of death for high schoolers in New York State. Close to 20% of them have seriously considered suicide in the past year. 11 of them attempted suicide in the past year. That's 1 in 9 high schoolers in New York felt so hopeless that the thought of harming themselves and ending their lives was a better option than waking up another day and continuing. Now, if pneumonia were the 3rd leading cause of death in New York State among high schoolers, our response wouldn't be giving schools the option to train some teens in first aid. It would still be a worthwhile effort, and mental health first aid is an incredibly worthwhile effort. And it is not a replacement for the treatment that kids and families need. Decades ago, when I was an adolescent routinely having suicidal thoughts, treatment is what I needed. It's why I'm here with you today. We need to invest in the mental health service system. We need to start with at least a $200 million investment in children's outpatient services. We've been asking for that for the last 3 years. We needed it then, we need it even more now. And especially as we hope to work closely with the state in developing a system redesign pursuant to the settlement, we need to make sure that we're also still serving the kids and families who need help today. 18 months from now, I hope that we do have a really well planned out and well thought out system that will take the needs of our workforce, serving kids and families day in and day out, into account. But we need to serve the kids who need services today. We need to raise the targeted inflationary increase to at least 2.7%. We need this to be an annual adjustment for inflation so that we can continue to try and attract and retain the people who stand between life and death for families. Thank you.
Hello. Good afternoon, Chair Kruger and members of the committee. Thank you for the opportunity to address you today and talk to you about Fountain House, the club and the clubhouse model as you consider the New York State budget. My name is Ashley Miles. I'm a pre-law student majoring in social work at Hunter College. I have maintained a 3.9 GPA, and my success now would not be possible without the support of Fountain House. Fountain House is a national nonprofit that fights to improve health, increase opportunity, and end social and economic isolation for people most affected by mental illness. We serve about 1,500 members across Hell's Kitchen, the Bronx, and Harlem. Our clubhouses are member-run, and the therapeutic programming that members participate in allow us to build relationships and autonomy. These choices we make as members aid in our recovery, and the resources offered at the Fountain House have meant that I've been able to find housing and employment too. Research has consistently shown that individuals with an SMI who are members of clubhouses experience improved quality of life, reduced hospitalizations, and enhanced self-esteem. And the benefits of the clubhouse model extend beyond individual outcomes. A study by NYU found that Fountain House reduced Medicaid costs by 21% for individuals with high-risk mental health needs. This economic modeling has shown for every person we serve, we save the government an estimated $11,000 annually per person, when including costs associated with health, disability, criminal justice, and productivity. If the clubhouse model were expanded to just 5% of the 15 million Americans living with SMI across the United States, our nation could save over $8.5 billion nationwide each year. With the success in mind, I asked the legislature to do 3 things for clubhouses: provide robust funding for capital and programmatic funding for the expansion of existing and accredited clubhouses so that we can reach more New Yorkers struggling with mental illness; create sustainable funding sources that reward accredited clubhouses based on the value they provide to their members and that promotes fidelity to the clubhouse model; and protect access to federal benefits by streamlining recertifications and creating strong exemptions for people with mental illness. Lastly, we urge you to maximize investments in voluntary, evidence-based solutions rooted in community care. Please prioritize these proven models before involuntary methods that may compromise trust. In my experience, I've once been hospitalized and put on court-ordered treatment without being fully sound mentally, and that heavily impacted me. With the expanded support for clubhouses, we can have more outcomes like mine and less like Jordan Neely.
Thank you. Thank you very much. All right, let's see. Senators who would like to have any questions? Yes, Senator Fernandez.
Thank you so much for sharing and speaking about suicide prevention. That really is a problem, and we know that amongst demographics of young Latinas, young Black male youth, rural New Yorkers, veterans, it's still high. And a big concern is seeing how young children are when they're speaking of suicidal ideations. So the mental health program I do think is good for now, but also I do want to see professionals available to young people. Is there anything you can speak on this program and how maybe it can be strengthened?
Are you asking about the mental
teen
health first
mental
aid?
health training, the new program proposal?
Right. I've heard nothing but good things about teen and adult mental health first aid training. I think it's wonderful. It does a lot to sort of change the perception of mental health conditions among youth and their peers. But when we're talking about treatment needs, it's just not in the same category. We're not supporting the system that employs the clinicians and peers and those who really go into people's homes and communities and are there on the worst days of their families' lives often, are who's helping them, connect them with the resources that are available, giving them the services and treatment they need. So it's good, and it's just not healthcare.
Thank you so much. And it's Fountain House. I'm a big fan of Fountain House. I visited a few in the city and, very supportive of the expansion of it. Can you speak about how communities that don't have clubhouses lack in care for members of our community that could use the support of a clubhouse?
Um, could you reframe the question for me a little bit?
Sure, I might have even confused myself. But could you again speak on the benefits of a clubhouse, and if a community doesn't have a clubhouse,
What it can mean?
what are other resources or the lack thereof?
For me, when I think of Fountain House, the support that it gives is that it provides a community of people who have a shared lived experience where they can find comfort and belonging. The supports that we have housing, we have employment, we have an education unit where people can come and pursue their educational studies. What else do we offer? Generally, we just offer a safe space for those who don't have it. And I feel like for communities that do not have it, it leads to people lacking support, and with the repeated hospitalizations, it impacts their health and it could risk the safety of communities, having people who are not sound because they're not getting. Oh,
thank you.
Sorry.
Assemblyman Palmisano?
Thank you. I appreciate it. First, thank you all for your testimony here. I appreciate it. My question is for you, Kaylee.
Okay.
I'm going to stay on the same theme I had at the last panel and earlier on the rural suicide. I know you touched on suicide in your comments. And just going back to what the Commissioner of OMH said today, that they're going to be working with locals, they're going to be working to get feedback and input. Have you had any conversation with OMH on this rural suicide task force and on policies and plans and strategies they're going to be implementing? Do you feel like you'll have the opportunity? And what types of recommendations would you possibly be making on that task force? Or is there anything we can direct to them on your behalf? If you have any suggestions, I would just ask you to reach out, because it's something that, from personal perspective, I'm really trying to help, with what our constituent went through and is really vested. So I just like to just get your quick comments on that, if you may.
Sure. The coalition has not been directly involved in the rural suicide prevention work, but we are certainly, our providers at the community level are involved, engaging with their county mental hygiene departments and the state to try and make clear what families need. We know that it looks different in different parts of this. And we collected some new data this past year showing that there's a very clear concentration of youth with more complex behavioral health needs in less resource parts of the state. So we know that where there's higher poverty and often in our more rural counties, kids have more needs that aren't getting met. Families have more needs that aren't getting met. So we would be supportive of working with you and with OMH to try and make sure that what they do is effective and really trying to bring mental health resources to all areas of the state.
Thank you very much. Thank you all for being here. Appreciate it.
Senator Canisteri Fitzpatrick.
Thank you, Chair. Thank you all for being here today and sharing your stories. My question is for you, Kaylee. You said in your testimony that in a 2025 study that you found a higher concentration of youth with complex behavioral health needs in counties with higher poverty rates, and very clear correlation between lack of access to outpatient behavioral health services. And I'm wondering, are there other things contributing to these issues that we're seeing? Is it affordability? Is it, you said lack of access, but are there professionals in these areas? Like, what do you think we should be doing to help the youth in these areas where there's more poverty?
Sure. I mean, I think a lack of workforce throughout the state is our issue, and it's most pronounced in more rural areas of the state where the ratio of social workers, mental health counselors, psychiatrists, et cetera, to the number of youth is just astronomical. There's no way that those in that area could get all the help they need. So part of supporting developing our workforce is supporting workforce pipeline proposals that encourage young people to enter these fields or that encourage people mid-career to change professions and go these routes. We appreciate some of the loan forgiveness that we've seen. We also need to have more scholarship and fellowship programs that help people who can't afford to outlay that cash initially to get their degree, but who would be really valuable in the field. So supporting our workforce, and part of that is raising reimbursement rates to at least keep pace with inflation. But as you've heard from other folks, we've been very behind in keeping up with inflation for so long that at this point, we need more than 2.7 just to be able to raise salaries to where they should be. None of our staff should have to work a second job after they've taken care of people all day to support their own families. So we have a very long way to go in making the behavioral health field an attractive and one where our staff feel as valuable as they really are.
And what type of the complex behavioral health needs, what are you seeing? I know the statistics you said about, anxiety, depression, suicidal. It's outstanding. It's unbelievable, that's where we are. But I know that's the reality.
Mm-hmm.
I said before, I have 4 children of my own, and I see it constantly with what's going on with our youth. But what else should we be doing to support the workforce? Loan forgiveness, incentives, those types of things that will encourage people to go into this area to help other people. Is that things that you think would be helpful?
We can follow
Thank
up
you.
with it.
Simon?
I didn't realize I was next, so I apologize for chewing. So thank you all for your testimony.
He'll see about getting the list.
Obviously, what we need to do with mental health is pretty extensive. I am very concerned about the settlement with that you referenced with regard to children's mental health care, and the ongoing nature of the engagement that will be happening, and then subsequent additional regulations. And so I wanted to just ask that, are you involved with that? Do you know the people who are involved in that stakeholder engagement? Who is sort of watching out from the sort of advocacy point of view to ensure that this is as collaborative and engaged as possible?
Sure, the coalition is certainly watching out. We know that that OMH and DOH are currently in the process of developing their stakeholder engagement plan. We know the folks at each agency who are leading the effort, and will continue to engage with them. There's also the plaintiff's counsel on the case who remains involved with certain aspects of the case, and hopefully will be a part of making sure that the stakeholder engagement process is meaningful, really focuses on the feedback from youth and families as well as providers, and that the recommendations and needs that are expressed are taken into account in the subsequent plan. So we certainly hope to be formally involved in as many ways as possible, and whether or not anyone wants to hear from us, they certainly will.
Thank you. Obviously, workforce is a big issue, and you've addressed that somewhat. It seems to me it's obvious that it's a matter of pay, but it's also a matter of ongoing training. It's also encouraging young people who are going into these fields, or increasing the number of people who are willing to go into the field, and being able to attract them. And I did want to just mention on the Fountain House and the clubhouse model. I know that we put money in our budget last year to expand clubhouses in other parts of the state. Are you, familiar with that? Do you know whether how that's going?
At the moment, I do not have an answer for that, but I do invite you to come to our clubhouse, so we would be able to answer that for you, since I do not have the answer for you right now.
I've been there, but I'll ask.
Okay.
That's okay. That's great. And then thank you for your self-advocacy organization. One of the things I think that is going to be a tough nut to crack is this issue of transportation that really leads to a lack of access. So I'm so glad you brought that up. It's something I think we don't tend to think about as much as policymakers. So thank you for that testimony. It's something that I think we really need to keep in mind. Thank you.
Okay. Senator Webb.
Thank you all for being here today and most certainly sharing your very powerful personal testimonies. So I asked this question earlier of our commissioners, and just to pose it to you all, for the last several years, we've made significant investments in mental health services, and you all spoke to kind of your experiences with our current system in New York. So my question to you is, what are other ways that the financial investments that we've been making in mental health services and even policy areas that we could strengthen to make sure, whether it's the clubhouse model that you're talking about and just kind of overall services and resources that you think would be the most helpful? And it's open to anyone to answer on the panel.
I just wanted to say, as far as this, I think it's been touched on a few times that it seems like the investments are to keep us all afloat instead of, looking at what really is, will it take to have overall transformation and really support people, because, the mental health piece, all the things that I brought up, and you know, your mental health is, number one, and it affects all of those things. If I can't leave my house, if I can't get to work, if I can't, find housing, if I can't find food, those are all affected by my mental health. So, really looking at, if that's our goal, is real transformation and transforming people's lives, is not just, funding things so, the ship doesn't sink, so to speak, but really, moving us forward.
I would just say I'd like to thank both houses of legislature for including funding specifically for kids' behavioral health services in last year's budget. That was really important recognition that we do need to do more than we've been doing in children's mental health services, and especially in children's services. So I'm hopeful that we can continue to keep up that momentum and to try and get more investment. In this executive budget, what we don't see is an investment in services. We see an investment in some programs that are going to be helpful, but are not a replacement for healthcare.
And then did you want to add as well? Thank you all again for being here, and most certainly your continued advocacy. Thank you.
Any other? Assemblywoman Griffin.
Thank you, Chair, and thank you to all of you for being here. What you're advocating for is so important and so meaningful, and you're all making a great case. So thank you for being up here and really conveying why and what you need and why, and why you need this money, this funding, and these services. I just wanted to ask you. Kaylee, is that, am I saying that right? You have a reasonable request of the 200 million in funding, and so that seems reasonable for all that you're trying to accomplish. And it's like heartbreaking to know that there are so many children that can't get the care that they're, to have a child that needs care desperately, but as a parent, you're unable to afford that. That is a very, I don't even know how to describe that challenging of a situation. So let's just say, okay, we're all set. The organization gets the funding they need. But what else? What's like the other type of things? Like, it seems like that money is helpful, but what else?
Wow, just the thought of actually having the funding we need for the system, I haven't really gotten past that. But I mean, the first thing it would enable us to do is to hopefully, first of all, retain the staff that we have to provide services and hire thousands more clinicians, peers, and other support professionals to be able to expand service provision beyond who we're able to serve today. That's really the key. I mean, we know that we don't have enough professionals, even if all of them wanted to work at nonprofit agencies that work with clients on Medicaid. We don't have enough of them. So we need, then the next step is to try and expand the field of professionals who are interested and able in providing these services.
Okay.
Those are the
And
main things.
I just want to ask one question to Shamika. I am so sorry to hear that last year you couldn't be here because you didn't have a working wheelchair. And I've had various constituents that have come with a similar problem where they've been denied the cost of these wheelchairs are extremely expensive. They can break, and then you're just left. I had years ago, there was a young girl, their stair, the stair raiser broke, and her mother, who wasn't that strong of a woman, had to carry her up the stairs each night. And then we were finally able to get her that wheelchair, but it's astonishing like that. It so often happens. And so I just wanted to know, could you speak on that? I know there's so many barriers with transportation. It's not really out of time, but if you even want to email me, I'd love to hear more about that, because there seems to be so many barriers to transportation, to being in a home that you can live in and work and all of that. So I'd love to hear more from you.
Definitely.
She's run out of time, but I will try to answer that question for you using my time, if that makes any sense. But the state has been woefully lacking in its reimbursement for costs of durable medical devices. The real problem is that the state is using, I think, 1984 Medicaid rates, and not the full rate, but a percentage of the 1984 rate, which has caused many of the companies that did prosthetics and wheelchairs and things of that nature going out of business. And it's becoming more and more difficult to get what you need. And they seem to be drifting all toward one company that makes a lot of plastic things, and many individuals, especially with cerebral palsy and whatever, that need metal in the bracing section, they can't use the plastic, and they have to wait and fabricate something, and that really isn't what they should do. We did pass legislation last year. It was unfortunately vetoed because these things are expensive, but we're responsible to pay those things. So the answer to your question, Assemblywoman, it's
what he said.
Is what Ms. Andrews would have said. I want to thank the three of you for your testimony. And we have two more senators? Oh, late bloomers? Okay.
As we say. Yes, Senator Pat Fahey.
Thank you. Thank you to both chairs. Sorry, we had conference and they were trying to start the floor, but I just wanted to race back over. Thank all of you for your tremendous advocacy. And Ms. Andrews is also a constituent and has been just a fierce advocate. I want to second what the chair said on durable medical equipment. That's a terrific bill. I also have a wheelchair right to repair bill, and you've just been so articulate, and just want to let all of you know your advocacy means a lot, and it is appreciated. I won't ask questions, but just wanted to thank you for your continued passion and hard work. Thank you, chairs.
Yes, thank you, Chair.
Yes, Selma in Santa Barbara.
Okay, thank you, Mr. Chair. I just want to thank you all for being here, and I want to thank you for your testimony. And it's insightful to hear from people that experience, that go through the system, that experience some of the hardships and some of the things we need to improve in the system. I just wanted to ask a few questions, if I can. And Shamika, maybe I can ask you directly. Where do self-advocates feel the least heard? I think we've talked about this before. Maybe you can give us a little insight on that. We've heard about service planning, housing choices, incident reporting, employment, across the board. Maybe you could just give us an overall view on some of the things that we really need to work on.
Well, as I said before, I think it's important to know that all of those areas have to work together in order to give people, the services, we seem to focus a lot on eligibility requirements and what red tape and all of these things that are not, uh, you know, really allowing people to live the lives that they deserve, including myself. Um, so all of these things, you know, work together. And really, like I said, it seems like we are looking at how we can keep, you know, services afloat versus, you know, really moving and transforming the systems. Many people have mentioned, we're providing services based on outdated regulations and outdated, service systems, and it's just things are stagnant, and we seem to be having the same conversations over and over and over again because we're really not moving the needle, so to speak.
And in terms of accessibility, I know my colleague mentioned the wheelchair repair bill. That's a bill we've been working on. And can you talk about some of the issues we still need to address with accessibility itself? I know we talk about disabilities in terms of, sensory friendly, but also accessibility, the ADA compliance, those type of issues. Can you talk about the challenges and some of the things that are still lacking?
Yeah, there's definitely, lack of accessibility in buildings is still a thing. There are many neighborhoods where you can't access certain buildings. I mean, just even in the building that we're currently in, there's challenges with accessibility and accessing things like bathrooms, for instance, which is always fun being in this building. Um, yeah, so there are a number of things that still need to be addressed, and just quickly, I'll say, accessibility is not only about physical buildings. Accessibility is also about people and their attitudes.
Well said. Well said. Thank you. That's very helpful.
And Senator Bino.
Thank you, Madam Chair. Hi, good afternoon. So my question is regarding accessibility as well, and I wanted to know if there were any challenges regarding wheelchair accessible vehicles being able to transport to and from your destinations and being able to get ride shares, or I know that there's county services that are available with sometimes after hours or outside of the area, it might be a challenge.
Well, I know for here, I'm from the Capital Region. The Capital Region currently has no accessible rideshare services. None. We have none. So there's that. We currently have CDTA, which is a great organization, but they have more customers than they can service. And as I said earlier, as it comes to accessible transportation in New York State, you either have lack of or you have none at all. So there's nowhere that I have been where people say we have wonderful transportation.
Right.
Nowhere.
Right.
So that's a major problem. And like I said, with the increase of things like Uber and Lyft, the fact that here in the Capital Region I can't access that, I personally think that that's a problem. But
Okay. Yes, I'm actually working on that issue, and I have a bill, and I'd love to engage with you and get your thoughts on it. So I know that that's an issue even on Long Island where I'm from. So it's something that I think as a state we should be working together to ensure that we leave no one at the curb. So thank you.
Had a chance? Well, then, I want to thank you all very much for being with us today. Appreciate your work and advocacy every day. Thank you.
Thank you.
Okay, we're going to call up panel D, Coalition for Self-Direction, Jim Karp, Dr. Natalie Ferguson, I'm sorry? Oh, okay. Parent Assistant Director of Nursing, excuse me, it's a replacement. Mike Siritier, Secretary, New York Disability Advocates, and Christopher Palega, Parent. Let everybody get settled in. Great. Okay. And Jim Carp. That okay, and we'll just then go straight down the aisle from there.
Sounds good.
Good. 3 minutes each. Thank you.
Thank you. Afternoon. I'm Michael Seawriter. I'm President and CEO for the New York Alliance for Inclusion and Innovation. I'm here today in my capacity as the Secretary for New York Disability Advocates, and I'm subbing in for Mike Alvaro. Our NIDA coalition comprises 6 statewide provider associations representing providers who support over 85% of New Yorkers with intellectual and developmental disabilities here in New York State. The stability of the New York State IDD service system directly affects individuals with IDD, their families, and the frontline workforce known as direct support professionals who support them. But please remember this, that the stability of this system is almost entirely dependent on government funding provided through New York State. So in recent times, we have made some significant investments here, and those significant investments are working, but reinforcements are needed. Since the state fiscal year 2022, New York State has provided nearly 16% in cumulative inflationary increases to the network of nonprofit providers. Our sector is deeply grateful for that. And the return on these investments have resulted in a 44% decrease in DSP vacancies, a 6% reduction in DSP turnover, and nearly a 29% increase in starting wages for direct support professionals. In just the last year, vacancy rates have dropped nearly 18%, and wages have risen more than 9%, demonstrating something that I have said at this hearing since when I started testifying in 2013. Targeted investments work. While NIDA appreciates the governor's proposed 1.7% targeted inflationary increase, this does not reflect the cost growth our sector has experienced, not the least of which are things like insurance. Rising costs for wages, food, transportation, insurance, and facilities mean that anything less than a 2.7% increase leaves this sector disadvantaged and simply unable to keep up. If IDD services are expected to continue these impressive performance trends, they can't be allowed to start falling behind. We can't afford to lose momentum. We urge that a full 2.7% targeted inflationary increase and a restoration of the care coordination organizations as eligible programs be included in the final budget. Looking beyond the TII for what this budget could do to be helpful, we also see opportunities to support the challenges that the care force faces as it relates to housing, childcare, and healthcare. In the housing department, many DSPs spend more than half of their income on rent and are priced out of the communities that they serve. NIDA supports a care force housing package detailed in our written testimony that includes employer-assisted housing grants, first-time homebuyer supports, and housing preferences for care workers. In the childcare department, DSPs are often working parents, and childcare costs remain a major barrier to attracting and retaining DSPs. NIDA strongly supports the governor's proposal to expand the child and dependent care tax credit. And in the healthcare department, we are seeking supports in the healthcare department. Thank you very much.
Thank you very much. As demand on the system of care for New Yorkers with intellectual and developmental disabilities continues to build, solving the complex challenge of allocating limited resources while maintaining appropriate levels of service for people with IDD seems almost impossible. Without billions of dollars of additional and ongoing funding on the horizon, it should be clear that the only viable pathway to achieving a sustainable system of care lies in developing and leveraging existing resources in an effort to control the demand and to improve the value of outcomes. My name is Chris Palega. I'm a parent who knows firsthand that caring for a family member with IDD at home comes with profound and ongoing physical, psychological, and financial stressors that are at times overwhelming. But despite these challenges, family caregivers who support family members with IDD at home are providing billions of dollars worth of services without compensation. We have built and we now maintain the most utilized residential option for New Yorkers with IDD by far, living at home with family. There is no doubt that family caregivers greatly reduce the demand on both the paid DSP workforce and much higher cost, more restrictive residential placements. More than 3 decades ago, New York State clearly recognized the importance of this work through the adoption of Chapter 552 of the Laws of 1992 and its amendment of Mental Hygiene Section 4143, the statute that governs FSS. This important legislation clearly details the original legislative intent for family support services, including that the program should be family-driven and designed to empower families by maximizing families' control over the nature of FSS services. Unfortunately, years of policy-driven disinvestment in FSS have made it abundantly clear that we must pause to become reacquainted with the original legislative intent for FSS, and we must be guided by it to redefine how we value and support the work of these family caregivers. In my written testimony, I've shared a number of simple, cost-effective legislative actions that are desperately needed to achieve this realignment. They include the amendment of Mental Hygiene Section 4143 in ways that will codify the clear legislative intent detailed in Chapter 552, and amending the FSS appropriation language during this cycle to ensure that OPWD is investing the full amount budgeted by the state of New York for family support services. Properly targeted, family-driven investment in these heroic caregivers is not only the right thing to do, but it is among the most responsible and effective investments that can be made as we work to ensure the success of our entire system of care and the families who rely on it every day. It's really quite simple. Making families stronger will make the entire system of care much stronger. I thank you for your time and the opportunity to speak with you today.
Good afternoon, Legislature. My name is Dr. Natalie Ferguson. I'm the Assistant Director of Nursing at SUNY Downstate Medical Center. I'm a domestic abuse survivor. I'm a doctorally trained nurse practitioner, and I'm also the mother of a son with multiple special needs diagnosis. And I have to say, through all of that, the hardest thing that I've ever had to do was to fight for services, advocate for services for my son. I almost gave up. I moved to a completely different neighborhood that I heard had better services than the one that I lived in. And it was a never-ending battle to get services from OPWDD eligibility, to get approval for the HCBS, also to the self-direction launch. It took a lot of months. The most recent housing application budget that I did for my son when he turned 21 was also a nightmare of epic proportions, coupled with administrative barriers and vetting obstacle. It takes an incredible, incredible amount of perseverance and persistence to get through that process. Most parents, unfortunately, do not have that perseverance. Most recently, about 8 months ago, in my hospital, the security department called me because there was a mother who was screaming in the hallway of the hospital. She had her son was in a wheelchair with a helmet on, and he was banging his head against the wall. She was crying uncontrollably, saying that she did not want to have him anymore. She was overwhelmed. She could not do this. She was in complete and utter stress with the whole situation. They called me because they know that I am the mother of a special needs son, and that if I can offer assistance as a nurse practitioner. So I went down there to the clinic, and after I made sure that her son was safe, I proceeded to speak with her and to give her support. She had no idea what respite is about. She'd never heard of self-direction. She never knew what community services was all about. When I explained to her that she was not a bad parent, she was just in need of help and support, she was so happy for that, that at least she knew that she was not the one that was a bad parent. However, it's been 8 months now and she still hasn't been able to receive the services that she applied for. And it took me with the housing to get the housing approval for my son 9 months. It is a never ending stressful situation. I humbly ask the legislature to please pay attention to the barriers which cause these delays and to make the process for parents simpler and easier to navigate. Thank you.
My name is Jim Karp, and I'm here representing the Coalition for Self-Direction. You have our written testimony, which has detailed proposals. What I hope to do in the 3 minutes that's allotted me is not to talk about specifics, but talk about the general aspiration that we have here in New York State. And we have grand aspirations. We closed down Willowbrook and we moved people into community, and we wanted people to live lives of dignity and meaning. And that is possible in our system. But we have also drifted, and we have circumstances, as my colleague and fellow parent Chris mentioned, where only half of the money devoted to family support services, less than 50 million of the 97 million allocated by the legislature, has actually been paid out. We have circumstances such as my colleague and fellow parent Natalie mentioned, where she has had to fight. And this is a woman who has a doctorate. And the hardest thing she's done is navigate our system of care. And she encounters routinely at the hospital where she works people who are unable to navigate. Nobody wanted this. Nobody designed this. We've drifted into this because we have great expectations, but then when it comes time to trim the budget, this family support pool of money, that wasn't spent last year. Let's not spend it again this year. We don't do enough innovation. There are innovative parents out there creating new models. There are innovative providers out there doing new things, but all too often they smash up against the regulations, the limits that go along with the strings that are attached to the medicization, the waiverization of everything. We need to bring back innovation. We need to bring back that innovation fund that the commissioner made mention of, that we no longer have. We need to bring grace from OMH into OASIS into OPWDD. We need to have outreach into communities such as Natalie's. We need to free up the creative impulses of people as opposed to squashing them. Thank you for your time today. I know I'm preaching to the converted. I know that you see the lack of coordination, the barriers to access, and I will just end with a shout out to Shanika. I didn't want to clap during hers, but I wanted to. Thank you for your time.
Senator Fernandez.
Thank you. To the last speaker, could you just elaborate a little bit of the current barriers that exist? Because I know I know, but can you say for the record?
Yeah, so there's all sorts of barriers. We see that the rate at which children 8 and below are approved for the waiver has plummeted. It's gone from almost all of them who have gotten OPWD eligibility to it, and really the barriers are a combination of things. There's Medicaid rules. There's the state interpretation of Medicaid rules. So Medicaid rules are out here. The state interpretation is much narrower. And I think it's all based on the idea that we want to be a good steward of the taxpayer dollar. But what we're doing is we're actually being a bad steward. My son is in self-direction. He lives in his own apartment. He works part-time at Trader Joe's. He travels independently on the New York City subway system, despite having an IQ of 55. This is all enabled by self-direction. And this wonderful life of dignity and choice that he lives was enabled by the services that people are now having difficulty getting access to. And all this is possible to him cheaper than if we put him into a group home and sent him to a day hab.
Thank you so much. No further questions.
Senator Simon? I'm sorry. I give you demotion. Assemblywoman Simon.
Oh. We can talk, yeah. There's so much moving around these days, anyway. So thank you all for your testimony. I think one of the things that it comes through is that we have a lot of work to do. Now, were you guys here to hear the commissioner of OPWDD? She appears to be trying to take a different tack with the organization. Have you been involved or contacted? Because she seems to be reaching out to stakeholders. I'm curious, from your perspective, how that's going.
I've been kind of honored to have a number of conversations with Commissioner Bear. I've found her to be very engaging in presenting in a way that is, it strikes me as being incredibly non-defensive, right? So one of the conversations that I've tried to have with her is the importance that we're able to sit and have authentic conversations, that we're able to sit and be able to talk about the truths that we see and be able to discuss those in an environment where we can walk away and then have a cup of coffee, right? So I've been very impressed. I've seen, she's a third commissioner I've seen now. In my personal opinion, I feel regardless of how challenged the Family Support Services program has been and remains. I, in fact, commented to her this morning when I spoke with her that I feel better right now about the position that we're in because we have a strong foundation. We have a group of people who are now advocating around it. And I think we have a commissioner who truly believes in the value of family caregivers and understanding that being able to leverage what has to be the most dedicated, most experienced, most productive workforces in the state of New York, which are family caregivers supporting IDD loved ones at home. So I have a lot of hope.
From the provider perspective, this commissioner is remarkably genuine in her engagement with provider organizations. And that is incredibly appreciated. I also want to point out the fact that we are dealing with an incredibly antiquated system, I believe, and we're going to need that kind of genuine partnership if we're going to be successful in kind of bringing this into the 21st century, quite frankly. There's a lot of things that have been discussed here. There are lots of other things we could discuss, but the willingness to engage in a genuine conversation about those things and find places of commonality is remarkably refreshing, and we will need that if we're going to be successful at all.
Great, thank you.
Yeah, and
Anybody else?
I appreciate the candor that the fresh perspective that this commissioner brings. She brought to the table today information that in the past we would have had to have foiled about the number of housing subsidies available, that kind of thing. So much appreciate the movement. Still a long way to go, but better than it was.
Senator Fahey.
Thank you.
Thank you, chairs, and thank you to this panel for your extraordinary passion. And just piggybacking on what a few of you said, I think I appreciate your note about the commissioner being forthcoming, including on the housing slots. I think that was at least one of my questions earlier today, and I appreciated her frankness in talking through that as well as talking about the challenges. Also, hear you on the 2.7. We're all in. Trying to continue to advocate there, and I really appreciated the shout out on legislation I carry on the CareForce housing grants because there's just so much needed there. The Innovation Fund. One of you mentioned the Innovation Fund, and if I heard it correctly, you also mentioned the Grace Fund. Are you talking about the one that came up earlier today about the guided recovery action with through congregational engagement. Did I hear that right? Is that the Grace Fund?
Yeah.
you were
So
referring
one
to?
one of the benefits of showing up at these hearings is we get to some cross system information. And so I was so heartened sitting with Natalie to hear, because we were talking on the way up here about outreach into community, and to hear that, once I pass it over to you, Natalie, to hear that that's going on in another
Okay.
sector, it's like, let's bring it over to OPW.
Okay. I've got a few. Well, go ahead, but I've got a couple other questions, and time is running. Thank you.
Yes, the outreach with OPWDD has been very. It's been starting. It's definitely in the right direction, especially in the neighborhood that I work in. SUNY Downstate Medical Center, as you know, is in the Flatbush area. Very low socioeconomic environment of high Blacks and Latinos. So the outreach really needs to be started where we can start to bring it to where the patients are, where they
Yes.
can access it.
I have another question on self-direction, and this can be for any of you. The concerns on the self-advocacy, as well as the updates on the CAS, the Coordinated Assessment System. Just wanted to see if that is helping, not helping. Is some of this, that the paperwork that each of you described, or not the paperwork, the process that is so difficult? Please feel free to continue where you were, Ms. Ferguson, or Dr. Ferguson. In terms of what is it, automation that we need? And we're down to 20 seconds.
The process needs to be sort of simplified. A lot of parents, when the different applications and forms that they see is so confusing and complicated for them that they have no idea where to start and how to follow
Is
through.
it automated? Is all of it automated or not?
Not.
Okay, thank you. Thank you, chairs.
Thank you, Assemblyman Santa Barbara.
Yes, thank you all for being here. Thank you for your testimony. I want to thank the New York Disability Advocates, Mike, for bringing us together early before our session even started to talk about the CareForce Affordability Agenda, and it is a package deal. And we've been talking about the inflationary increase. Earlier today, the commissioner said 1.7 seemed like a significant investment, but it's really not. That 2.7 is really what we talked about being the bottom, really. We should be asking for more than that, but I think that's where we wanted to end up in the budget. But and I'll give you an opportunity to talk about that. But I also want to talk about the entire package, because it's more than just that, right? The affordability has been a topic of discussion. So affordability applies to everyone, including DSPs. So DSPs, we're talking about housing assistance, childcare access, healthcare protections, and incentives to help them stay in their community, because that's what's happening. They're not able to stay in their own community, and that causes disruption in service. So you've done a very good job of explaining that, and I just want the panel to be everyone here to be able to hear that connection and why it's so important. And lastly, the investment in the infrastructure, the homes, just like our own homes, making sure we have modernized facilities, and that has fallen behind. So these three categories all require investment. So it's not just a targeted inflationary increase. It all has to come together, and it has to happen as a package in this year's budget. So there's about a minute and a half left. I want to give you time to just expand on that and talk about how this has to be a cohesive win in the budget this year.
You've said it already, but I'll reiterate it quickly. If you're looking at these as one-off investments, that's not the way system change works. And much like we were talking about things before, with either transportation or employment or other things, they're all linked. There's all connective tissue between these things, much like these types of investments. If we're going to make investments in a sector to allow it to maintain what it already is able to do in relation to inflation, we also need to be making other strategic investments to make this a care force that people want to work for. You know, that we're going to make that easier in the housing department. We're going to make that easier in the health insurance department. We're going to make that easier in the child care department. Those are things that start to make a package deal that makes it a much more attractive job to be starting to move into this sector and be in this work for people who want to be in this work already, who are naturally inclined, like was talked about before, who are passionate about these issues. who want to be here and don't want to be going to another job because they can't make ends meet. We need to figure out a much more comprehensive way to address all of these things, and we think we're putting some of those things on the table for consideration in this budget.
And I think in the discussions, we do need to, as I said, the focus is always on that increase, and that's important, getting that targeted increase. But I think the conversations really need to encompass the entire package that you put together that really makes a lot of sense and will keep our system stable for the future.
Senator Rollison.
Thank you, Madam Chair. I just wanted, I may have missed something when, Jim, I think you were talking about 50 million spent of 97 million. And could you elaborate on that?
I'll get started and then I'll pass it over to Chris Palega. The commissioner actually gave us that figure today, that 50 million of family support services was spent last year. The legislature has appropriated for decades now 97 million each year, but there's a number of reasons why that didn't get spent. It's mostly neglect. And this is, as Chris said in his testimony and will carry forward, it's money that supports people who are living in the family home, that keeps that family so you don't end up like Natalie's patient lying on the floor screaming, "I can't take it anymore." That's what we're trying to prevent, but through benign or malign neglect, it's gone from 97 million down to below 50. Chris?
And I think it's a little deeper than just benign neglect. I think a lot of it has been policy driven, right? For years, there's been an allocation for $97 million for the provision of supports for family support services. I don't believe I've ever seen a time in the 7 or 8 years I've been in the milieu where the amount of money that we actually had under contract, the amount of money that we actually maybe intended to spend was more than 60 million. If you look at the actual money that they dispersed from 21-22 to 22-23, the actual disbursement went from 47 million down to 41 million out of the $97 million that this legislature tried to allocate for the provision of services to the families who are critical to the success of the entire system. That disinvestment is policy driven. There's the vehicle that we use to replace programs, FSS programs across the state, as they close, as they're reduced, as they're underutilized, an RFP process. That process was put on hold in 1999. We have an RFP that's been out. We are waiting for final awards on it. It's been 6 and even 8 and 9 years in some areas since there's been an RFP to cover that churn that's gone on. That's policy driven. And it goes on.
And then, Chris, there's also an ADM, right, that made it more restrictive?
The ADM there's an ADM that came out in 2022 that's created tremendous barriers to access, right? If you look at your own legislation, Chapter 4143, Paragraph C talks about, for the purposes of this section.
Thank you.
Thank you for the explanation.
Senator Cancenari Fitzpatrick.
Thank you, Chair. My question is directed at Mr. Karp. I read your testimony for today, and I understand your concern about having a child that needs constant support, and you're getting older. And I saw that you, so my first question is, how do we address that? But second, then you also mentioned this pilot program PASS that you wanted to roll out in the coming year, and I just wanted you to speak to those two issues.
Appreciate that. Yeah, and I was celebrating, if that's the right word, my 65th birthday last year. And based on what happens to men in my family, I will be lucky to have another 10 or 15 years. So I want to have right now my son's program, his life of dignity and choice, depends upon me as his champion and also me as the doer of administrative tasks and the smoother of obstacles. His fiscal intermediary recently said that he would have to log every trip he took on the Long Island Railroad going forward if he wanted to get reimbursed. He's incapable of that. So they essentially said, we're no longer going to pay you for that because you can't log it. Well, we could have, it costs $4.50. We could have a burden cost of $50 an hour. ComHab staff go along with him to log it. That's ridiculous. So what we're doing is I've gotten together with several fiscal intermediaries to define what it would look like to actually have a program of not only sustainability, but also access. So access and sustainability, making it easier for parents to maintain these systems. What we want to do is we want to prove on a large scale and document it what it takes to actually keep somebody in a self-direction program. We think that most of those tasks can be taken care of at a relatively modest financial increment, which would allow my son's program and the other, we're up to over 37,000 people now in self-direction. We want to be able to maintain those programs after the parents are gone. And it doesn't take that much money to do the administrative work. If we reduce the administrative burden, it would take even less. The hardest thing that we're working on that I haven't figured out yet, and that's what we need to figure out, is how to maintain a champion for the individual after the parents are gone. But there's ideas about circles of support that have been implemented in other. So thank you for the opportunity to explain.
Thank you.
And I feel bad about all you guys with your blankets and such. It looks like you're freezing up there.
Thank you. Assembly.
Assemblyman Stick.
So I have a question for Mr. Alvaro. So if everyone is, maybe you are a substitute, but anyway.
Yes.
Yeah, you did say that at the beginning. I apologize.
No problem.
But if we are contending that the legislature votes this money, right, and then it simply isn't spent, why doesn't anyone ever bring a Article 78 proceeding to compel the expenditure of the funds? The legislature can only vote the money. We can't force it to be spent. Sadly, it requires enforcement. Anybody can comment.
Yeah, I'm trying to understand where that enforcement comes from, right? We have very little power to go to OPWD and say,
No,
look,
no. You have to go to court and bring an Article 78 proceeding, which is also called a writ of mandamus, which is to compel the government to undertake an act that is required by law to do. And, Article 78 proceedings are not that expensive in the grand scheme of lawyerly things. Unfortunately, we can't compel them to do it. We are in the same position as you are. We can only ask.
I will definitely consider that and look into how that fully functions. I don't fully understand how that applies to this particular situation, but if it does, I'm certainly willing to look
If
into
they
it.
are required by law to spend the money and they're not doing it, then the court could compel them to do it.
Again, I think one thing the legislature can look at is what is that appropriation language? Because the state likes to point out to us that there's the appropriation, but then there's the cash provided by the Department of Budget. And apparently there's a lot of discretion within the law for the Department of Budget to choose to only give 50 million, even if the legislature says 97.
That is a fair point, and certainly the legislature can be criticized for too much delegation of authority to the executive branch.
Yeah, and the other aspect is just to understand that parents, having gone through hell and high water to get services, are on the edge of exhaustion, and it's hard to find somebody who's okay. Now, in addition to everything else you're doing, bring a case to court. And there's a fear, I don't think it's a justified fear, but there's a fear of raising your head above the parapet.
Well, I know from some organizations in my area, they're afraid to bring proceedings, so they think there'll be retaliation, but otherwise you got to do something, though.
We've gone through all the people who wish to ask questions. Yes, we have. Then I want to thank all of you for your advocacy on behalf of your family and others. And yes, it's quite a challenge. But, you know, it's one of the great things about our system, for all its flaws. You are allowed to challenge when you believe it's not doing what it is intended to be doing, or even what the law says. Perhaps that's the reminder for our entire country every day lately, that if they're not doing it right, you have to take them on. So thank you very much for playing that role today here at our hearing. Thank you. And I'm going to call up Panel E. Drug Policy Alliance, Tony Smith. Alliance for Rights and Recovery, Luke Sikinia. I think I pronounced that incorrectly, but it's a replacement for Harvey Rosenthal, who can't be with us. New York County's Defender Services, Stephanie Basil. Local 372, New York City Board of Education employees, Donald Nesbitt. And New York State Harm Reduction Association, Emma Fabian. We'll just let everybody get the chairs set up.
We have 42 minutes of testimony left.
Okay, you counted that way. Okay. That's not so bad. Okay. Good afternoon, everyone. And shall I start with the Drug Policy Alliance? Is that all right? And then we'll just go down the row from there. Okay. And each of you get 3 minutes. So when the buzzer goes off, you stop, the next person starts. Hello.
Hello. Good afternoon, chairs, committee members. The Drug Policy Alliance appreciates the opportunity to testify here today. DPA advocates for a holistic approach to drugs that prioritizes health, social supports, and community well-being. We support the Substance Use Prevention, Education, and Recovery Package, the Super Package, a slate of bills that will strengthen funding for substance use care across the state. In addition, we support the Drug Checking Services Act, which would codify the community drug checking program. After years of increases, overdose deaths in New York have begun to decline, a direct result of expanded harm reduction. But Black, brown, and low-income New Yorkers continue to die at the highest rates, and still over 4,000 New Yorkers died of overdoses last year. As New York faces steep federal funding cuts, the state needs sufficient dedicated funding to support the millions of New Yorkers who rely on services related to substance use. We have existing funding streams we can build on. In November, DPA released a report examining the first 3 years of New York's opioid settlement funds. Our report recommends strengthened reporting to ensure these funds are being spent supplementally as required and not supplanting other funding streams. We also have the Drug Treatment and Public Education Fund, which was created by the Marijuana Regulation and Taxation Act and is funded with adult use cannabis tax revenue. As with opioid settlement funds, this fund must be transparent and it must prioritize communities most harmed by the war on drugs. The Super Package will grow this fund with appropriate tax revenue and strengthen the fund's transparency and allowable spending. In addition to securing sufficient funding across the continuum of care, we need to protect harm reduction services, which are most targeted by federal funding cuts. On January 7th, in response to a series of hostile substance use-related funding cuts and directives by the Trump administration, the Senate Finance Committee Democrats released a memo warning that the Trump administration is mounting a sweeping assault on Americans living with mental health conditions and substance use disorders, and ignoring overwhelming evidence that harm reduction programs save lives, reduce overdose deaths, and lower healthcare spending. 6 days later, SAMHSA terminated approximately $2 billion in grants across the sector. Although Outcry successfully got the cuts restored, we are certain to see more erratic cuts, with a particular eye toward harm reduction. New York has a robust harm reduction infrastructure that includes syringe service programs, drug user health hubs, overdose prevention centers, supply distribution, and the community drug checking program. The Community Drug Checking Program was established in 2023 with Governor Hochul's championship and is enabling the Department of Health to provide earlier and better public health data. But the program has been operating for nearly 3 years without codifying legislation. The Drug Checking Services Bill will rectify this gap. We urge the legislature to pass the super package and the Drug Checking Services Bill. Thank you.
Thank you.
Good afternoon, chairs, ranking members, and esteemed legislators of your respective committees. Thank you for the opportunity to be able to present testimony on behalf of the budget this year for Local 372 under the leadership of Sean D. Francois, the first president, representing our SAPIS counselors, Substance Abuse Prevention and Intervention Specialists. Since 1971, the SAPIS counselors have provided a range of mental health and intervention services to the largest school district in the nation. Through teaching social-emotional strategies and offering all behavioral support available to our children so they are ready to learn. They do this in individual settings, and they do this in group settings. And they use evidence-based programs to do this. SAPIS serve K through 12 throughout New York City's 32 school districts, including special education. SAPIS has always been proactive in providing students and their families with tools to navigate the myriad of societal, personal, and peer pressures that they deal with on a daily basis. In previous budgets, union colleagues in the legislature were constant champions for our students through funding the SAPIS program. In fact, we thank Chair Steck for being an advocate in the previous years and commend Chair Fernandez for leadership in the Senate last year in making sure that funding was available. It is willing leaders like yourself and your colleagues in the legislature that assure us that the needs of our children will not go unheard. Notwithstanding, while we appreciate the $2 million that has gone into the SAPIS program, it is not enough to maintain SAPIS and ensure the efficiency of our children. Taking already the reduced budget, the rising cost of living impacting our families due to inflation, losing SAPIS workers due to retirement, and rising needs for services tackling the mental health crisis, we need more funding. The students in New York City reside in the state's most undeserved regions, experiencing trauma daily. New York City is in the midst of a deepening youth and mental health crisis. Nearly 40% of the city's high school students report personally being sad or hopeless on a daily basis. Controller Tom DiNapoli issued a report just this week that showed outdated definitions in drug-related and bullying reporting that led to misreporting. So we really don't even know the full impact to our students. The Office of Juvenile Justice and Delinquency Prevention encourages that the use of evidence-based programs are practiced. The panelists earlier on panel B spoke of support for solutions, not suspensions. And we support this fully at Local 372 as long as knowing that our SAPIS are that actual solution.
Thank you.
Thank you.
Good afternoon, and thank you for the opportunity to testify on behalf of tens of thousands of New Yorkers living with mental health, substance use, and trauma-related challenges, in partnership with the Alliance's 85 community recovery agencies across the state work every day to advance rights, recovery, and community inclusion. My name is Luke Sakini, and I'm the Vice President of Public Policy at Alliance for Rights and Recovery. The priorities I'm about to share today reflect what we've heard consistently at 14 regional and statewide events across New York. There was one thing that was clear. While the governor has made significant investments in mental health, far too much of that funding continues to flow into psychiatric hospitals and inpatient beds rather than the community-based services that actually keep people well and out of crisis. Most recently, the state announced $43 million for hospital services, including $20 million solely to expand inpatient bed capacity and another $23 million for CPEPs. This is on top of prior budgets that added 1,000 state and community hospital beds and even advanced $100 million for a 100-bed forensic facility on Wards Island that we will not see be operational for years to come. Meanwhile, community services and the workforce remain under-resourced. Our members are deeply frustrated that tens and hundreds of millions of dollars continue to be directed towards the most expensive and restrictive parts of the system, which serve the least amount of people, when those same dollars could be used far more effectively for prevention, peer support, crisis response, housing, rehabilitation, treatment, and reentry services. We cannot build a recovery-oriented system by endlessly expanding institutions while starving our community services. Workforce stability is the foundation of everything, and that is why we join our partners in calling for a 2.7% target inflationary increase for mental health and substance use services. Without it, agencies cannot retain staff, services cannot operate, and access will continue to shrink. Workforce investment must go hand in hand with continued investment in supportive housing and carving out behavioral health services for Medicaid managed care, which has created unnecessary administrative waste and continues to siphon hundreds of millions from our system. In our last few moments, I want to talk about Daniel's Law. Last year's $8 million investment into mental health first responder pilots and the Behavioral Health Technical Assistance Center was critical, but these funds have to be stretched over the next 3 years and will not allow for robust services if we do not continue to invest in this. That's why we are calling for an additional $8 million to support the Behavioral Health Crisis Technical Assistance Center, as well as those pilots to really show the need and the effectiveness of these programs. Additionally, we also support the passage of the Treatment Court Expansion Act, Forensic Rehabilitation Act, the proper implementation of Raise the Age, and call for a commission to consider closure of state hospitals and the consolidation of those to reinvest those funds into the community. Thank you.
Hi, and thank you for the opportunity to testify. My name is Stephanie Bizel, and I am Senior Policy Attorney at New York County Defender Services. We are a public defender office based in Manhattan that serves more than 10,000 clients in criminal cases every year. We also lead the Treatment Court Expansion Act campaign, which would amend the Criminal Procedure Law Article 216, the Judicial Drug Diversion Statute, which established drug courts in every county, by updating it to reflect best practices and ensuring mental health courts are established in every county across the state. The criminal legal system has become our de facto mental health system. Rikers Island is, for all intents and purposes, our largest psychiatric facility in the United States. In 2024, a whistleblower exposed widespread practices of deadlocking, or locking someone in their cell for 24 hours a day without access to meaningful human contact, food, water, or even medications when they were in the midst of an acute psychiatric crisis. This is not only widespread, but it goes beyond Rikers. And this is all happening while crises are increasing. OMH caseloads are increasing, rates of suicide rates in prisons have doubled, and rates of serious mental illness on Rikers are increasing. And this is against the backdrop of a collapsing prison system. We're relying on 18-year-old correctional officers. What people have done in response is create ad hoc mental health courts, but those are geographically inequitably distributed. Where you are born should not determine if your mental health challenge is criminalized. What's the solution? The Treatment Court Expansion Act. This would stop the cycle of incarceration by addressing the root cause of criminal legal involvement. It would connect our most vulnerable citizens to services they are unlikely to otherwise access. It would have downstream benefits for all New Yorkers. We are asking for $51.4 million as estimated by OCA and an additional $75 million for treatment providers. That is a substantial ask, we know, but there's precedent for this. CPL 216 also asked for a large sum of money, but it had enormous cost benefits that inured to the state, and millions of dollars that came back because it made the criminal legal system far more efficient, and it was done during the time of financial recession. So there is precedent for doing this, and it was during a time of fiscal austerity, just like we are in now. And thus, it is a financial imperative and a moral imperative that we pass the Treatment Court Expansion Act, and we urge you to do so in the budget this year. We cannot afford to wait. Thank you.
There we go. Good afternoon. I'm honored to be here today. My name's Emma Fabian, and I am the Executive Director of the New York State Harm Reduction Association, or NYSRA for short, a statewide network of harm reduction providers and advocates serving people who use drugs and people living with substance use disorder. Many of our members are the types of providers who conduct syringe services, naloxone distribution, outreach, and other low-threshold drug user health services funded by the Department of Health, and also many receive some support from OASIS and OMH. For the past 11 years, I oversaw programs like that in Buffalo and Jamestown. We're at a critical moment for harm reduction and the entire continuum of care in New York State. While overdose fatalities have decreased or plateaued in some areas, we know that any loss of life to drug-related harms is too many. And importantly, overdose rates are not declining in Black and Brown communities, including in Erie County where I live. Furthermore, federal opposition from the federal administration seriously threatens our efforts to care for vulnerable community members. We're urging the state, therefore, to look at the AIDS Institute and the leadership it has shown for decades in community-based, health equity-driven public health responses. The AIDS Institute was established within DOH in 1983 in response to the HIV and AIDS epidemic. At that time, HIV prevalence among people who use drugs in many parts of New York exceeded 50%. Because of AIDS Institute interventions like syringe exchange, people who use drugs now account for less than 1% of new HIV transmission statewide. That is one of the most successful public health outcomes ever in New York State, possibly in the entire country. Today, the AIDS Institute's Office of Drug User Health oversees syringe service programs, drug user health hubs, naloxone distribution, low-threshold buprenorphine, and more. Most of us think of OASAS when we think of substance use, and understandably so, as they provide life-saving treatment programs, but the AIDS Institute's role in serving people who use drugs cannot be overlooked. We're asking that the AIDS Institute receive a significant share of opioid settlement funds, that its budget be increased and include the drug checking services bill, which was mentioned earlier by our colleagues at Drug Policy Alliance. And I also want to lift up the so-called revenue raisers, which I think are very innovative, including strengthening the Drug Treatment and Public Education Fund, thank you, alcohol excise tax, and redirecting the opioid excise tax. In the last 20 or so seconds, I want to raise up the fact that when I was growing up, my father worked at a hospital that had a syringe exchange program. And because of the harm reduction approach that they took, he wasn't invited to sit at the table with treatment and recovery providers. Now, today, I've had the opportunity to sit with folks from Friends of Recovery, who I just saw come in, and shake hands and hug people from In Unity, the traditional treatment providers. We can't let the federal administration's attacks on harm reduction services and vulnerable people take us back in history. Thank you.
Thank you so much. I don't want to cut you off. So I'm going to, I guess, man the fort right now. I'm going to ask my 3 questions, and then we'll go to other senators that would like. Start the clock. But thank you so much for your testimony. I did just want to mention, I guess, the bills of mine that were mentioned, S56, which is the codifying of the drug checking program, which, to a question from one of the senators before, is the tool and the solution to knowing what is in the supply out there so people can make the best educated decisions. And the super package, which stands for Substance Use Prevention, Education, and Recovery. These are the revenue raisers that you spoke of to help fund the services that we have. Can we speak a little bit about, and anyone can take it, about recovery and I guess where it lacks compared to the other services that we have? Because we know harm reduction is funded. Of course, we could always use more, but in terms of recovery services, how can we strengthen support with the money, if it's there, to help people?
I think one of the biggest things from the recovery services is a lack of coordination. I think we talked a little bit from a panel earlier about some of the services that we have. Often services are underfunded and also unconnected.
And is it true that the opioid settlement dollars do not cover recovery services?
That I cannot answer myself.
Oh, I do think that there are speakers planning to highlight some of the challenges with the opioid settlement funds coming up later, including folks from Friends of Recovery, who I think are on the panel late in the day. So that might answer some of those questions better.
Okay, we can get to them later. In terms of recovery in the workplace, Mr. Nesbitt, you are representing DC 37. Could you highlight, to your knowledge, any support systems that a general workplace has for people in recovery?
So the city's mental health, for city employees, the city's mental health services, the MLC, the labor committees actually push for better mental health services for city workers. There's been reports that workers who are finally at the point where they can say, "Hey, I'm addicted to this. I want to get off." They go months before they get services. And so the municipal labor committee, we're pushing the city to do better in providing mental health services for workers. These are people who are servicing our children, work at EMS, in our parks. DC 37 has a range of members who serve in several different capacities. For services for them, should they need some type of services, counseling, and things of that nature, it's just not sufficient.
It's not. Okay. Thank you.
Assemblywoman Simon.
Thank you. Thank you, Mr. Chair, and thank you to all of you. It's really impressive testimony and stuff we all need to hear. You know, I wanted to ask a couple of questions. One is, Mr. Nesbitt, you mentioned SAPIS, right, which is, you know, your folks who are working with young people in the schools. Can you tell us the number of folks you have that are SAPIS? Because that's always a program that potentially doesn't get funded, and then we fund it later on. And I know that there are many fewer of them than there used to be. If you could just address that issue briefly and what kinds of service they provide.
So SAPIS, they help children navigate. They do prevention, they do intervention, they help our children navigate bullying situations. They teach anti-bullying. There's a whole range of things that SAPIS actually do in preventing our children from going down the wrong path, right? Things that may deter them from healthy academic success. But there's 236 of them servicing 1 million children. They're stretched thin. I like to say they're our sheroes and heroes, but they're taking on a mighty task and often have to figure out who needs which group of our students need services more. That just shouldn't be something that they should have to bear themselves.
Yeah.
And assess themselves. There just should be more funding, more SAPIS. If you look at in high schools alone, if we had a SAPIS in every high school, there's 534 high schools in New York City. If you add a SAPIS to the high schools currently, with the 236, their range is 500 students that they can reach per SAPIS. They're reaching 118 out of 1 million. Okay. If you add them in every high school, they can reach 267,000. So certainly is not all of our children, but it's a path in moving in the right direction.
Great, thank you. And Luke, you had mentioned about the Daniels Law pilots and the concern about ongoing funding, because we have $6 million for 3 years, which is not a lot. Can you talk a little bit about what would happen if we didn't have those and the need for additional pilots?
Yeah, I think the first thing is, police intervention has led to a lot of harmful interactions between arrest, death, and other harm. The other thing I would also add is the $6 million is being stretched over 3 years, but there's no guarantee of what happens afterwards. And counties who are helping to stand up those resources and that infrastructure will be looking to make sure that they don't have to bear the burden of those costs long term or have to close those programs. So we need to make that investment to ensure that they are consistent and they can become a permanent aspect of our recovery
Thank
system.
you.
Thank you.
Sorry to cut you off. Next is Senator Leah Webb.
Thank you all for your testimony and for being here. So, a number of things that all of you touched upon, most certainly the way in which individuals who are impacted by substance use disorder and their interaction with our criminal justice system, and then just overall funding structures that we have been doing through the budget and making sure that it reaches all of you who are essentially doing the work on the ground. So I know I asked this question of the previous panel, but if anyone could elaborate further on what are additional best practices that you all feel that we could be supporting as a state, in addition to the funding issues that you lifted up, and most certainly some policy measures. What are some practices that you all are finding to be very productive on the ground? And whoever wants to elaborate on that point. Thank you.
If I could start just by naming a couple things, some of the priorities that the New York State Harm Reduction Association is talking about this year are not only codifying this drug checking program. Again, it's a program that's happening around the state, but we haven't put the bill in place to protect folks who do that program. And furthermore, decriminalizing buprenorphine possession. There's a number of things that we've done to respond to the opioid crisis, the overdose crisis, and kind of acted fast and got resources out into the community like buprenorphine, but we haven't taken the legislative steps to protect people who either take that buprenorphine or prescribe that buprenorphine. So, and the other practice that I would mention is just decriminalizing low-level possession in general. It's one of the reasons why people get tied up in the courts systems in the first place in criminal court.
Anyone else from the panel want to add to that?
I think making use of a true continuum of services in all areas of New York. I think we have done a really good job of standing up individual services, and I commend OMH for the work that they've done to try to connect them, but making sure that each area has things like crisis response for folks who are in crisis, post-crisis services, whether that's a crisis respite for someone who might need some longer support, peer support, thinking about housing as an essential aspect of this, but also a place to go as well, which could be a clubhouse or a recovery center for folks. And finally, just looking at education and prevention more thoroughly and investing more dollars there so that we can stop folks from falling into the stream at the upstream area rather than having to work on purely just treatment and recovery services.
Thank you. Thank you all again for being here.
Assemblywoman Chandler Waterman.
Thank you, Chair. Thank you all for your testimony. I just want to touch on two topics: SAPIS workers. As you may or may not know, and I said it many times, I'm an educator, formerly working in multiple schools, including high schools, but I had to work continuously with SAPIS workers for reducing gun violence in the school. And my understanding, I think you said it, Chair Simon said it, that there's not one per school. Is that my understanding, that each school does not have their own SAPIS, not the building, but each individual school, because some schools have 5 schools within it, right? Some campuses.
So, Local 372, we've advocated, President Francois and myself have advocated for SAPIS to be in every school because they're just not. They're not a mandatory staff member, so it's optional for a principal to choose to have a SAPIS within their school. And that goes back to my statement earlier. You're assessing to see which child, which student needs services more. That just shouldn't be. That shouldn't be a system where we're picking and choosing who may need services more. We know our children. We haven't even had a full assessment of the impact of what COVID has done to our children, their mental health. And so we just need more. We advocate for more. But to your question, no, there isn't a SAPIS in every
That's
school.
unfortunate. We, as I did pushing services, SAPIS workers was a great support for the teachers, for the community-based organizations, and in addition to the expansion of community schools, we need an expansion when it comes to SAPIS workers. You want to say one more thing before I
Yeah,
get to the next topic?
just wanted to add something real quick that I missed. So people look at the aspect of what SAPIS do in prevention for our students. Should a child fall down the line of where they having mental health issues or drug abuse, the SAPIS also convenes the family together and
Yes.
provides services for the entire family.
Exactly, holistically.
It goes beyond the school.
And so that brings me over to Daniel's law. So I know you was in the middle of saying a thought, Lou. I don't know if you want to finish that thought because we know we need expansion and fully pass Daniel's law and we need more money investments. I agree. I know we all agree with that, but I'll give you the floor.
Yes, yeah. I think the biggest thing is really making sure that these programs, the pilot programs that will be awarded, are able to expand to 24/7 so that they are available for support like any other emergency service, and also have a wider range for the sort of scope, the area that they serve, so that more people can receive these support services, but also so that we can get the data to show that this is a better approach to crisis response than our current approach, which is police-led and often leads to a lot of negative outcomes.
All right. Thank you so much. The work you do is very important, and we want to definitely push for these expansion and more investments so it could be holistically taking care of the whole entire community, especially in our Black and Brown communities. We need a person center. We need culturally relevant services as well. So thank you so much for embodying that. Thank you to all of you.
Thank you. Excuse me, Senator Calzari. I've done it. I've been so good with your name for days.
Canzaneri.
I know, and I just blew
Fitzpatrick.
it. I apologize.
That's
I thought
okay.
I had
That's
it down.
okay.
Calzaneri Fitzpatrick. It sort of flows off your tongue once you have it.
Thank you, everyone, for your testimony today.
It's late in the afternoon.
That's it.
It's early.
My questions are to Mr. Nesbitt. I read your testimony, and very troubling is your comment about the explosion of illicit cannabis shops in close proximity to schools and the increased student use of cannabis. And I'd like to know, what do you think as a state we should be doing to assist you, other than the obvious of trying to crack down on these illicit shops? But what are you seeing that you think you could offer today?
Well, I think the OASIS does a job OASIS actually funds the SAPIS program. They fund campaigns to deter children away from those institutions that can be harmful to them. I think a key component too that I miss is SAPIS actually live in the communities that they work. It's a huge statement when I can say to a student, stay away from there because I'm going to call your dad, I'm going to call your mom, right? I can think my years of working in the school, living in the community that I worked in. I was able to stop gun violence in front of my school. I was able to deter kids away from places. And SAPIS, in their capacity, I think living where they work is a tremendous, you can't put a price on that. So I would say funding more SAPIS within schools across the state. I think someone last year at the panel asked about outside of New York City. We would advocate and definitely support that. Services for children anywhere is important.
Okay. And then you also had in your testimony about the creation of the multidisciplinary crisis intervention teams in 2024. And I think you spoke about it before, but I'd like you to try to give us a snapshot of the success of that program and what else can we do to support that program.
So those programs often within the school system, you have crisis programs that may not include a SAPIS because you don't have SAPIS in every school, which is teachers are being tasked in those programs to learn something new, to add social emotional components to what they are doing. A tremendous job for our children. You're adding more tasks on a teacher to do when SAPIS have been doing it since 1971. If we added SAPIS to every school, it would relieve the teachers and administration of the burden that they have of adding more and more and more on our teachers. And every time we look around, the teachers are learning something new. When you don't reinvent the wheel. They've been doing it since 1971.
Thank you.
Assemblymember Steck.
So, just as a footnote, we're strong supporters of SAPIS here in the Assembly, and it is a joint program that is funded by the state and the city of New York. We have legislation to expand it statewide. We're such strong believers in this program. OASIS does not really have anything similar. They have certain volunteer type things, but nothing professional like SAPIS. But my question is for Ms. Bazell. My first question, did you seek to have OASIS include your proposal in the OASIS budget? Not OASIS, I'm very sorry, OCA. You mentioned OCA. Did you seek to have it included in the OCA budget?
We did have conversations with OCA regarding this. Their position was essentially that it needed to be enacted on the treatment provider side. So their money needed to come from the treatment provider side first before they put it in their budget.
Well, in response to that, I would point out that OCA is seeking a 7.5% increase in its budget amidst declining caseloads, while the increase in the OASIS budget was 0.1%. So it might seem that you would have more success on the OASIS side. I wanted to ask Ms. Fabian, there are drugs that are often prescribed with medication-assisted treatment to assist folks in their recovery. And one of the difficulties that a lot of providers are facing is that pre-authorization, although it's banned for MAT, is still permitted for those ancillary drugs. And it makes it very difficult because the people that are being treated are not, their medical conditions are such that it discourages them from continuing with the MAT. Are you aware of that problem?
Yeah, absolutely. There's buprenorphine and methadone are the generic names of the most popular medications for opioid use disorder. And then you have various ones for alcohol use disorder and other things. Extremely beneficial at reducing cravings and reducing likelihood of overdose and so forth. And yeah, it's a very big problem, prior authorizations. I think we need to be very concerned, not just about prior auths, but about federal Medicaid changes, what that's going to do for people's access to substance use treatment and mental health treatment, I think, in New York State. That's why we have to really invest in these community-based organizations that act as a safety net.
Yes, Madam Chair. Yeah, well, actually, I did have a couple of questions about the programs that you all advocate for, but in particular, SAPIS. There have been many questions and answers about SAPIS, and in fact, I did know about this program for quite a long time through most of its existence. So it's unfortunate that it has suffered cuts primarily from the federal government, and we try our best to put as much of it back into SAPIS. I have no doubt that had SAPIS maintained the original level of service and number of professionals involved, some of the opioid crisis that we have endured could have been mitigated at the very minimum. So my questions have been answered, but I want to thank you for continuing your commitment to SAPIS and also to our school kids. Thank you. Thank you, Madam Chair.
you all for your participation this evening, your work every day, and we will excuse you and invite the next panel down. So we're on panel F, the Association for Community Living, Emil Slane, the ARC New York, Eric Geiser, the New York State Council for Community Behavioral Health Care, Lori Cole, and Families Together in New York State, Khadija Abdul Aziz. Still afternoon. Good afternoon. It's hard to tell because it's so dark here all the time. All right. Which is Emil Slane? Okay. And then, well, all right, we'll go Emil Slane, Eric Geiser, Lori Cole, Khadija Abdul Aziz, the order that is on the paper. All right. 3 minutes each. We'll just go from 1 to 1. Thank you.
Hi, thank you very much. I'm Emil Slane. I'm the Executive Director of ACL, which represents 100 providers of community-based mental health housing programs, which serve 50,000 New Yorkers living with serious mental illness in the community. These programs are life-changing. They give people the supports needed to help them achieve independence and recovery in the community. And we like to point out that these programs are extremely cost-effective, as all of these community mental health services are. They cost a fraction of what it costs to serve people in hospitals, other institutional settings, or shelters. So you have our written testimony. I'm going to provide a high-level overview of some of the things we're very focused on. We do want to say that we're appreciative of the executive budget, that there is a strong commitment to continue mental health housing and support, and that's important in light of the fiscal challenges and federal changes. But at the same time, there's 2 areas we're very focused on, which are challenging for our members. The first is the 1.7% target inflationary increase. Everyone has heard a lot about that today. That is below inflation. Inflation is 2.7%. You've also heard that over the past 5 years, there's been 15% in adjustments. That has been below inflation by 9%. So this continues to impact programs and services. I want to talk briefly about that our providers have vacancies, workforce shortages, recruitment and retention. The work is challenging, and the challenge is offering competitive wages. So you've heard many people talk about making the choice of working in the field or working someplace else. Our providers are facing increased food, utility bills, things that they can't avoid, insurance, property, and 1% shortfall is a cut to services. They have to keep positions vacant. There may be waiting lists. Reduce services, increase caseloads. They may have to defer maintenance. So that is a significant impact. So we're hoping the legislature can work to close that gap and fund the full 2.7%. I'm going to talk about the $71 million, which is for supported housing rate increases for OMH and OASIS programs. $65 million of that is for community mental health programs, and it represents 2 pieces. $38 million is to continue to support for recognizing property cost increases for scattered site supported housing programs. That's against a gap of $118 million, but it makes sure that we don't go backwards on the property side. And then there's $27 million for stipend increases for supportive and CR SROs, which are facing significant shortfalls. The gap there that we shared was $90 million. So those are positive steps forward to try to preserve capacity, and our members continue to struggle to keep and make ends meet on the CRSRO, supportive SRO side. So even after these investments, if you've seen our written testimony.
Thank you very much. Next up, Eric Geiser.
Good afternoon. My name is Eric Geiser. I'm CEO of the ARC New York, the largest provider of supports and services for people with disabilities in the state. Thank you for allowing me to testify here today. Every year, we come before you asking for the very same thing, an inflationary adjustment. not to grow, not to innovate, just to keep up. This year, as you've heard, we're asking for a 2.7% increase. That request is not ambitious. It's not aspirational. It's really the bare minimum we need just to adjust for inflation. Now, the state has made significant investments into our field in the last few years. Rebasing injected more revenue and funding than we've seen in a decade, and we appreciate that commitment. Those investments pulled us out of a crisis of care. But when you hear about those investments, it can sound like the system has been righted. I'm here today to tell you that it hasn't. Funding to support New Yorkers with disabilities still lags behind inflation over the past 5 years alone. Think about that. A loaf of bread that was $5 in 2020 costs roughly $6.25 today. We're not asking for butter. We have to beg every year just to afford the bread. Those same pressures hit our workforce. We've finally been able to raise wages, but they're still inadequate. Frontline staff are leaving because they cannot afford to stay. They can't afford housing, childcare, healthcare. They can't afford food. That's why we're also urging support for the CareForce Affordability Package. But ask yourselves, why are we asking for priority placement in affordable housing communities for our direct care staff? It's because wages are still so low that many of our staff still qualify for affordable housing. How is that possible? It's possible because we haven't really stabilized the system. We can't innovate or modernize. We can't invest in quality. We can't even make basic operational progress like transitioning to electronic records. And it's 2026. Providers are burning resources every year, advocating for you to cover inflation. People trek across the state to rally at the doorstep, not fighting for progress, just fighting to maintain the status quo. We are tired. All of us here today are tired. Adjusting provider rates for inflation cannot be an annual fight. It should be a given, and it should be a given every single year. New York has a $3.5 billion revenue surplus and the most robust reserves in the nation. And we're pleading with you to ensure direct care workers can meet their basic needs. We shouldn't even be having that conversation. The state can afford these requests, and you have a responsibility to meet them. Thank you.
Okay. Lori Cole.
Wow. Good afternoon. I'm Lori Cole. I'm the Executive Director of the New York State Council for Community Behavioral Health Care. We are 175 mental health and substance use disorder providing organizations around New York State. And that includes counties, includes not-for-profit organizations, and hospitals that offer significant amounts of behavioral health. Before you today is our written testimony, which I struggled to contain. And struggled to contain because we wanted to get everything in that we wanted to say here today. But for purposes of this verbal testimony, I'm going to talk to you about managed care. I'm going to tell you that for the last 10 years, mental health and substance abuse services have been carved into the state's Medicaid managed care program. New York is paying $400 million a year to 15 insurers who are contracted with the state. They are primarily for-profit corporations that are housed outside of New York State, and they are in charge of and have a conflict with what they're hired for, which is to arrange care for these Medicaid members. And the game is to delay and deny care, to delay and deny payment, such that insurers can bank the money, earn interest on it, while we wait for payment, while waiting lists are abundant across New York State, while when an individual in New York with a substance use condition gets a denial from an insurer, and they go to an outside external appeal process, in 64% of those cases, they are overruled. The insurer is overruled. The delay and deny tactics that are employed by insurers who are motivated by profit, not by people, is a huge conflict of interest. We've been in it 10 years. We've done our time. This is a quagmire we have to get out of. The claims denial rates by insurers for mental health services is 60%. In the fee-for-service domain, it's 20%. We can, together, make a stab at $400 million in savings that I mentioned earlier by firing the insurers, removing them from this triangular situation, and reinvesting the money in our systems of care to ensure that gaps in care are addressed, to ensure that you have the money to deliver the workforce TII that you want to deliver. This is a tremendous problem in our system. We're asking for your help. I don't have any more time. Please ask me about the COLA. Okay?
Expect we will.
Okay, thank you.
Okay. Khadjan Abdul Aziz. Am I getting anywhere close?
You were closer in the beginning.
Sorry about that.
That's okay. Good afternoon. My name is Khadija Abdulaziz, and I'm the Youth Public Policy Coordinator for Families Together in New York State. Families Together in New York State is a statewide, family-run, family-governed organization, which means that all of us at Families Together are members of the community with direct, lived experience. Our organization represents families and young people across the state who are navigating behavioral health systems every day. And what we hear from them is both simple and urgent, and probably repetitive from what you've heard all day long. When families reach out for help, they need a system that responds, not one that makes them wait. New York is in the midst of a mental health crisis, and these are not isolated stories. Across communities, parents are doing everything they can to support their children, yet many are met with months-long wait lists, limited provider availability, and services that are increasingly difficult to access. Too often, care only becomes available once a young person has already reached a point of crisis. Providers want to meet this need, but they are struggling to keep programs staffed and open. Workforce shortages, rising costs, and administrative burdens are pushing many providers past what is sustainable. This is why a meaningful targeted inflation increase of 2.7% as the bare minimum is critical to stabilizing the human services workforce, so providers can retain staff, maintain capacity, and ensure families can access the care they need when they need it, not months later. We also urge the legislature to protect and expand family and youth peer support services. Peer advocates bring lived experience that cannot be replicated in traditional clinical settings. They help families navigate complex systems, reduce isolation, build trust, and often prevent the need for higher levels of care. These services are not only effective, they are cost-efficient and preventative. Yet despite growing demand, peer programs remain underfunded and vulnerable to staffing shortages. At the same time, systemic barriers continue to delay care for children and families. Families are spending critical time searching for in-network providers while programs manage payment delays, administrative requirements that divert attention away from service delivery. Behavioral health services must be carved out of Medicaid managed care so that public dollars are directed towards timely, appropriate care rather than processes that continue to restrict access. Finally, New York must expand investment in community-based youth mental health services. When families can access support early and within their communities, we reduce reliance on emergency rooms, hospitalizations, and more restrictive interventions. Early access leads to better outcomes for young people and strengthens families' ability to support their children at home. Families and young people across New York are not asking for extraordinary solutions. Rather, they are asking for a system that works when they reach out for help. Again, not months later. Thank you for your time, your leadership, and your continued commitment to the well-being of New York's children, youth, and families.
Thank you very much. Senator Fernandez.
Thank you so much. And Ms. Cole, I will give you my 3 minutes. Please
my
tell me about
gosh,
this.
thank
Cola.
you.
Tell me about this bill.
So, each year you come here and you fight like dogs to get us a COLA, TII, along with the governor. And together we do something rather extraordinary every year. I'm telling you that the money that you legislatively intend to get to providers sometimes doesn't get to them for years. And it's not just a broken contracting process. Not by any means It is a failure by insurers to pay the correct rate on time and in full, as is the law. So your legislative intent is in question. You mean for that money to get into our pockets. It doesn't, very often for a very long time. The other thing I want to tell you is that in 2023, the Attorney General's office did a Ghost Networks secret shopper survey and found that the directories that we all look at when we're looking for practitioners, 86% of those entries were incorrect. Either the practitioner didn't exist, didn't accept Medicaid, or whatever. This is unacceptable. This is out of control. We have $400 million at a minimum at risk that can be redirected and should be redirected into our systems of care immediately. Governor's budget was silent on this matter. We ask that you not be silent. We have bills. We have two same-as bills. Assemblywoman Simon and Senator Brooke are sponsoring our bills. Please, please include this in your one house. Thank you.
Thank you.
You're my hero.
All right. Well,
Assemblywoman Simon?
oh, okay.
Thank you. Thank you for the heads up, and thank you for your work on the Medicaid managed care. We did raise that issue earlier today.
I know.
Didn't get like quite the response we would have liked, but we're working on it. And we're going to have an evidence-based approach to this.
Okay.
So thank you
I'm cool with that.
for helping with that. So thank you. You know, one of the issues that I have like big issues this year, Medicaid managed care is one of them. The other is supportive housing, and the sort of dance that is done. You know, that we have, and certainly in the city of New York. So it's probably more protracted in some ways in the city of New York. The differences between the OMH housing, the SROs, and the ESHI housing, and why there are different rates when the OMH housing is actually providing more care in many cases. So it doesn't make sense to me. I don't know how we fix that. I'm curious what explanation was made. I know ESHI is newer, but like, so what? It doesn't make any sense to me that it's because it's newer. So maybe if you know anything about that, that would be helpful. And the other thing is, you know, I got some data earlier today from New York City, and it appears that there are some real differences between the type of housing and how long people have to wait for it. And State Department of Health housing is 9-month wait, and it's 6 months for OMH housing, and for Oasis housing is 3 months. So why?
We'd love to hear more about the wait list, but to answer your first question, the ESHI new units are developed at a much higher rate, and the older SRO units are funded much lower. And as we pointed out in our written testimony, a lot of those SROs are CRSROs. They're actually licensed and held to a higher standard. So that is the $89 million gap that we reference in our issue papers. And we're very appreciative that the budget includes $27 million towards that. But there's still a significant challenge here. We believe the rate should be equivalent to the new capacity, but we'd love to find out more about some of the wait lists you're describing. In the mental health system, there's something called a single point of access, and the counties work on helping to fill vacancies in the system with providers. So maybe that explains some of the numbers that you're seeing there, but we'd love to hear more on that.
Okay, thank you. Okay, I'm going to give up my 5 seconds. Sorry. There's no point in bothering anybody else.
Any other senators with questions? No? We'll hand it back to the Assembly.
Assemblymember Simplowinski?
All right, thank you, Chairman. And thanks, everybody, for being on the panel. I especially want to highlight Mr. Geiser and Mr. Slane, because both your organizations are extremely active in my district, and I've had great communications with both your organizations. So as somebody who I point out a lot in these hearings, I represent a very remote and rural part of the state. Thank you for being so active and providing services and to both of your populations in the southern tier, and especially the rural parts of the southern tier. And thank you for the relationship that I've been able to develop with both your organizations. And I appreciate also everybody pointing out with the COLA, it's not just 1 year, right? So if you don't get a full COLA 1 year, it's not like that magically goes away. It accumulates over time, right? So you may be falling less far behind than maybe we were under the previous administration, which is sort of what the current administration likes to point out. But you're still falling behind. You're just falling behind sort of slower, right? So it's not you're not keeping up. If anybody on the panel wants to give any sort of tangible real life implications of that continually falling behind, I would love to hear that and get that on the record.
Sure. I could talk a little bit about our providers. We survey them regularly. We have substantial turnover as well as vacancies, 30% on average. So our salaries aren't, we're competing with retail and service industries, and these jobs are tremendously more complex.
And that's what I've been raising all day, is the concern with now we're going to have the escalator in minimum wage, and how does that make that even more of a challenge?
So when we have to face rising insurance costs, positions may be kept vacant to make things work. That means higher caseloads. It means less capacity to provide services.
Thank you.
Yeah, I would just add, you're absolutely right. Look, if inflation is 2.7%, and we're, right now the governor has proposed 1.7%, at the end of the day, that amounts to a 1% setback that we are not keeping up even with inflation. The solution is not even just the full 2.7%. That's going to help keep us treading water, keep our heads above the water. But it's a comprehensive package. The affordability care force package that we've promoted has to be a part of this too. We have to start to address our direct care workforce affordability crisis that they have with housing, with child care, and with health care.
If anybody can do anything in 13 seconds, they're good. Otherwise, thank you very much, Chairman.
Assemblyman Santa Barbara.
Yes, thank you. Thank you all for your testimony. Thank you for your comments on the targeted increase, and that targeted piece I think is very important in there, and that mechanism to make sure that the funding flows to where it goes is critical, and that's something we have to make sure happens. Eric, I just wanted to, good to see you again. I feel like we were just here. I wanted to ask you about the self-direction funding. In my conversations with constituents, one of the problems they're having is, funding can't really be shifted too easily between where you want funding to go. So you could end up with a shortfall, and then funding that's left over in another category can't really be transferred too much. Are you hearing the same thing? And then the housing piece of it is also an issue, because if it's one or two people in a setting, that number starts to change. And if it's 3 and 4, it starts to get reduced even further. And that funding can't be moved anywhere. That's a whole separate category. So just want to hear your thoughts on that and what you're hearing from the people you represent.
Sure, and nice to see you as well. Admittedly, self-direction is a wonderful program. It's kind of become the wave of the future. But as you indicate, it is a complicated program. And funding is driven, there's a number of ADMs. It's kind of a fragmented program that makes up the full array of services within the self-direction program. I'm not familiar with the specific issue that you're mentioning here today, but I'd be happy to follow up with you and get the ARC New York's perspective on that particular issue.
Okay, great. Thank you for your comments on that. And then, of course, earlier today, I talked to the commissioner about the non-existent wait list that is refusing to, the agencies refuse to acknowledge. And I tried to get some answers on how long people are waiting for placements. And the answer I got was about 6 to 8 months, which does not seem right to me. And then we talked a little bit about an emergency list, which is a whole nother category. And I think we talked about this last year. We talk about it every year. But it's just about a minute left. Just love to hear your comments on what the reality is with this wait list.
Sure. And I don't want to enter the fray of, the semantic argument of what to call it.
Yeah.
There are people who have needs in New York State with IDD who are waiting for services. And it's complicated because they don't go in order. It depends on a lot of factors. It has to be the right fit, the right kind of house, the right kind of roommates and housemates. So there's a lot of pieces to it. So I think it's less important that we, debate this, what to call this thing, and more about how do we make it better.
Agreed.
Thank you. Assemblywoman Giglio.
Yes, thank you all for being here today. And New York State does have a prompt pay law for insurance companies where after 30 days of an electronic submission, the provider is supposed to be paid. After 45 days of mailing in, it's supposed to be paid. And in Texas, if the insurance companies don't pay, they get $1 million fine. So we create all these laws, but we don't implement them. And I see that as a big problem, especially when I'm talking to providers of mental health and addiction. And they can be placed into a rehabilitation home where after 2 weeks of being there, when they need 28 days or 30 days of mental health rehabilitation, and they're finally making progress, and after 2 weeks, the insurance company says, that's it, you're done. You have 12 hours to get out because we're not paying for another day. And providers, primary care doctors outside are not even able to prescribe them the drugs that they need. They have to go to a specific doctor in order to get those drugs. So I wanted you to talk a little bit about that, about the maybe primary care doctors being able to provide certain prescriptions for addiction, such as Vivitrol or Sublocade and things of that nature, that when somebody needs it, if they're incarcerated and they get out, or if they're in a wellness program and they get out and they have nowhere to go to access this medication. And I'm being told that the bigger companies that people pay a lot of money for the insurance companies, they're the worst in paying these claims. That Medicaid is pretty good about paying the claims, but these big insurance companies that they just don't pay the claims. So that number one. And number two, I couldn't agree with you more on the 2.7% COLA. And you shouldn't have to come back here every year and beg for the cost of living increases, because we heard all throughout the state of the state that inflation, affordable inflation. But meanwhile, you have people that are doing this tough work and they're unable to get a paycheck to afford housing. So any of you can just add on. You have 45 seconds left, but go ahead.
Prompt contracting is only as effective. Network adequacy is only as effective. Any of the things that we brag about in New York State, we have the toughest law here or there, only effective if you have surveillance, monitoring, and enforcement that is robust, that is not afraid, that addresses insurers, any business where it lives, which in this case is its pockets. But New York's enforcement, I'm told, has to go through a very long process due to the contract. The contract can be changed, but it isn't. At the end of the day, if you don't have surveillance, monitoring, and enforcement, no matter what you do, you have nothing.
Thank you.
Thank you. Assemblyman Palmisano.
Yes, thank you all for being here. My question really time is with Mr. Geiser. First, I want to say thank you to you, all your ARCs across the state, and all the employees who work for your organizations, especially our direct support professionals. They truly are doing God's work. They are on the front lines of improving the quality of care and quality of life of our most vulnerable citizens, individuals with intellectual and developmental disabilities. Earlier, when I was questioning the Commissioner Bear, and we've seen that wage gap between living wage and minimum wage for people working in nonprofits, and that gap's just going to continue to exacerbate with the indexing of minimum wage and not even able to get to the inflation rate and having to fight tooth and nail for that. What I asked the Commissioner, we know some people that don't make their living wage are on public benefits like HEAP, WIC, SNAP, other benefits. Seems like it'd be better to have more of a sustainable wage for them, versus being on the public benefit. And I'd asked her the question, would it be a good idea, or could we ever look at doing a cost study to see, look at these individuals who work in these fields as a profession, how much they're using, because they need these benefits. I mean, you talk about affordable housing, they need these benefits to survive. Would it be a good idea to do a cost study and say how much we're spending there, and then instead of spending for public benefits, pay them a living, sustainable wage so they can stay in that profession? And as I mentioned, working, doing God's work, I've talked to direct support professionals who want to stay there because they love their work, they love the impact they're making. Sometimes they're their only family member; they're like family. But they had to take that job at McDonald's or Burger King because they can make a lot more money. So would the cost study to kind of analyze this kind of help prove, we're paying this amount out in public benefits, wouldn't it be better to pay them a sustainable wage? Is that something that would be a good idea?
The short answer is absolutely, and I would be happy to discuss further study of this issue. What I can share with you is that our organization, along with our partners at NIDA, did look at direct care professional salaries and quality of life in 2024 with Miami of Ohio University. And what we discovered was that about half of our direct care workforce has housing insecurity. About half of our DSP workforce has food insecurity. And about 65% have one or have both. So it's, with 2.7%, there's a lot of things that we need to pay for with 2.7%. There's rising costs, there's insurance, there's groceries, heat. It can't all go towards salaries. So even with 2.7%, we're not going to be able to make the kind of progress we need to make to address folks needing public assistance.
Thank you. We got to do better. Thank you.
Things for us to follow up on. Thank you. And as they leave, we're going to be calling up our final panel. The Dwyer Coalition for Military Veterans and Families, Gavin Walters. Friends of Recovery New York, Dr. Angelia Smith-Wilson. Truth Farm, Alexis Plus. In Unity Alliance, Jahoon Kim. And New York State Association of CASAC Professionals, A. Maria Mendez. Are we just checking? Are we missing one or are we all here? Perhaps we're all here. Okay. All right. We will see who's not here. Why don't we start at my left? And why don't you introduce yourself? You have to press the green. It should light up green when you press it in just the right place. Ah, you got it.
There we go. Thank you. Hi, my name is Alexis Plus, and I'm the founder and executive director of Truth Farm, and I'm also the chair of the board of the New York State Harm Reduction Association. I lost my son in 2014, and since then I have been advocating for change in the way that we deliver care in New York State because, like many other directly impacted individuals, I know how hard it was to find help. And these are the systems that we heard about their services touted today. We as an organization have successfully advocated to maximize opioid settlement funds to come to New York State, and we're deeply concerned about the way that these funds are currently being distributed. We have documented these concerns in a report released yesterday. I'd be happy to share with anyone here if you haven't received it yet. That shows a lack of transparency, questionable procurement processes, and the fact that despite the efficacy of community-based services, these funds are not reaching community-based organizations, low-barrier services, or families that are directly impacted, where the needs most exist. In fact, over 85% of these funds have gone to organizations with budgets over $5 million who sit on millions and millions of dollars of cash reserves. These funds are intended to compel change, to innovate care, and to provide the types of services that have not been available. We should be using these funds to end the overdose crisis, not sustain it or the services that have been failing the most marginalized communities. Despite our advocacy, involvement, and incredible community-based services and attempts to reach these funds, we, like many other community-based organizations, have not been able to access opioid settlement funds because of unnecessary structural barriers by state agencies. I have faith that we have legislators here who will recognize the importance of these time-limited resources, will insist on accountability, find a way to support families, ensure actual transparency, and legislate real change so that we can use these funds to end the epidemic. Our path forward requires amendments to the legislation that guides opioid settlement funds to commit funding to community-based organization, and we need a complete audit of the opioid settlement funds spent to date. This is an opportunity for New York State to set its legacy in how these opioid settlement funds will be spent. Other states are using these funds to support families and the children left behind who have been completely ignored by New York State. Massachusetts and Pennsylvania are examples of states that are setting aside funds for families.
Thank you.
Thank you.
Good evening.
Good evening. It is evening. Committee Chairs Kruger and Pretlow and distinguished committee members. My name is Ji-Hoon Kim. I serve as President and CEO of In Unity Alliance. I'm also a social worker and peer professional by training and a person in long-term recovery for both a mental illness and a substance use disorder. It's an honor to be here today representing 150 mental health and substance use disorder community-based organizations. Beyond advocacy, we provide training and are the exclusive certifying body for the peer recovery credentialing in New York. Thank you, Senator Fernandez, for your continued support of this work. Many people do not realize that substance use disorders and many mental health conditions are preventable, and that recovery is not only possible, but expected when people receive timely intervention. Yet, unlike other health conditions, New Yorkers face months-long waits that let treatable illnesses escalate into serious harm, including homelessness and death, at an enormous and avoidable cost. These impacts are rippling through families and communities, hitting some much harder than others. In 2023, deaths for non-Hispanic Black men 55 and older were nearly triple the national average for that age group. Triple the national average for that age group. These are grandfathers, fathers, spouses, uncles, sons, and brothers. The death rates we see are only the tip of the iceberg. The primary drivers of care delays are structural. So why aren't we investing more in peers and clinicians, especially for those working with children and underserved communities? Why are New Yorkers seeking care and the clinicians providing that care forced to act as collection agencies, navigating insurance red tape, focused on cost-cutting over care? We are just shifting that cost. Why is it taking years to open new services, and why are these life-saving services underfunded? I'd like to offer some clearer practical solutions. However, I will note they don't even begin to meet the true need of the demand that is out there. First, we ask at a minimum for a 2.7% targeted inflationary increase, at a minimum, to be aligned with this year's CPIU. We also urge the legislature to carve out behavioral health services from Medicaid managed care, which has only added to barriers to care rather than improving coordination or reducing costs. And in addition, please protect access to care by ensuring sustainable funding for life-saving programs, such as OASIS's vocational and job placement services, OMH's assertive community treatment teams, and the Health Home program. These steps are especially urgent as federal policy changes threaten to add further strain, including more frequent Medicaid recertification and work requirements that may not account for people who shift in and out of disability exemption status. Our additional budget and legislative priorities can be found in my written testimony, and I appreciate the committee's time and consideration of these requests.
Hello, everyone. My name is Gavin Walters. I'm the Executive Director for the Dwyer Coalition for Military Veterans and Families. And for everyone that do know, the Joseph P. Dwyer Peer Support Program across New York State. Um, I'm speaking to you all because of so much of what the Dwyer programs do across New York State. 62 counties have the service, 62 programs are able to connect with veterans, their families, caregivers. But the service that they do is big, but it's not big enough because there's not enough funding. And I testified about 2, 3 years ago saying that there should be a 27.5 increase because of the rate of inflation over 10 years because the programs did not see such a growth. And also, there's programs that receive like $50,000 in one county, and another county might receive $192,000. But I could talk about the data that there's like 60,000 individuals that they encounter all year. And there's so much that we could speak about, but also I want to talk about the tribal nations that don't have the Dwyer program. There are 9 tribal nations recognized in New York State, and right now, over 6 of them is saying they support the Dwyer program within their nations. We know that suicide, mental health, and so much other stuff are in their nations. So that's one of the things that we're trying to advocate for and we're supporting. And also with the coalition, we're looking at how can we connect, how can we support, and how can we help each county and create a care program, Dwyer Care program within our program to help them, to help the individuals that really need it, and that's the caregivers. The caregivers that unfortunately are going to lose their jobs, are going to commit suicide, are going to just go through so much, as well as the children that's going to have their grades go down, that's going to go through many situations. So you can see the dynamic of how everybody's connected and that one person struggling. You know, we raise our hand to serve our country, but then when we come back, we're fighting just to say, hi, we're here. Or, yeah, we don't have housing because, you know, we got out of service because we have a dishonorable discharge. So the VA won't look at us, but where can we go? So much of what the Dwyer program is looking at is the service member that have rose their hand and said, hey, I need help. Because so much of them come back broken and just disrepair because they don't see the help. They look for the help, and unfortunately, as someone that have served in the military and that's 100% service connected and still go through to this day, the help is not always easy. But I'm telling you, the family members that's willing to sit next to us 2 o'clock in the morning when we're crying and just wondering why nobody's there, you know, those are the folks that really need the help. Thank you.
No worries. First you started on left to right and then no worries. Good evening, Chairpersons Kruger, Pretlow, and as well as distinguished members of the Senate and Assembly. I cannot think of any better time than Black History Month to discuss system inequities, especially health inequities. My name is Dr. Angelia Smith-Wilson, and I serve as the Executive Director of Friends of Recovery New York. Thank you for allowing For New York the opportunity to testify here today. Friends of Recovery New York is an independent 501(c) organization, New York's only statewide recovery community organization, representing thousands of individuals and families living in recovery from addiction and those who have lost loved ones to addiction. As New York considers the fiscal year 2026-2027 budget, it is critical to recognize the investments that are needed in recovery services and the workforce supports, which is not only life-saving, but is a strategic approach to strengthening communities, reducing costs, and supporting a productive, healthy workforce. Unfortunately, systematic threats are happening daily and sometimes appear online in the middle of the night. Friends of Recovery New York strongly supports a $2.5 million investment to implement the Recovery Ready Workplace RRW Act. This legislation establishes voluntary recovery-ready workplaces that prevent substance misuse, support employees in recovery, and promote inclusive, stigma-free workplace cultures. While the RRW Act passed both the Assembly and Senate, and thank you, It was ultimately vetoed by Governor Hochul due to concerns regarding fiscal costs. This funding request would enable statewide implementation, including the establishment of many grant programs to support recovery-ready advisors who will guide employers through certification and best practices. In closing, Friends of Recovery New York urges the legislature to take decisive action to strengthen New York's recovery infrastructure by investing $2.5 million and ensuring the full passage of the Recovery Ready Workplace Act, providing a 2.7 cost of a living adjustment for peer workers, and securing permanent sustainable funding for community-based recovery programs. New York can protect its most vulnerable individuals. It can reduce the stigma and build a stronger, healthier workforce. These evidence-based, fiscally responsible measures will save lives. They will improve workforce stability and create lasting economic and social benefits for communities across the state. Now is the time to act boldly to support recovery and empower individuals, families, and organizations at the heart of this work. Thank you.
Thank you so much. I was going to ask about your thoughts on the Recovery Ready Workplace bill, but you did answer it, so thank you so much. And I do agree that that $2 million should be something we can do of this billions-dollar budget. But overall, the work of recovery, I believe, is important to the entire spectrum of care when it comes to addiction services. Harm reduction we know is important, education and prevention we know is important, but recovery and long-term care is just as important. Is the state putting enough dollars towards helping recovery programs compared to the other parts of overall care here?
Well, we know that inequities exist. I mean, if you were to look at the OASIS overall budget and look at the percentages of those funds that go directly to support recovery support services, you would certainly see inequities that exist there. I do know that OASIS over the last few years have been trying to if not stabilize, but continue to increase in recovery support services. And to answer to your question earlier with regards to the opioid settlement funds and recovery services receives about 14% of those opioid settlement funds, up from 7.8% of previous years. So we are seeing some increase in the opioid settlement funds, but again, if you look at the overall budget in comparison to treatment and prevention, recovery support services remain the lowest.
Thank you. Mr. Gavin, you mentioned that your program is unattainable by our nations, our Native American nations. Is there a technical reason why, or is it a matter of money that we're not providing?
It's the money that's not there. In my proposal, there's a $600,000 proposal for the nations, and the proposal was actually sent to the nations last year, and all of them were able to review it. And the ones that weren't have agreed is because they were still talking. But I definitely wanted to get this out to you guys so you could see it, because the nations are absolutely in support of it.
And 600,000 would help all the nations?
Honestly, I'll say $1 million. Like, but yeah, if for the budget, we could say 600,000 for right now.
Thank you so much. That's all I have. Thank you.
So thank you all for your testimony. I know we've talked about where opioid settlement funds aren't going. And I guess my question is, where are they going? Like, you know, and from a budget point of view, it's like, we're going to do this, and we're going to, nope, it's hard to keep track of that. So I'm curious if you could say, you know, they're going here. We know now where you think they should be going. What's wrong with that?
The bulk of the funds are going to large system providers such as hospitals and enormous system, treatment system providers.
So high overhead.
Those organizations are also capable of billing for their services and sit on a large amount of cash reserves. They don't really need money to improve or increase the capacity of people that they serve. And that's part of the problem why we're not changing. An example of this is, as the commissioner mentioned today, they spent $450 million of opioid settlement funds. I'll mention that the dashboard currently only shows about $150 million spent, so we're seeing there's a big transparency gap there. But yet their own dashboard does not show an increase in treatment admissions. So all of those funds have been spent without increasing the number of people receiving treatment. Why? So, I think pumping money into big systems that are already failing people is not going to change anything here.
Okay, that's very helpful. Yes, Mr. Kim.
If I could just also add to that, I appreciate the question and I appreciate the response just now. I think it is also important to underscore that when you think about the larger continuum of care and the providers that are able to access opioid settlement funds, and the fact that there still are unmet needs throughout the state and quite frankly throughout the country, it does underscore historic underinvestment in the sector, right? I mean, we all know that this hearing, and all of your attention to this is very much appreciated. But we know that in the larger scheme of things, that behavioral health services are usually the issues and the services that get the change in budget negotiations, right? So I think overall, I do want to just underscore the larger frailty of the system that is serving and saving lives, and recognize that opioid settlement dollars alone cannot, fill the need that exists.
Okay, so it's really decades of underinvestment in the field.
Yes.
Yeah, okay, thank you. Anybody else want to argue with that?
Well, I would add that there's been a 70% increase in funding to these agencies since 2011. And again, we currently have 3 times the overdose fatality rates that we had in 2011. So we have continued to invest in these systems, but the systems are failing us.
Right. Okay. Thank you. I appreciate that.
Thank you, everyone, for being here. Thank you, Chair. Mr. Walters, I have a few questions for you.
Yes, ma'am.
Thank you for your service. As someone from a military family, I really appreciate what you've done, what you continue to do for your fellow veterans, so thank you. Like everything else in New York, I'm assuming the costs for the Dwyer program have gone up, and I'm wondering how it will affect you if you don't get the budget requests that you've asked for. And then connected to that, how are you doing with retaining your staff? And because I know that continuity of care is so important.
The Dwyer program has a high turnover rate with peers. I believe I just found out one peer left one program. So if you talk to every program in New York State, you're going to find out that it's a revolving door with the peers because 1, they can't afford the peers. 2, it's the peers that are already disabled doing the work. And then when they're trying to take care of themselves, no one else is replacing them because the younger veterans have to take care of their families. The younger veterans have to put food on their tables. So they're not even able to afford one person, where I could say with Orleans County, they have a $54,000 budget. And I know for a fact $54,000 does not cover one person in one county when you could say there's like 2,000 veterans in the county, and it will definitely impact the counties again every year. You're going to see that revolving issue of peers being burnt out, resources really just probably could get spent in a month or just a week, because the programs, they do the work based on the quality, not the quantity. They look at what's happening with the individual. It's social work 101. What is happening with the individual and seeing how you could get them to their necessary support system. If the family member is being impacted, and then the veteran is just drinking themselves silly, like who's helping the family member while the peer is helping the veteran? So the family member's already gone through something so it is bad.
Yeah, it would be a shame to see this program not succeed or not fall short on the funding, because it's so important that we support
We're
the
veterans, so we'll never give up on anybody. Yeah. We've worked. When I was in Ulster County, I was up until midnight helping someone that was suicidal There's a gentleman back here, Corey, who's an Army veteran. He's done work as well. So we will do the work no matter what. We will, no matter what somebody's going through, we will absolutely be there for them. 2 o'clock, 5 o'clock in the morning, we don't care, you know. But for us, mentally, it's gonna drain us and destroy us.
Thank you for what you're doing.
Thank you.
Assembly Member Ra.
Thank you. Mr. Walters, just that $600,000 and just in terms of the operations there, is that also part of the, the outreach, the trying to make sure veterans know where these counselors are and where these programs are when they need them?
Yes, actually, we have a $600,000 proposal for the coalition because we've built the infrastructure that actually connects all veterans across New York State. We are the first ones to design and build the Dwyer website that probably everybody went to, and that's us right here. We're actually developing an app that will connect everybody in New York State to resources in every county. If you visit the website, you actually can go through each county page and see each individual resource that's in the county. So if a veteran is actually suicidal, they could connect with the county crisis center. And then if the family member is going through something, they could connect with whatever resources within their counties. And also what we're doing too is we actually field phone calls and connect the individual's family members to county programs. So we've been doing so much work. It's just that we don't have the resources for the coalition itself. And then also in the proposal is the budget for the tribal nations, because we just threw an arbitrary number out there. Like I would say $1 million for every county to receive an increase in funds, and then $1 million for the tribal nations. But we're in New York State and we know we have to negotiate budgets. So I was like, let's just start low to see where that goes. So
Okay.
yeah.
Thank you for the work you do and all of you for your advocacy.
Assemblyman Steck.
There we go. I wanted to ask Ms. Plus what how would you describe the main differences between these large organizations and the local community organizations?
The most important thing is that the community-based organizations are providing community-level care that has very low barriers to access. So, for example, at our office, people can just walk in and receive services. There aren't long, complicated forms. We don't require insurance for people. If a family is in crisis, they can contact us. We will find them treatment. We'll drive the person to treatment. And so that's the difference between community-level care in a large system. Recently, we got called by the Rensselaer County Hotline telling us that they had a young woman who had secured a treatment bed from Rome, New York, and Binghamton, New York, who couldn't get there because the treatment provider wouldn't provide her a ride. I looked at the dashboard. That very treatment provider was provided $1.6 million in opioid settlement funds for a transportation initiative. Those organizations aren't going to answer a call on a Sunday like a community-based organization will, and that's the difference between community-level services and a big treatment provider.
But I'm trying to understand this a little better. Your organization does not actually provide treatment. You
That's
just
correct.
Okay. All right. You're like a facilitator.
Say again?
You're like a facilitator.
Right, we facilitate, and we're also a drop-in center. We provide harm reduction services, food, navigation to housing. Last month alone, we connected 22 people to treatment. The HOPE hotline mentioned earlier, if anybody tries to call that number and tries to secure treatment, you'll find out that it's not a very user-friendly system for families to navigate to get treatment. If they call a community-based provider like me or one of the Friends of Recovery community centers across New York State, they'll actually get connected to treatment. That's the difference between a community-based provider and a larger system.
And you had mentioned you provide harm reduction. When you refer to that, what are you referring to?
We provide syringes and other things that people need to stay safe and alive. In Broome County, we have an HIV outbreak, and so this is something that's, public health intervention and disease prevention. People who I view it as people who were not able to access treatment for years and years, who fell through the cracks, are now unhoused, struggling to survive, and they need something to keep them alive and disease-free. Harm reduction services are doing that until the point in time that they might be interested in treatment. As an example, at our organization, sometimes if we feed people enough, they might be interested in treatment, but when they're hungry and unhoused, it's hard for them to think about treatment.
Thank you. Assemblyman Brown?
Thank you, Chair. Thank you all for being here. I have a bunch of questions that I'm going to just kind of bounce around, but it seems to me some of the, going to the woman at the end, I'm sorry, I don't know your name. With the 2.5 million that you're looking for in additional funding, between the opioid settlement fund, between the MRTA money and the problem gambling money, couldn't there be kind of a reassessment and, reallocation of some of that money to get to what you need?
Yes, Dr. Angelia Smith-Wilson. I would say in terms of using a combination of all of those things, it could be resolved, or there could be an opening within the budget so that we don't have to continue to barter from other areas where the monies are also very much still needed. This investment could certainly come from the opioid settlement funds, the $35 million that was the interest. It could come from a combination of things. One of the things that we do discourage, though, is taking funds from other additional recovery support services, because when you think about a recovery-oriented system of care, all of these things are needed. Housing supports, supports regarding peer services, supports, wraparound services, all of these services are needed. So I would certainly refrain from wanting to take from one pot, but certainly it could, but I would refrain from doing that and say, let's look at the $35 million interest.
Thank you. Just moving on about with the respect to the Dwyer program. When I met with the commissioner of OASIS recently, she told me something startling, was that they're not really tracking OASIS, how much they're helping veterans. And I told her that I wanted to follow up with her, and I didn't get a chance to ask the question today. But have you identified just how many people that you're serving present with an alcohol or substance use problem?
No. The reporting that the program sent to Albany doesn't show those type of diagnoses or anything like that, because it's a confidential program.
Yeah.
But what we've done to go around that is also include OASIS on our meetings. Christopher, who's a veteran, we don't blame him because he's a Marine, but he is an individual that joins our meeting monthly, and he connects with all the Dwyer he tries to connect with all the Dwyer programs to actually introduce OASIS to them. So we've actually been bringing that conversation to many people.
Yeah, I'd love to follow up with you because it seems like a marriage that should happen. Thank you.
Okay, thank you. Yes, I have a few questions about the Dwyer Coalition. Mr. Walters, thank you for your service, first of all, and thank you for your work with the Dwyer program. Both of my counties, Schenectady and Montgomery County, have some wonderful programs that they do every year with the funds they receive. You mentioned in your testimony that there's some areas that don't receive funding, or they haven't requested it, or they're just not in place.
And that's the tribal nations. They haven't received any funds for the Dwyer program, and this one of the budget proposals that I'm asking for is for them to actually start having a Dwyer program within their nation. And all 62 counties do have funds for their programs.
Okay. Okay. And the increase, 27.5%, is what you're asking for.
Oh yeah.
Okay. All right. I just want to make sure that was clear. The programs I'm familiar with in my area, my assembly district, what are some of the other? I guess is the funding is. What can it be used for, and what do some of the other programs look like
They,
across
yeah,
the state?
absolutely. They're unique. Like every county does have their program being, they're administered by the needs of the county. So when I was the director for Ulster County, I saw that Ulster County needed resources in the southern tier of Ulster County because so much is in Kingston, the resources. So we spread it out, the resources. So we're able to go into different areas because we had a higher funding pot for our county. While other counties, if they're rural and they have one person administering their program, they might be part time and they won't be able to connect with a veteran that is unable to leave their home. So every program looks at the need of their county as well as depend on their funding. They're able to provide more resources as well as they're able to advocate and try to bring in volunteers, which volunteers is not a guaranteed thing because some of them don't want to spend about 10 hours with somebody if they're in crisis, have to go to the hospital, have to come back home and have to go to the store. So it's a logistical task just to get one person to the service. And that's why it's based on quality and not quantity.
And that determines. That's why the funding varies from county to county.
I believe because it's the census, because one county, I believe Ulster County is up to like 14,000 veterans, and I think New York State is about 500,000 veterans, but we say that those numbers don't mean anything because we service other than dishonorable discharge veterans. We service the Guard and Reserve members who are not quantified within the VA's definition for veteran. So that's a whole pot of individuals that's not even being seen, and the Dwyer programs are actually doing that work. So the census is showing numbers that we're touching when it's not being shown.
I see. Okay, thank you for your work with us.
Assemblyman Palmisano.
Yes, so first to all of you, thank you for your patience, for sticking it out to the end. And wanted to say that first. It's been a long day, so thank you. Thank you for what you do and the work you're doing in our communities and the people you're helping. But with my time, really, I want to kind of focus with you, Mr. Walters, if I can. First, thank you for your service. Thank you for what you do for your fellow veterans and their families. I mean, we have all heard the sad and tragic stories of more and more veteran suicide, the impacts of PTSD on our veterans and their families. And it's heartbreaking. And when we talk about the Dwyer program and how effective it is, and I wanted to kind of ask, I mean, I was trying to listen and see if we got, you mentioned your ask is like for a 27.5%. What would that bring the funding up for the program statewide? What would that be, if it approximately?
Well, it'll be about close to $10 million.
$10 million.
Across the board.
$10 million. We have a budget that's over $250 billion. And you're here asking for basically about $2 million.
Yeah.
And the thing that's kind of shocking to me is the veterans like yourself, the veterans you serve, have already paid for this time over and over again. And now that's just to bring it basically so you can really be sufficient and provide that service. Now, what would be, that's your ask to kind of be here in this budget. What would be your ask? I'm curious. What would be your ask to make this program transformational that would totally impact? So $10 million, about $10 million to bring it where you're asking, what would make it transformational? How much would that be approximately, ballpark?
About
statewide.
$70 million.
$70 million.
Yeah, and that's because the program is not 24 hours.
Exactly.
Veterans, the VA really talks about how great they are. I mean, a $1 billion company does not do as much work as we do because we're there 24/7. We do the work 2:00 in the morning when the VA urgent care is not open, because I've experienced that with many individuals that we try to get to the VA and we have to go someplace else because that person is suicidal because the VA is not open. So I'll say if we were 24/7 as well as have a peer line that the veterans could actually connect with, that will be transformational for so much individuals, so much people that unfortunately feel like they've been abandoned, isolated, alone, scared, upset, sad, and I could keep going down the list because I've lived it as well. I've lived it, the fact that I can say that I'm here because of the Dwyer program, and so much of us are here because we have a peer that reached out to us and said, hey, you matter today. Don't kill yourself today. You matter today. Your children love you, your wife love you, and your family loves you.
I mean, that's incredible. I mean, again, we're talking about a context of a $250 billion budget. You're asking for 70 million. Again, our veterans, yourself, have already paid for that over and over again. Thank you for your service.
Thank you.
Thank you. Assemblymember Semplowinski.
So I'll be quick, because Phil was sort of on the same page where I was going to go, and I want to talk about the Dwyer program. And one of the things I do appreciate about it
Close it out.
is being 62 counties, and so much often in my district, people got to drive to Buffalo, they got to drive to Rochester for services, and having people on the ground in all 62 counties could be life saving, because if you're in crisis and you don't want to be in a situation where you got to travel or do things. And I wanted to put some context. You mentioned earlier Orleans County, $54,000.
Yep.
That's a county of 40,000 people. So just to put in context, as Phil was saying, $10 million or $8 million, or you're going sort of from 8 to 10 is what your request is. In the context of our budget is a drop in the bucket. And in my opinion, the return on investment is huge. And the lives that are saved and the lives that are brightened is huge. And I also want to point out, I have a tribal nation in my district. I think your idea to include them this way we include our counties is 100% on point. And so the folks in my district, they came reaching out to me before I had even been sworn in as the assemblyman. I had already just been elected. They wanted me to know what the Dwyer program was doing, in this case in Cattaraugus County. And whenever I'm out and about, I'm running into folks from that program out in the community. So I would also posit that certainly there's a benefit to our veterans. I think certainly there's a benefit to our veteran, our military families and the children and the spouses of our veterans. But I think there's a benefit to the broader community. When we support our veterans, you're helping every member of the community. So there's not really a question there, but I just really like what you're doing, and I think we should give you more money.
Yes. Thank you.
That's
Thank
it.
you.
Have completed the questions. I'm just looking. Yes. All right. Then I want to thank the four of you for being our final panel tonight and educating us so much about your programs, and appreciate your coming. And I'm going to officially close this hearing. But fear not, you can sleep quickly, and you can come back here at 9:30 tomorrow morning for the Human Services hearing, which will be a quite extensive day for us all. So thank you very much for your participation.